Ross C. Brownson, a prominent public health expert, once said, and I quote, "The future of public health will belong to those who can turn data into decisions and ideas into action." A very good morning to the small yet enthusiastic gathering present here today. We here at Goa Medical College are truly honored to host the 6th IAPSM Young Leaders National Conclave 2025 in collaboration with the Indian Association of Preventive and Social Medicine. And on behalf of the organizing team of the Department of Community Medicine, I, Dr. Nadia Clare, take immense pleasure in welcoming all of you, dear delegates and resource faculty. We sincerely acknowledge the travel disruptions many of you faced due to flight cancellations. Your commitment in still attending this conference speaks volumes. The organizing team is grateful for your resilience and continued support to our conclave. We are truly disheartened for those who could not make it here physically. However, in line with our theme, digitalization, are present online. And after all the toil, we wish you a warm welcome to our beautiful state of sun, sand, and sea, Goa. The theme for the 6th YLNC 2025, Digitalization, Data and Decisions, Youth at the Forefront of Health Tech, was chosen with the aim to inspire young leaders to harness digital innovation, strengthen data-driven decisions, and transform the future of public health, hence setting a tone for the conclave that celebrates youth leadership and embraces digital evolution, transforming modern healthcare. We here at Goa Medical College assure you that we will make this conclave a memorable one for all of you, and right at the outset, ask pardon for any shortcomings along the way. We now begin this academic extravaganza with the Young Leaders Ambassador Award 2025, given to that young leader who has been dedicated to health, has demonstrated commitment, innovation, and impact in their public health effort. And to start the first session of the day, I call on stage Dr. Jagdish Kakodkar, Professor and Head, Department of Community Medicine, and the organizing chairman, YLNC 2025, to welcome our chairpersons onto the dais. Our first chairperson for this session, Dr. Manish Kumar Singh, Professor, Department of Community Medicine, Dr. Ram Manohar Lohia, Institute of Medical Sciences, Lucknow, and the Honorable Secretary General of IAPSM. Our second chairperson, Dr. Hemangini Kesha, Associate Professor, Department of Community Medicine, and the Organizing Secretary, YLNC 2025. I also request Dr. Jagdish to welcome Dr. Meenal Thakre, Additional Professor, Department of Community and Family Medicine, AIIMS Bilaspur, and the lead of the Young Leaders Ambassador Award 2025. I also request the SR coordinators, Dr. Ananda Selva Das and Dr. Tejbir Singh, to kindly take the dais. I now request our chairpersons to begin the session.
Ladies and gentlemen, तुमकां सगल्यांक आमचो माय मोगाचो येवकार. That translates as a warm, heartfelt welcome to each of you in the audience of the 6th Young Leaders National Conclave 2025. Thank you for being here in spite of all odds, courtesy the flight issues. To our esteemed IAPSM office bearers, faculty and delegates who have joined us online, we miss your presence in person. Do stay connected throughout the 2 days proceedings and be part of our conclave. As the organizing secretary, as I kickstart the 6th YLNC along with the Honorable Secretary General of IAPSM, Dr. Manish Singh Ji, what better event than the Young Leaders Ambassador that is aimed at identifying, recognizing, and encouraging the young public health professionals who make a difference and have made a mark in the field of public health. To acquaint us to the conduct of YLA 2025, I request Dr. Manish Ji to invite the YLA coordinator and introduce her to us.
Good morning, everyone, and good morning to all those who have joined us online. As Dr. Hemangini has said, it's been quite difficult last 2 days, and many of us who would have loved to be here actually had to join online. So this Young Leaders Conclave is a unique platform that brings together all the young postgraduates, senior residents, and at the same time, some of the established leaders in the field of public health, as I can see some sitting over here. So that's a unique platform where you can interact, where you can bring forward your ideas and develop a roadmap how you're going to build upon it in the coming years. So I wish all the organizers a grand success, and I hope all of you will enjoy all the beautifully, meticulously designed sessions. To start with, I would like to introduce the coordinator for this particular event, Dr. Meenal M. Thakre. She is additional professor, Department of Community and Family Medicine at AIIMS Bilaspur. And she has been honored with many prestigious awards and professional experience of 17 years with 37 research publications. So, Dr. Meenal, it's over to you. Please start the proceedings.
This is pointed. Okay. Okay, thank you. So, thank you, organizers, the Secretary General, Dr. Manish, the Organizing Secretary, Dr. Hemangini. So, without further ado, let us start with this formal session. In the 6th IAPSM Young Leaders National Conclave 2025, Digitalization, Data and Decisions, Youth at the Forefront of Health Tech. The Young Leaders Ambassadors 2025, this concept was started in the last Young Leaders National Conclave, which was conducted in AIIMS New Delhi. Kiran ma'am is also there. So the concept was empowering the young talent, fueling the next generation, and recognizing the impact. So Young Leaders Ambassador is an innovative initiative to engage the dynamic and enthusiastic young public health professionals from across the country. This platform celebrates their achievements and inspire others to strive for excellence. The primary goal is to identify and honor the young public health professionals who have made significant, impactful contributions in specific areas of public health. Their accomplishments will be showcased to a wider audience of public health leaders. By celebrating the work of these young trailblazers, the initiative aims to empower and motivate other young professionals in the field. Their stories will serve as inspiration to keep pushing the boundaries of public health. So this is the coordinating team, Dr. Harshil Ramesh Salve from Center for Community Medicine, AIIMS New Delhi, then myself, Dr. Ananda Selva Das, Senior Resident from AIIMS New Delhi, Dr. Tejbir Singh, Senior Resident. They are there Dr. Ananda and Dr. Deshbir, can you just wave off towards the audience? So, and Dr. Malavika Krishnan, who has been in the coordinating person and I must thank her that she has been so cordial and there was such a smooth coordination on part of Dr. Malavika Krishnan. So there were 4 domains. The the applicants were asked to apply if they have significant work in any of these domains, or they may have work in multiple domains. So first was entrepreneurship, to recognize and support the young public health professionals who have demonstrated innovation and leadership in the entrepreneurial ventures related to public health. Community service, honor the young public health professionals who have made significant contributions to community service and public health advocacy. The applicants are supposed to be less than 40 years age. This goes to the rest of the young IPSM members who are thinking of or working on lines with the areas and are eligible to apply in the next conclave. Environment, to identify and celebrate the young public health professionals who have contributed to environmental health, any green initiative, and sustainability. Digitalization and health technology was the domain which was added to it this year itself, to highlight the young leaders harnessing the power of digital tools and technology to revolutionize public health, improving access, quality, and efficiency in healthcare delivery. So we received multiple applications, and I am really, I have all admiration towards all applicants. So we must applaud each one of them for participating. So after a careful evaluation and based on the given criteria, we have selected 2 winners. So the first prize winner of Young Leader Ambassador 2025 is Dr. Bhushan Dattatreya Kamble. Dr. Bhushan is Associate Professor, AIIMS Bibinagar. He is not there because of these issues, so we are expecting him to join us tomorrow. So let us see briefly what is his work. Mobile Medical Unit, the Arogya Ratham, outreach for equitable rural health. The aim was to deliver promotive, preventive, and curative healthcare to vulnerable and hard-to-reach tribal and rural populations of Yadadri, Bhuvanagiri district of Telangana. It was launched in 7th April 2022. The outcome was 394 health camps, 17,411 beneficiaries served, 1170 hypertension, diabetes mellitus patients received regular medications and monitoring, and more than 80% disease control among hypertension and diabetic patients. The second is drone-enabled sputum and medicine transport. To evaluate the feasibility of drone use in the NTEP in rural and hilly areas of Telangana, its impact on the diagnostic turnaround time, patient or diagnostic delays, and out-of-pocket expenditure for TB sputum transport. The outcome is median diagnostic turnaround time reduced from 15 days to 5 days, and 67% reduction in delay. Next day diagnostic results 1.5% to 76%, 92% fall in delay more than 2 days, and mean out-of-pocket expenditure from INR 9451 to INR 91 only. So we must applaud for Dr. Bhushan's work. So he is the first winner for the Young Leader Ambassador 2025. So, and again, I'm pleased to announce the second winner, Dr. Lima Limla Jameer. So she is Associate Professor, Department of Community and Family Medicine in AIIMS Guwahati. I think she is there. Dr. Lima, can you please come on the stage? So let us see work of Dr. Lima Limla. Integration of screening and management of mental and substance use disorders with other non-communicable diseases, ICMR MINDS. Aim was to implement the ICMR MINDS cadre-specific clinical decision support app and a electronic data capture based monitoring system to enable the data-driven tracking of NCD and MSUD services for improved program performance and scale-up in Assam. The outcome was 1395 NCD patients screened using the ICMR
Dr.
Minds.
Minal, I think since the presenter is here, it's better she presents her work.
Can you briefly just take a minute and explain what was done? Yeah.
Thank you so much. I deeply appreciate the appreciation. We are working in Assam, which is heavily populated and most populous state in the northeast. And through this initiative of screening NCT patients for mental and substance use disorders, we have taken the initiative of first approaching the community, training ASHA, CHOs, MOs, psychiatrists, like all levels of the healthcare system, and integrating it with the ICMR developed ICMR Minds app. This is a fully implementation research study because we are developing several iterations through the formative phase and going through the different models. Through this, we've been able to enter patient health records, about 1,000 plus, and several healthcare workers have been trained as well. Understanding the challenges, difficulties in digital health literacy, we have addressed those issues as well, and also destigmatizing mental health and substance use. We have been able to, improve the outcomes, improve screening and referral and management as well through all the levels of the healthcare system. So in short, this is about the current work that we are doing. We are also doing the National Mental Health Survey, which is fully digitalized. We are doing this in Assam and Nagaland, very difficult terrains in Nagaland especially, but through these initiatives, we are building capacity in the local regions. People are coming to know that we don't need paper-based forms, especially when it is remote. Digital health technology really helps. So in short, this is what I wanted to share. Thank you so much.
Thank you, Dr. Lima. So with this, I thank everyone for joining the session. I thank the organizers and chairpersons. Thank you.
So thank you so much to both the winners of this competition and all the participants. I hope there would be a lot of good work coming up. So I would request Dr. Minal to kindly make a compendium or something which includes everybody's, whoever has applied, their work should be highlighted in that. And congratulations to Dr. Lima and the other winner of this Young Leader Ambassador for highlighting the work that you have been doing, and I hope it encourages the youngsters also to take some initiatives. And I would request both the winners to please take along other members also, other colleges, involve other colleges other than your own college, so that there is some capacity building happening in other colleges also. We are committed to capacity building of all community medicine students, PGs, across all medical colleges of India. So in your region, try to include others as well, so that they also join in and they can learn from you how digital technology can be made use for the benefit of the society. But ultimately, we are going to serve the society, the purposes, and IIPSM should be the brand name that we work for the society. Thank you.
Thank you, Dr. Manish. Yes, idea of compendium is taken, well taken, and we will try. We must publicize the work, and the work of other candidates was also should be appreciated and publicized. Thank you so much. The formal felicitation of the winners will be done during the valedictory.
Yeah, sir is requested for a group photo with the team, so and the winners. Please do come on stage.
I request Dr. Jagdish Kakodkar and Dr. Kiran Goswami to present our chairpersons and the speaker, Dr. Meenal Thakre, with certificates. I also call on stage Dr. Bhavesh Modi to present a certificate to our chairpersons. Thank you, dear dignitaries. The next session is on Adolescent Health Unlocked, from systems to communities, navigating healthcare, nutrition, research, challenges, and innovative models. I request Dr. Malvika to welcome our chairpersons and speakers for this session. The chairpersons are Dr. Bhavesh Modi, Director and Scientist G, ICMR, National Institute of Occupational Health, and Dr. Kiran Goswami, Professor and Head, AIIMS, New Delhi. I also request Dr. Malvika to welcome the panelists for this session, Dr. Aarti Gupta Reddy, Associate Professor, Community Medicine, AIIMS, Mangalagiri, Dr. Madhur Verma, Associate Professor, All India AIIMS, Bathinda, and Dr. Ankita Kankaria, Assistant Professor, Department of Community Medicine and School of Public Health, PGI, Chandigarh. Mrs. Lakshmi Durga Chava, Senior Consultant, Health and Nutrition, Raitu Saddikara Samstha, Department of Agriculture, Government of Andhra Pradesh. I request our panelists to kindly take the dais. Dr. Madhur Verma cannot be here physically. However, he will join us online. I kindly request our chairpersons to start this session.
Good morning, everyone. We start the morning with the oration from our speakers. Most of them I know already, and they have been my students, so I feel very happy to introduce them. Dr. Aarti Gupta, she did MD from AIIMS, Delhi, and she is Assistant Dean Research now at AIIMS, Mangalagiri. She has a fellowship and membership of the associations in the subject. She has been awarded 11 gold medals and 23 certificates of merit for academics. Professionally, She has been involved in funded research projects of over 2 crores, and she is author of a book which is titled Community Medicine Practical Workbook by CBS Publishers. Her areas of expertise include adolescent health, of course, and nutrition and public health policy. She has over 60 research publications. So welcome, Dr. Aarti. I'll request Dr. Modi to introduce the next speaker.
So are we like one by one we have to introduce or? Okay. Dr. Madhur Verma is online. He is MD Community Medicine from PGIMS Rohtak, currently Associate Professor at AIMS Batinda, Punjab. He is also recipient of Fellowship of IAPSM, IPHA, EFI, RSSDI. More than 13 years of professional experience, 171 plus PubMed index publications. Area of expertise include community-based NCD prevention, behavior risk factors, and digital health. And I am really impressed by one thing which he has written, awards, still trying, with 171 plus publications. So welcome, Dr. Madhur Verma.
Okay. So we hope you'll get it in near future, of course. Then we introduce Dr. Ankita Kankaria, who is again has been my student. She has done MD from AIMS Delhi. She has awards scheme for promotion of academic and research from UK and a certificate of higher education in diabetic retinopathy screening by again NHS Foundation Trust. She has a professional experience of over 11 years and she has worked at different places including PGIMR where she is currently also located and Bhatinda, AIMS Bhatinda. Then her areas of expertise are implementation research, non-communicable diseases, reproductive health, health system, health informatics. She has over 33 research publications. Welcome, Dr. Ankita.
Thank you, ma'am. Our last speaker is Dr. Lakshmi Durga Chava. She is MSc Food and Nutrition, MPH and BAM. She is working as Senior Consultant for Health and Nutrition with Ritu Sadikara Samstha, Department of Agriculture, Government of Andhra Pradesh. She is member of Core Team Social Empowerment Mission, Government of Andhra Pradesh. Nutrition advisor for School Midday Program, Department of School Education. She has also worked as consultant in World Bank, FAO, IFAD, Government of AP. Area of expertise includes public health, nutrition, nutrition-sensitive agriculture, community-driven approaches, and maternal child health. She has 6 publications to her credit. Welcome, Lakshmi Durgaji.
Okay, so we request Dr. Aarti now to present her presentation.
A very good morning to all the resource persons and delegates present today for the session. Before we start, a very sincere thanks to the organizing committee for selecting our plenary session in the main auditorium. For new generation speakers like us, it's a very big opportunity. And I also thank chairpersons for introducing the panelists and all the panel members, those who we can team up to bring something good and something interesting for you, where you can also find the opportunities to collaborate and work or learn from us. With this, we'll just start. So we all know adolescence is a special phase of life, and usually 10 to 19 years of age is being given by WHO. However, different government portals and different government health programs, some may say 10 to 18 years, so it's different for different, and ICMR research policies of ethics guidelines say 10 to 18 years is children. So on an overall, we consider like 10 to 19 years with a reference for World Health Organization. And it's a special time because it's changes in the physiology of the body, it's physical changes in the body, it's mental changes, there are societal changes. So it's very different phase of life in altogether, where there will be actually learned, they will be taught, they will be motivated, they will be going up into a good adulthood. So it is very, very critical to address adolescents. Now coming to our subject, we have been, the subject has been struggling for identity on various professional forums. And we all know in clinical structure, as per the guidelines, pediatrics caters less than 14 years and general medicine caters more than 18 years. So when such are the policy issues, then often 14 to 18 years adolescents are struggling in big hospitals, of course, where the registration decks often get confused where to send these. Either they will be gone to pediatrics or they will be gone to general medicine, which the guidelines are not clear and they are being just twisted from here to there. So in this case, we thought, like, because in new aims, the subject came up as community and family medicine, which was having a very important role in providing clinical services also. So we thought this was one of the area which is not being catered by either of the specialties, and our subject can take a lead on this, and which is very strongly recommended with all the audience present today, that we all can work together for a new forefront for the subject. So the ministry has come up with the guidelines for adolescent-friendly health service resource centers. And these guidelines are very clear what are their objectives and what is their requirement, logistics. They are very clear in the requirements for saying it is a AFHCs. It is available on the government portals. It's all easily available in the Google also. If you file difficulty, we can share the resource materials. So today I am presenting you one of our work in adolescent health in the state of Andhra Pradesh through State Adolescent Health Resource Center. The primary objectives of this center was and is to provide clinical services to the adolescents, because AIIMS Mangalgiri is a tertiary care hospital as an institute of national importance. So the institute has its own mandate of clinical services. So that is one of the primary objective of the center. Keeping in our subject, because we work more in preventive medicine, so health and well-being is our mandate to take through to the center. Education, protection, and trainings and research, of course, is one of the main included in any work. This center, we are talking about convergence in public health. If we stand alone and try to work in public health, it may succeed to a level, but bringing it to policy changes, it may not be very successful. Because for policy changes, we all have to work together, and all partners have to consider each other at equal tables. So the center is being supported by Rashtriya Kishore Swasth Karyakram, National Health Mission, Government of Andhra Pradesh. It is being a lead center for APSCRT trainings, for Samagra Shiksha Department of Education trainings, for AP series, Social Welfare Schools trainings, Balika Vidyalayas. So we are being integrated with all the sectors which are being which are working in their own domains for adolescent health, but they are not integrated with each other. This center provides a key platform for all the government agencies and, of course, NGO partners to work together in coherence and customized needs. We are also working closely for HIV-positive adolescents living in the state of Andhra Pradesh through APSACs. This is being funded by UNICEF. Coming to the healthcare services, which as a community medicine department, we could have provided to these patients, to these adolescents, those who are coming to All India Institute of Medical Sciences, Mangalgiri, Andhra Pradesh, is first most important is patient counseling, because this is the time the adolescents will come with lot of questions where they may not have the right answers, or may have their answers through various internet forums, but they want to reassure it by various counselors or doctors. The other is providing them to the telemedicine services. So there are many adolescents, those who may not come to tertiary care hospitals due to X number of reasons. So telemedicine services is also very key important. So eSanjeevani is the Government of India platform through which the telemedicine services are given, and the center is a hub spoke for that. Apart from that, some adolescents may even don't have internet or the app access for eSanjeevani, for which special telecounseling services are being provided 24/7 hours. The center provides services for growth monitoring, then vaccination, including both DT and HPV vaccination. Referral is one of the most important work of the center. When we talk about the clinical services, the center plays a key role in building networking with super specialties, because in government institutes and in institutes like AIIMS, the rate of super specialty services are really low. The surgeries in AIIMS Mangalgiri, we cannot charge more than 5,000 rupees in INR, whereas such surgeries outside these adolescents may pay lakhs and lakhs of rupees. So we play a critical role in building bridges among super specialties for connecting adolescents to save their money, which can be used for some better growth or better use for the adolescent. This is our summary status for clinical services for last 3-4 years, where we have seen nearly 10,000 adolescents we have consulted, and most of them will come for health checkup, or they may need some like blood group testing for some forms. These are the most common presentations. But as we know, the burden of NCDs are increasing, so it will be very interesting to know that this adolescent have a good chunk of 10 to 19 years having endocrine disorders, which are being identified by our centers. They are also having a lot of gastritis and gastrointestinal issues, which have been identified. Also, nearly 25% and so are also having different problems of malnutrition, facing the dual burden, maybe obesity or maybe thinness. So this is a summary for the second most important role which we play as subject experts is training for various cadres, for various organizations in the state of AP for various health topics for adolescent. So we have till now trained nearly over 30,000 population for CHOs, that is community health officers, plus medical officers for and ANMs in Andhra Pradesh on various health-related topics like nutrition, menstrual hygiene, or HIV/AIDS, or STIs. Whatever, this training topics comes as a customized needs from the government of Andhra Pradesh, and they are tailor-made, standardized resource materials have been generated, designed, which is bilingual, which is very user-friendly, which is very attractive to be used, and has been kept in many libraries in the schools across the state of Andhra Pradesh. We also have been conducting many physical trainings, TOT trainings for the AP-SCRT, for Sakhi, which is under Department of Women and Child Development, Anganwadi workers, and so on. So we are been actively doing a lot of training works and there. We have also been preparing as technical experts many e-modules, as now it is digitalization world. So which, there are a lot of small videos with associated quiz, certificates, and so on have been prepared by the center. So this is our coverage for phase 1 of trainings, which was in 2022. And this is the coverage for the phase 2 of trainings. And this is for now, we are in process of doing it. This is Sakhi, which is under WCD trainings, which have been going on. There are various modules, as I told. There are various monitoring cascades, standardized contents, both English and Telugu, which can be used by anybody across the country. And all these content is original, and there is no copyright infringement in any of the content. So the center plays a very, very critical role in convergence, without which we could not have been progressed or succeeded. We are being strongly working with WCD, so we had a new Sakhi Corner, which is being situated at Vijayanagaram district. And I'll just take you to the glimpse of the Sakhi Corner, where the Sakhis or the adolescents come there, and they can directly get teleconsultation through our center. We have been working in the midday meal scheme and the Department of School as for standardization of midday meals for adolescent. Then we are also a part of national pool of RKSK division for trainings for Ministry of Health and Family Welfare. We are also having partnerships with the Department of Education, which I'll just take you through, and Kishori Vikasam program, which is again under WCD. So you'll see there are a lot of various sectors in the government of India, and especially what we have worked with government of AP, which are working in discrete fashions in the adolescent health. So we play a critical role in convergence with all the partners. So this is a Sakhi Corner, this is situated in district Vijayanagaram, from where in adolescent, if you can see the mid photos are of AIIMS Mangalgiri, and the down photos are of the left, and the right photos are for the Sakhi Corners. Our work is being displayed. Now we have worked so much, but that has to go to the user end also. So the best way for the user end is department official websites. So our work is being projected at school health program.
I think, Dr. Aarti, there are 3 more speakers, so please try to summarize it.
Yeah. So this is from RKSK. This is the website of the school health program, where our works have been displayed and can be easily accessed. These are our other stakeholders. The third part of as a subject is, for us, is outreach, which is very, very critically important. And we have been covering a school health registry of 78 schools covering around 9,000 adolescents. So this is those adolescents, those we appreciate in the field. We have called them to AIIMS Mangalgiri under Nai Soch program. And this is our former director, Professor Mukesh Tripathi, who is honoring the adolescent, a way to connect that they belongs to us. This is our work being projected. Now, advocacy is another very important. After we have done a lot of work, we have to come with policy changes. This is our work being showcased in the Global Thematic Report for HIV, and at G20 Summit, at World Health Summit, and so on. We have been conducted many youth consultations across the country for knowing and addressing their challenges and trying to sort them out. Of course, research, I told, is an integral part. So all the data sets are being managed, and it has been tried to be published to get it. Recently, at the ministry portal, we have been at the 2nd number in the country for providing adolescent health services. This is our key milestones of last 3.5 years. This is our goal, adolescent AIIMS Andhra Pradesh. Thank you.
Okay, thank you, Dr. Aarti. I would request other speakers to please stick to time and try to finish it in 6 to 7 minutes each. Thank you. Sequence में तो उनका था. Do we have Dr. Madhur online? So you can
yes.
put him on. Okay, so Dr. Madhur is going to present now.
Is my screen visible to all? Is my screen visible to all? Good morning.
Please change the screen. Dr. Madhu's presentation, please. If it Dr. Madhur, I think we'll wait for your presentation. We can go to the next presentation meanwhile. You will have to wait for some time due to technical problems. So Dr. Ankita Kankaria now.
Okay, till the slides are setting up, good morning everyone, and I would like to thank all the organizers. Thank you so much for a warm welcome and a smooth coordination in these scenarios. Respected chairperson, distinguished speakers, my seniors and my young leaders or future leaders. So the topic was research gaps and challenges in adolescent reproductive health. Is there a slide changer? Okay. So as we all know, and I think the youth can connect it well because you have just passed your adolescent, or maybe you have some relatives or maybe your siblings in adolescence. So you have dual responsibilities, both in your profession and in your personal life, to work on these areas. So we all know what good sexual reproductive health implies to. It aims to have a satisfying and safe sex life, capability of reproducing, freedom to decide when and how often. And adolescents do constitute a substantial proportion of our population, and you can see the journey. Right from 2000 to 2023, we have different programs, different initiatives, but despite all these, you can see the indicators. So you can see that, yeah, we have early adolescent marriages. They do get pregnant in their adolescence, and yes, you can see the figures which I've highlighted in red. They show that there is an opportunity to work on these areas. So the good thing is, yes, we are registering them at early stage, and they are getting institutionally delivered. But if you see, the trend is also improving over a period. But still, you can see the red highlighted areas, which includes the knowledge about their current modern contraceptives and the violence. So all these areas, and these are all available in the literature. So there is a lot of scope, as Dr. Aarti has mentioned, about different areas where we can work and we can deliver. So as we all know, there are issues. The coverage, 15% about sex education, and just ask yourself when you were in school, how many of you were had any session by any counselor in your schools? I had none, but my daughter has. So now I can see, yes, there is a progress, but we can be part of it, as Dr. Aarti has given the successful model at their institute. So we can all learn from that. And there are different reasons. Orthodox societies, still in my families, we cannot talk about these issues, especially when we sit with our grandparents. So they have different, their own beliefs. And as she already said, the informants. So there are no trained informants. The informants are peers who themselves are not trained. And considering the era, though the theme is digitalization, but we need to have the evidence-based information, which is correct. So there is misinfodemic also. And we have the curriculum definitely needs to be transformed. So there is a lot of scope to work on right-based approach. And the menstruation is in focus since many years, but still there is period poverty. You can see, especially when we talk about rural areas. So yes, there are celebrities and there are influencers which have their photographs uploaded, but when it comes to the implementation, there are a lot of gaps. So even the rural population, first is we make a product. We make reusable products, but the thing is, do we actually know what are their demands? Do we know actually what they need? So we do not talk, we just enforce. So they should be the decision makers, and it should be a shared decision. Early marriage, as already covered, and there is, because of early marriage, there is adolescent pregnancy, and then there are different consequences both for mother and child. So let me talk about the program challenges. Something has already been said by my previous speakers, but yes, as we have youth, we have policy makers also in this audience. So now, as a team, we can work, we can develop an advocacy, and we can prioritize adolescents. There were some strategies, as we all know. There was our strategy, but it had some gaps. Poor program planning, there is gaps in resource deployment, and integration into the health system. So as we were having session on implementation research yesterday, so the main thing is strategies exist, solutions exist, guidelines are made, guidelines are beautifully designed, but when it comes to ground implementation, there are definitely different challenges, both at the recipient end and at the provider end. So we need to have stakeholders. All the stakeholders should be together when we work on these guidelines and when we implement them. So there was no involvement of the adolescents, as adolescents were not involved when we were designing those strategies. And definitely there is a cultural resistance. So to overcome these gaps, RKSK was designed. And again, there were some reviews already available. And when we all see, you all must be going to your different rural and urban health centers. And let me ask you, do you have dedicated AFHS, adolescent-friendly health services? Do you have a dedicated corner like AIIMS Mangalgiri has? Can you raise your hands in your respective centers? No, we don't. Some of you might have, but broadly it is absent. So, poor youth community engagement focuses still on nutritional supplementation rather than on contraception. How many of you talk about contraception in your peer groups? Let me ask you this. We are not comfortable yet. So if we are not comfortable, how can we advocate that there will be a peer educator in the community? And as with all the national program, there is rigid fund flow, there is supply chain issue, shortage of trained staff. So we can have those models where we can train them. And definitely the quality of training will come later. First, let us develop a tailored training module. Now, the program challenges alone are not responsible for poor adolescent health. There are some societal and demand side challenges, so there is still stigma. I have my daughter who is entering into adolescent. Now, I am worried I have to talk about contraception. I have to talk about menstruation. So if I am worried, I am not confident, so how can you become the advocate? So let us train ourselves first. Okay, so there is taboo to discuss about sexual reproductive health, pregnancy, and conception-related information. And yes, girls are still now, there is a trend again that you should get married early because then there will be infertility issue. Yes, it is right to some extent, but I think they should have informed choice about it. And where are the early adolescents? 10 to 14, no one considers. Male adolescent, neglected more. What about the LGBTQs? What about the population who are living in slums? And what about the adolescent with disabilities? Already adolescence has a lot of physical, mental issues. And if some adolescent has some disability, it becomes more important and more critical for her or him. And as we all know, there is low awareness about contraception. So to all of you, these are some of the important research gaps. So you might be working on your thesis, on your research proposals. You can work on these areas. Lack of representation of male adolescent, early adolescents, vulnerable migrants, which include slum residents, tribal youth, adolescent living with HIV, LGBTQ, and yesterday we had some group presentation. They wanted to improve the HPV screening uptake among school adolescents. Then we asked, what about school dropouts? That is not in our focus. So let us bring them into the main system. And adolescent-related data, if I ask you, there are only few surveys. So as they are developing their data repository, we all can develop at our own respective centers. NFHS is there, and there are some few surveys like Udaya, but there should be independent surveys. And we should have some longitudinal database of adolescents, because they are critical periods. If we follow them now, we can have more reliable data on the health outcomes. You have heard about any digital interventions, so there are very few. And you are youth as well as tax savvy. So you can work on this area again. So the way forward is stakeholder mapping and engagement, but not only include policymakers, include parents, include teachers, and include adolescents. So tailored multi-stakeholder SRH education, which should be context-specific. What works in Telangana or Andhra Pradesh will not work in Punjab, okay? So you should have context in your mind, and it should be implemented. And peer educators, so there are some successful models. What Dr. Aarti has presented, let us go to the website and see what can be adapted in our respective settings. And there should be due focus on right to seek abortion. We should not be afraid. There should be someone whom we can connect in a friendly manner, okay? And there should be clarity on POSCO rights also. So, coming to research, yes, we all need more research, mixed method research, where we need to evaluate the existing programs. We need to understand what is the current pathway of care for adolescents, because we do not have one, okay, about the quality, about the equity, and the intervention research should have a robust design, okay? And participatory action research will be an important area where we can involve adolescents as a researcher in our own research designs and economic and modeling studies.
Thank you,
With
Dr.
that, thank you so much. So let's not whisper, but rather brazenly sensitize our adolescents and ourselves. Thank you.
Thank you, Dr. Aarti. Over to Dr. Madhur Verma.
Sir.
Yeah. Yeah, you are visible. Share your slides.
So, yes, the slides are visible, sir. Can you hear me?
Yes, you are audible. Please start.
So, good morning, everyone, and thank you, organizers, for this last-minute arrangements for this online meeting. Thank you so much. So, as Dr. Aarti and Dr. Ankita have rightly talked about the need for adolescent health and research, we do understand that adolescents, we have the largest population globally, and adolescents, they represent a global, the critical window for breaking the intergenerational cycle of malnutrition. It is very important, but the current data suggests that among Indian adolescents, malnutrition is still very high, and we are escalating towards overweight and obesity. And the odds of getting stunted, they are more among those who are in the later stages of adolescence compared to the younger ones. Girls, universally, they are suffering more from stunting. This is as per the Comprehensive National Nutrition Survey data. The burden of, within malnutrition, the burden of micronutrient deficiencies is high. The same survey, the CNNS, they assessed 6 micronutrients, and it was seen that only 14% of the girls and 21% of boys, they had no deficiencies, and while other had multiple. So multiple deficiencies are common, and more than 50% of all adults and girls, they are suffering from 2 simultaneous micronutrient deficiencies. In girls, the deficiency is highest for vitamin D, folate, and iron, while in boys, the deficiency is for folate, vitamin B12, and zinc. With respect to Punjab, we are the only state where adolescents had high prevalence of 5 micronutrient deficiencies. This makes the context very important that micronutrients are less assessed and less talked about, but they still have a very major role to play in the overall metabolism and metabolic health. The data shows that anemia is very high in adolescent girls and equally in boys. Also, this another paper tells about that this deficiency continues from the very early stages, and that is more seen in adolescents. So we can see that it is just not iron, but all major micronutrients that are important and leading to anemia in the later stages, and would be having consequences on the reproductive health and the neonatal outcomes. So it is important that we start targeting not just one stage of the life, but we have to follow a life course approach. It is just not anemia that micronutrients are affecting, but in our another study that we have done, using the same data set, we can see that in adolescents, there are significant differences among those who are having normal body weight or were overweight or obese and had differences in their micronutrient levels, telling us the impact of micronutrients on the malnutrition, both the stages. So when we talk about the causes of these nutritional challenges, we have a lot. And if we categorize them, they can be segregated into dietary and behavioral factors. The food environment and industry influence, we can see that industry interference is increasing, and this easy access to junk food around schools, aggressive advertising, celebrity endorsements, and misleading hand-washed packaging. These are all having an effect on the eating habits. Then family and socioeconomic factors, they are increasingly playing an important role in shaping the dietary patterns. We are more reliant on the convenience food we have, but at the same time, there is low awareness about nutrition within the parents, so that these things are not percolating down. There is a cost barrier to nutrient-rich foods and family dietary patterns, and they are relying heavily upon the refined cereals. This latest ICMR studies was telling us that it is the high dose of cereals that we are taking and leading to obesity, but they are yet not talking about low micronutrients and low amount of proteins in our diets. Apart from this, there are biological and developmental factors, and majorly there are policy and system gaps with weak enforcement of healthy schools, canteen norms, limited adolescent-focused nutritional counseling, poor convergence at the level of health, education, and WCD sectors. And there are many other factors that cannot be jotted down in this slide only, but yes, this ecosystem is large, and we have a lot many gaps that need to be identified and targeted. When we say where should we act upon, so there are multi-level levers for actions of adolescents and nutrition that can be right from the level of biological factors, behavioral factors, environmental, and like what I have discussed earlier. So within, if we have to plan our interventions, they can be done at level of 3 levels: the personal level, the school level, or parental engagement, and at the larger level, that is community level interactions and health system integration. Within personal level, it is important that we teach our children the role of balanced diet. We propose eat less junk food to them, and they should be adequately hydrated. All these things are very basic, but they still need to be talked about. It is important because adolescence is also a stage with that we have to deal with autonomy, peer pressure, body image, school transitions. So at school level, we have to talk about different interventions that have been proven successful in other countries, but still yet to be tried and tested in our settings. We can have school-based peer leaders, the use of digital tools that closely aligns with the theme of this conference. Digital tools are playing a very important role because I have been doing a systematic review where I'm looking at what interventions work best for improving physical activity. And it was seen that the interventions involving digital tools, they more consistently demonstrated significant outcomes. So we can rely upon digital tools. They also ensure privacy. They also are self-paced. So I think they should be talked about more frequently. Then menstrual health can be linked to anemia counseling. That should be done in schools. We need to teach our teachers first how to deal with these curriculum, as Dr. has rightly said, how be the change you want to see. So we should be first talking to the teachers, making them our leaders for advocacy and the face for the children, because children are spending a large majority of their time in schools. At community level, we need to improve the awareness that we are all working upon. We have good supplementation programs. We have community kitchens that can be further used to meet the needs of the adolescents. And when we say intervention,
Dr. Madhu,
yeah.
try to conclude in next 1 minute. So.
Yes, we have to start early if we talk about adolescent health, because it is the maternal malnutrition during pregnancy that is going to lead to different problems in adolescents. Our initial studies from Punjab, they suggest that eating habits, they are no more depicting urban and rural disparities, and we need to treat them equally. And another study that we are doing in Punjab, they say that we are still looking at calories and micronutrients, they are still not being assessed. Dietary intake from the school surveys, they suggest children are more into junk foods with increasing frequencies and no disparities. Role of parents is important because they play a very important role in shaping the norms. We have to control over the pocket money and eating out habits. They have to focus on modeling breakfast and prioritize not to skip them. Stigma and pressure has to be dealt with. Monitoring and health indicators is important because we have seen that very few have taken interest in regular monitoring of height and weight of their children. So role of health system. So we already have the largest nutrition delivery system, but we just need better utilizations and not new schemes. Fortification, supplementation, and diet diversifications must act as a unified package. District level convergence and monitoring is the missing link, and strengthening these can rapidly improve outcomes. And this is where community medicine physicians can play a very important role in improving the convergence. So we have global best practices that can be used for improving our reach and having the sustained outcomes. Thank you.
Okay, thank you, Dr. Madhur. Now I request Dr. Lakshmi, and kindly just see the time also.
So good morning, everyone. I really take the opportunity to thank the organizers for selecting a non-medical person.
Please stay close to the mic.
Non-medical person to present in a medical fraternity. So I would, I'm being a public health and nutrition person. I'm here now sharing the experiences in a agriculture program, how a natural farming is good for sustainable adolescent health. So I'm here to share some of the practices and the innovations and the evidences that we have seen in an agriculture natural farming project. This is the Andhra Pradesh community managed natural farming. So basically, this is how I'm going to share with you the experiences. So we all have discussed, the previous speakers have focused on why we need to do. 1/5 of the total population is on adolescents, having a lot of risk to the anemia, NCDs, micronutrient deficiencies, and also in the context of the climate change. I think this is very important, which is not only to the adolescents, but the entire community family. And the natural farming. So why natural farming? So we get very safe and chemical-free foods. We get nutrient-dense and diverse foods. And it has a climate-resilient food system approach and lowers the health risks and gives family economic benefits to the family. And more importantly, it is a community-led project and also can be scalable. So in Andhra Pradesh, we are implementing a program called, by an organization called Raitu Sadhikara Samastha. It's a farmers' welfare society established by the government. In 2016, the focus was on going to the farmers and making them to understand the importance of the natural farming. We covered about 4,000 village the Gram Panchayats. And more focus, they have developed over a period of time in the past 9 years, really developed a lot of technical breakthrough. is a pre-monsoon dry sowing and ATM model. There are various agriculture models. I'm not going to spend time on these things. And the vision is because of the current government, even the government of India now this year, they've launched a program on national mission for natural farming. And government of Andhra Pradesh is looking at not just only 4,000 villages, but it has to be taken to every village over a period of time. The saturation needs to happen. So currently we are reaching about 10.12 lakhs farmers and around 12 lakh acres. But aim is to reach the entire state, about 6 million farmers and the farm workers also. And this is basically, this is a community-led model, focus on the safe food and also the diversity and behavior change. So the key approaches, what we are looking at is a diversified crop production. It's not just a monocropping, and also focus on the soil health. If you improve the soil, then the nutrient density of the foods that are produced from those soils is also, the plants also very healthy. And not just focus on production, we also focus on the consumption aspects and helping the families on homestead food production. And also we're supplying the nutrition, natural farming produce to the institutions like Anganwadi Center and the schools and hostels where the supplementary nutrition on behalf of the government is being supplied. The other continuous effort is on empowering the communities. So going to the farmers, bringing them to the farmers' field schools, helping them to adopt these practices. There are 9 key principles of natural farming. So that's being promoted. And at the same time, we work closely with the women self-help groups with the women who are federated at the village level. And they are being given, because these are all from the farm families. So the consumption aspects more focus in the farmer nutrition schools. These are the key approaches we are adopting in this project. And while working on, initially the project was designed only to influence the production aspects, but in 2019, after 3 years of the project implementation, we looked at there is a need to focus, integrate health and nutrition, because the food system and nutrition has links. And it also helps the other issues of the malnutrition, NCDs. And another important thing is we can promote diversity with the local foods. So we started this journey on health and nutrition with focus on promoting the production and consumption aspects, and at the same time empowering the families on maternal and infant child feeding practices, and also especially on the food plate diversity. That is important for the family. The family has children, adolescent girls, all sorts of the age groups. So that's where our focus is. And we did not start, though the program is in 4,000 villages. We just began the journey with the 50 villages. Then slowly every year we added up. Now currently we are looking at implementing this project in 400 villages where the natural farming practices are being done. The focus is at the community level, at the household level, at the community level, and the institutional level. We are also working at the market side. So I just wanted to take you to what are the key interventions that we are taking up in these 400 villages. All are related to the nutrition sensitive interventions, focusing on the homestead food production, like the nutri gardens, the backyard poultry, and the small ruminants where they get all the micronutrient and the protein foods, all the perishables. At the same time, just perishable is not sufficient for the food plate diversity. So the food basket where the collective, because we work with the women group federations, collective work can be done much easier. So that's how the food basket where with the staples, pulses, and other fats and oil seeds and all being supplied to this. And at the same time, institution supply. All the Anganwadi centers, instead of buying from the local market with the chemicals, we are seeing the tying up the farmers, MOUs with the farmers, local farmers, and these being supplied to the farmers. Then other important thing is we also converge with the existing programs. Like in village health nutrition days, all these days the focus is on bringing them together. And there are thematic campaigns once in a month there is being done. And farmers just do the things as they want. So we conduct a crop planning exercises sitting with the farmers, focusing on the nutrition sensitive agriculture produce. So that's important thing is happening. That's where we were able to even do the transformation, natural farming transformation. Ultimately, the two objectives we are looking at is food plate diversity and the natural farming transformation. And these are is a focus is on domestic production. But only thing is we integrate the nutritional advice into this program. So all these things, who does this job? We have recruited the young professionals from the universities with the background of nutrition and food technology, and they are the ones who facilitate this process in the villages. Every 5 villages we kept one facilitator, and slowly we are expanding this program. After 5 villages, the 10 villages they'll be able to do that. And we also bring the community resource persons who are the SHG members who have an experience in mobilization, bringing them together and do this job.
Lakshmi ma'am, try to conclude in 1 minute.
So the home production is mostly year-long production, and all the natural farming fellows, they have to do the farming on their own. Without that, just not preaching will not allow. And institution supply, as I already mentioned, and the formal nutrition school, this is the place where the education part, the counseling part is happening, and the cooking demonstrations and how to retain the nutrients and other things. And the food basket, I've already explained, there's a collective purchase is happening. The important thing is we have not done just implemented the program, we have done systematically evaluated the program. With the help of research partners, AIMS Mangalgiri, they have done the midline survey. All the villages, APCNF villages also has an improvement over the NFHS data, but when natural farming is integrated with the health and nutrition, the results are much more encouraging. Even the severity of the anemia has been coming down in these villages, especially the adolescents. There are more cases of the mild and moderate, but I think that can be done with the clinical interventions. It's been clearly shown. These are the impacts I showed. The consumption of the food groups have been increased from 30 to 45% increase of the food group, and the consumption of the risky foods have come down among the adolescent girls. So even the consumption of the packaged foods was also coming down in these villages. I'm not saying that completely gone, but it's there. And especially when we formed the adolescent groups, they were very energetic participating in these things, and they feel that we are less stressed. And so we had a lot of partnership with the organizations. AIMS Mangalgiri is the main partner in doing these things. We also have the University of Edinburgh, and the public articles are also published in the journals. And this is, these are the key innovations: food basket, natural farming fellows, the graduates who are coming in the freshly from the universities, sitting in the villages and doing this facilitation. And the 365 days green cover. When soil is covered all 365 days, the soil health is improved, and that's where we are able to see the impact. And adolescent health groups. So the expenditure evidence is very clear, 20 to 30, 40% of reduction of vegetables is coming down, and access, around the year they're able to get the things. And we could see a high resilience among adolescents. So these are few case studies. I've already shared that. There's an improved performance is also being seen. So what makes APCNF unique for the adolescent girls? One is the system approach, the farm, food, and health. And then it is completely led by the community, the women self-help groups. And the natural farming itself is a way of addressing the climate, becoming a climate resilient system. And it's very low cost, and it can be scalable. So policy implications, we suggest that how it can be included in the NCD prevention programs, and also always have a partnership with the local SHGs, with the women, who can be the more great influence to bring change in these health and nutrition. And adolescent clubs, we have, that is giving a very good response in the villages. So other natural farming principle is introducing in all the farm practices 365 days green cover. So our next steps are expanding all the villages, and we are also working in 17 states of the country. The natural farming is happening. Now we are also entering in the Meghalaya, and we are working on developing these training hubs and enterprises, more focus on the research. So I would say that the natural farming is foundation for sustainable health. So when the farming is natural, I think nutrition becomes medicinal. So that's why we can make it as, we don't need the medicines as such. Maybe nutrition is a medicine which is really helping in diet diversity, anemia, risk. And so healthy soils and healthy crops and healthy adolescents. Thank you.
Thank you, Chandra.
Due to paucity of time, I'm thankful to my co-chair that he has given me the time to conclude this session. So the thing is, adolescents are one of the healthiest group in the community, and they are never complaining, they are energetic, and that is why probably we do not perceive their problems on the scale we should have. Dr. Ankita presented a comprehensive picture of the programs, existing ones, the gaps and the challenges. Dr. Madhur presented the nutritional deficiencies, calling for a life cycle approach. There was Dr. Aarti, who believed in that every challenge is an opportunity, but it is implementation that has to be there. And she presented a successful model with intersectoral coordination and convergence. It is that nothing on the planet grows except by convergence. We have a Sanskrit quotation, Deepo bhakshayate dhwantam, kajjalam cha prasuyate, yaddanam bhakshayen nityam, jayate tadrishi praja. I hope you don't understand it. So it is that lamp consumes darkness and produces dark soot. Similarly, what food we eat affects what we produce. And she has put an alternative viewpoint on that. It is that digitalization has helped remove the urban-rural deficiencies in area of the dual burden of the malnutrition, I should say, amongst the adolescents. And it is high time that we bring all the sectors to the table to take an action, otherwise the future is going to be very bleak. We already have the NCDs on horizon, so it will be very difficult to tackle them otherwise. With this, I thank all my co-presenters who are here, my co-chair, and the audience who has been very patiently hearing it. If there are any questions, the speakers are there. We can take 1 or 2 questions. Any questions are there? Any comments are there? Okay, then we have the tea break after it?
They are available in
Okay, so they will be there in the tea break and the lunchtime, and you can talk to them. Thank you. So I hereby close this session.
I request Dr. Hemangini Shah to felicitate our chairpersons, Dr. Bhavesh Modi, Director and Scientist G, ICMR, National Institute of Occupational Health, and Dr. Kiran Goswami, Professor and Head, AIIMS, New Delhi. I also request Dr. Hemangini to felicitate our speakers, Dr. Aarti Gupta Reddy, Associate Professor, Community and Family Medicine, AIIMS Mangalagiri, Dr. Ankita Kankaria, Assistant Professor, Department of Community Medicine and School of Public Health, PGI Chandigarh, and Mrs. Lakshmi Durga Chava, Senior Consultant, Health and Nutrition, Raitu Saddikara Sanstha, Department of Agriculture, Government of Andhra Pradesh. We also acknowledge the presence of Dr. Madhur Verma, who joined us online. Thank you, sir. Thank you, dear chairpersons and panelists. The next session for this morning is on future-ready classrooms, integrating digital technologies for effective learning. I request Dr. Rukmita to welcome our chairpersons and speakers for this session. The chairpersons are Dr. Kapil Goyal, Associate Professor, Department of Community Medicine, Goa Medical College, and Dr. Hemangini Shah, Associate Professor, Department of Community Medicine, Goa Medical College. I also request our speakers, Dr. Yugantara Kadam, Dean, KIMS Karad, Dr. Dipali Jankar, Associate Professor, KIMS Karad, and Dr. Rashmi Hulali, Assistant Professor, KIMS Karad, to kindly take the dais. Dear speakers and chairpersons, kindly note that the session is for 45 minutes. You all are kindly requested to help us to adhere to the time. I now request our chairpersons to start the session.
Good morning, all the esteemed delegates, faculties, and young public health leaders. Welcome to this plenary session on future-ready classrooms integrating digital technologies for effective learning. As we move into a post-pandemic landscape, teaching and training methodologies are undergoing a lot of transformations. So this session will focus on how the digital tools, AI, and technology-enabled learning environments are transforming and reshaping. So how we are building the new capacities for effective learning. So we are privileged to have 3 distinguished speakers for this session, and they will share their insights. Now I will request my other chairperson, Dr. Hemangini ma'am, to kindly introduce them formally. Thank you.
Thank you, sir. We have with us Dr. Yugandhara Kadam, whom I would like to fondly call as a lifelong learner. She is the Dean at the Krishna Institute of Medical Sciences, Karad, and she still has a very keen interest in teaching and is always very eager to learn new aspects, and that is why she is here today for this very important session. She has received the state-level Mukta Salve Award with more than 35 years of experience and expertise in MCH, epidemiology, medical education, technology, and research, with research publications to her credit. She is here with her team, Dr. Rashmi Hulali, Assistant Professor, KIMS Karad, who is received grants for thesis. Right from her thesis time, she's been interested into research in a big way. Her areas of expertise are NCDs, occupational health, and of course, medical education. Dr. Dipali Sadashiv Jankar is the Associate Professor at KIMS Karad. She is doing her fellowship in nerve conduction and EMG. She is from physiology, and she has done her advanced course in medical education, and therefore we have a very good panel of speakers who are going to talk to us about the future classrooms. That is very, very important as the generation is moving ahead, and we have Gen Alpha who are going to join us soon. So thank you, and we can start the first session, ma'am. Over to you.
Good morning, everyone. So I am very thankful for the organizers for giving us opportunity of this plenary session. And I think with the short note, we were able to present this plenary session. Training tomorrow's Indian medical graduates. Now, under the competency-based medical education, as you know, we are training our Indian medical graduates. And now the arrival of artificial intelligence and digital technology definitely we have to change our whole medical curriculum, including teaching learning methods and assessment methods. So medical education, as you know, it is a lifetime learning process, and there is an immense role of artificial intelligence in coming years. Now, artificial intelligence definitely is for our help. So it has fixed various issues like in education, like the language processing, reasoning, planning, and cognitive modeling. Now, when we are talking of artificial intelligence, here we have to understand that what we are using is the augmented intelligence, and what it means that medical field will remain human-centered, but here artificial intelligence will be helping us, it will be assisting us, and that is why it is the augmented intelligence as well as we are able to provide the healthcare services at a long distance. Continuous monitoring is available. So role of doctor is going to change. So depending on that, we have to make the appropriate changes in our curriculum. Now, in this scenario, we are changing as a doctor as authority to digital interpreter, along with keeping in the mind the ethical issues and professionalism. So previously we were the lone genius doctor, as we were famously known as we know everything, but it is going to change because huge volume and rapid expansion of the knowledge, it is there, and it is not absolutely possible for us to know everything, as the super specialties and more super specialties they are there. So it is increasingly impossible for us to know, and that is why we have to ultimately go towards the AI and the digitalization. So future clinicians will increasingly rely on sophisticated AI-driven algorithms, which we have to interpret, and we have to give the personalized treatment. So we have to integrate the amount of data which is generated from the variables. Then we have to match with them the individual genomics. Then real-time data we have to collect. Then we have to provide collect the comprehensive patient histories from the various sources. And therefore, our role is more of interpreting. And then we have to change whatever the data we are generating and make it more human-centered care, ensuring patients' understanding and trust, keeping it in our mind, and we have to practice the healthcare. Okay, now with the changing healthcare, we have to change the medical education. So digital technology and AI, they are reshaping. So there is innovating teaching techniques will be there. Learning will be more personalized, as in case of the personalized treatment. Then more effective clinical training is possible. Then evidence-based benefits. What are the benefits we are having AI in medical education? So some evidence-based facts are available nowadays. So personalized adaptive learning. Now whenever the student is learning, it will be assessed with the help of AI, and definitely he will come to know where I am lacking, and we can help as a teacher, we will mentor them, and we can make them learn more and more effectively. Then enhanced diagnostic and clinical skills. Definitely the clinical scenarios, then virtual cases, they will help the students to learn more and more, because this AI-generated AI, they will keep on changing for each student depending upon the level, and definitely the learning will be of a higher level. Immediate feedback and assessment is possible. Now in case of OSCE and OSPI, as we know today, to take the lot of observers and whether they are doing their observation very sincerely or not. So that problem will be solved here, and the feedback the students will receive very accurate. and assessment will be good, and it will be more rapid, accurate, and cost effective. As the feedback is customized and immediately it is given, and it may be in a very good terms, like the sandwich method or Pendleton method, whatever method you are asking the AI to do that. So feedback will be also very well. Support for evidence-based medicine. So whenever I want to find out any management, treatment, or I want some information, it is possible for me to get the evidence-based information, but for that purpose, you should know the appropriate AI tools. Efficient administrative task. So whenever you are working in the wards, then record keeping, writing the records, then coding them. So all these activities will be done by the AI with the help of digital tools. And equity and predictive support is available. Just now I have told you, depending upon the student's learning abilities, slow learner, fast learner, so the AI will adapt itself to provide these learning facilities. Then simulation and skill practice, it is very useful over there. So artificial intelligence or augmented intelligence and virtual reality, they will combine together, and it is possible to develop the skills, especially the haptic feedback. So when you are doing the surgeries, the feel of the real patient, how it feels at the time of surgery. So it is possible for us to get when the case scenarios or the patient is provided for your improving surgical techniques, so student can learn it very effectively. Then evidence-based risk. So always AI is not devoid of risk, digital tools and AI. So it may erode the clinical judgments, because now we will feel that whatever the information I am getting, I will give you to the digital tools having the AI, and AI will give me the diagnosis. But it is not like that. So our clinical judgments we should not lose. And just now I will like to tell you that today the students, they are just listen to the history, immediately they will start writing the investigations. And after seeing the investigations, they will diagnose. So it is not the way. Always we say that our clinical examination skills, they are our strength. No one knows about it because all other cognitive information is available on the Google or on the AI. But clinical examination, identifying various signs and symptoms, taking history, that is the doctor's skill.
Excuse
and
me,
we should not
Can
lose
you just
it.
bind in next 1 minute?
Okay. And so bias and data quality issues may be there if you introduce the biases in the AI. So we have to take care of that. Then inaccurate and hallucinated content, that is the information may be inaccurate, but it is available for the AI, then it can interpret it. Then academic integrity challenges may happen, so we have to take care of that. Ethical privacy issues, they are always there when you are storing any information digitally. Then widening educational gaps, because the AI and digital tools may not be available for the all the students, so we have to take that into consideration. Then teachers' role is also there, because they have to, they are the facilitators, they are the curriculum designers, but here it is very interesting that AI will help the teachers to develop the curriculum, how they can include the AI and digital tools in the teaching learning. Mainly he will be mentor for developing the professionalism and ethics as an assessor. So theory assessment, or it may be the practical assessment where the AI can be used, maybe teacher's role is going to come down. So classroom manager and the supporter, he can have a role that, and lifelong learner, that role has to be developed by the teacher into himself as well as in the students. So there are also challenges and considerations. So here it is the equitable distribution, overcoming resistance because upscaling of the faculty is required. So teachers, older generations may not like it, but they have to do it. So we have to prepare the teachers. So medical education unit's role will be very much important. So I would like to tell you here that already in our institute, we have started it 3 years back. So our teachers are trained in developing the e-content with the help of AI also. They are trained in using the AI in the research in identifying gaps and collecting the references. And also we are having now using the AI for developing the questions, MCQs, clinical scenarios, because as the NMC has changed the question pattern, so developing the scenarios, so many numbers. So already we have started it, but at the same time, what I am saying here in the competency-based medical education DREFUS model, so there are various levels of acquiring the competencies. Highest is the expert. Into that, intuition, that is very important. And that intuition, it's definitely, it is not be available with the AI. It is that person's, human being's strength, because these are the, always we say it was my intuition, gut feeling. So from it, where it comes. So it is a keen observation where you are not able to put it into the words. But you feel that even though everything is okay, patient, no fetal distress, nothing is there, no signs are there, but you ask the parents or the mother that maybe caesar is required, and after the cesarean you come to know that yes, my decision was correct. So that intuition may not be available over there. So definitely we should start training the students in the clinical acumens, all these things, and artificial intelligence will be augmented intelligence for us. Thank you.
Thank you, ma'am. We have Dr. Rashmi, who will now brief us on the further aspects of the future classroom.
So, good morning, everyone. I'm very thankful for the organizing team for giving this wonderful opportunity. So, I will be talking about digital tools. So, there are n number of digital tools in medical education, their types, benefits, and limitations. So, digital tools are classified broadly into e-learning platforms, electronic health record simulators, virtual and augmented reality, and mannequins. So under e-learning platforms, we have something known as learning management systems, so which has digital tools like Moodle, Canvas, and Blackboard, so which they provide access to all the courses and discussion forums. So under electronic health records, so as all of the documents in both government and health sectors are nowadays so we have to teach all these to our students. So with the help of these digital tools, we can do it SIM, EMR, Practice Fusion demo, so which helps in documentation workflow. So under virtual and augmented reality, and most of the colleges, they have a skill lab where we find all these mannequins. So we can use these for virtual patient encounters, anatomical exploration in 3D, and surgical training. So these 3D models nowadays we can show by using digital tools like Microsoft 365, so which has incorporated this 3D. So where we can show these 3D models on the PPT, and we can rotate. For example, if you want to show anatomy of heart, so we can take this 3D heart picture and we can rotate in all the 360 degree, and we can explain to all the students. And some of the mobile applications where we can find all the quizzes, MCQ banks, podcasts, diagnostic tools, so which help the students to learn on their pace and also test their knowledge. So under digital diagnostic aids, we have digital stethoscopes, heart, and where we can detect heart murmurs. So all this software help the students to refine their skills. and also they give instant feedback. So under online resources, as we all know that YouTube has live streaming lectures, and for assessment we have Google Forms, so where we can use these forms for for conducting quiz to UG students, and this Kahoot, so it is also for quizzes, which IIPSM has recently used for World Health Day quiz for UG students. So all these helps in doing assessments. And also we have e-textbooks. Nowadays the PARC textbook is available as a e-textbook, 28th edition, under this medical GPT. So all these are very easily accessible for educational content to students. So I'll be telling about a few of the digital tools. There are a number of tools, so which we can use on our day-to-day basis. The first one is Canva. Canva is mainly for content creation. So with this Canva, we can do appealing posters, infographics, so your flyers, banners, which we use for workshops, CME, and also like social media visuals. So, you can do invitation cards, all those things. So for medical education, we can use flyers and banners with the help of this Canva. So we have something known as H5P. So this is mainly for interactive content. So where we have drag and drop options, and you can do interactive videos and also some of the presentations. So we have Edge app. So Edge app is a mobile first micro learning lessons. It is mainly for micro learning lessons, and also it helps in tracking learner analytics also. So we have something known as Lumen5, where you can do short educational videos, which can be used for your practical sessions. And also you can convert the text to video automatically. So quickly when you want to do something, we can use these tools will help you. So we have peer grade. So peer grade is nothing but peer assessment. So it helps in doing peer assessment, and also it provides the feedback and helps in improving the reviews. So there is a Mentimeter, so which some of the staff they use during their class, where it helps in giving the opinions like live polls. So when you ask a question to the students to give their opinion about how was the class, so what you want to do next, so is this can be incorporated into our practicals, or was it helpful? So to get those such opinions, we can use these live polls. When they do it, automatically the polls are seen on the screen. So it makes the students to attract their attention. So as nowadays all the students, their concentration span is very less. So quite difficult to conduct 1 hour class. So in that 1 hour class, their span is less than 40. So in between, to attract after 10 minutes or something like that, we can use such tools to drive their attention. So we can also conduct quizzes, surveys, question and answer sessions, and interactive presentations through Mentimeter. And there is Edpuzzle. So it helps in creating interactive video lessons.
Dr. Rashmi, you have 2 minutes remaining.
Okay. And embedding quizzes and tracking student viewing progress. So we have something known as Moodle. Moodle is mainly for online courses, assignments and quizzes, where we can do some of the courses and fellowships. And OBS Studio. OBS Studio is mainly for tutorials, demonstrations and live streaming classes. Most of these tools they overlap in their uses. And Screencast-O-Matic is the one which is for quick screen recordings. So when you are doing some presentation online, so you can use this webcam and your PPT. So they were, both can be seen together. So that is what webcam and screen explanations can be done with Screencast-O-Matic. And we have something known as Padlet. So this is mainly for brainstorming. So and creating digital bulletin. So all these ads, we can see some of these digital tools nowadays they are coming in ads in TV. So many people are using it. All the students are using it. So somehow all the teachers should know this. So it has become a mandatory. So what are the benefits? So first one is mobile learning growth. So the mobile has become integral part of us. So without mobile, not even teachers and students. So it helps for educational content anytime, anywhere. And this gamification in education. So that content has been incorporated so much in education, so that students are attractive for this gamification. And this virtual reality immersion, so it helps like real life medical scenarios for better learnings. For them, it is quite interesting. And AI integration. Most of the digital tools are overlapped with AI. So we cannot differentiate. Some of the digital tools, some of the tools are quite difficult. For example, this nowadays Microsoft 365 is incorporated with AI Digital Copilot. So whenever you are doing presentation, so if you don't know the information, you can probe that Copilot. Copilot will give you all the information. If you want it, you can take it. If you want to edit, you can edit it. And also this Microsoft Word, whenever you want to draft a letter, so just probe the Copilot. So it will draft the letter. So after that, you have to just edit it. So it makes our work very quickly. So coming to the limitations, so internet connectivity is a must. So without that, we can't do anything.
Rashmi ma'am, please conclude.
Okay. So high cost of devices. So most of the mobiles are costly and softwares. Initially, all are free. So when you keep on using, after some extent, they are paid. All of the apps are paid. Reduced human interaction. Absolutely, there is no interaction. Distractions. When you are using all these apps, so these social media apps will also make you distracted, and also some of the identity can be misused. Limited hands-on experience, cognitive overload. There are so many number of apps. So how can you, so there is totally overload. And reliability. How can you rely on this, all the information given by all these digital tools and AI tools? So I want to conclude by saying a quote: in a rapidly evolving digital world, adaptability is not an advantage, it's a necessity for teachers. So anyway, students, they are already adapted. Thank you once again.
Thank you, Dr. Rashmi. We have Dr. Dipali, who would now present the last part of the medical education session. Ma'am, I would appreciate if you could try to wind up in 5 minutes. That would be great. Thank you.
Yes, very good morning, everyone. I'm a physiologist in a PSM conference, so odd person out in the crowd, but not so with my topic. The topic is AI in medical field. Much of it has already been told by my colleague, Dr. Rashmi. So these are the various AI search engines which we use daily, though we don't know whether we are using it or not. Google Maps, Alexa, ChatGPT, Gemini, everything we are using. So this is already in our life. Then I'll be going through quickly about use of AI in various aspects being a medical teacher, in content creation, assessment, and the most important research and publication part. So in content creation, always we say our teachers to prepare e-content for the students and all. So one of the platform is GPT. ChatGPT we all are using, but it is very casual platform. And it is a conversational type of platform done for content creation. But Custom GPT is a specific platform under ChatGPT only. So under Custom GPT, we can prepare diagrams or pathways. So we can just type under Explore GPT, diagram or pathway creator GPT will get that link, and whatever question, but prompt writing is very, very essential. How you give that command or prompt to this AI search engine is very, very essential. So giving that command, again, that command can be modified under ChatGPT itself by universal command modifier. Again, option is there in the ChatGPT. We don't usually go to the other details of ChatGPT, but yes, Custom GPT is very essential. We can create various diagrams and pathways from it. Question bank creator. Again, as madam already said, we can easily prepare the question bank with the use of this medical GPT under ChatGPT. We can give command or prompt, prepare 10 MCQs with a difficulty level for second MBS BA students or third MBBS students on this particular topic. Everything is ready. So Custom GPT is very important platform. Then next, again, Perplexity for Airtel users. It is free nowadays, the basic version. Perplexity is mostly focused on the research. Okay, so ChatGPT here, it will use already whatever data is fed to it, but Perplexity, it is modifying on a day-to-day basis. So this is a very good platform for, again, medical teachers. And into that, for pro users, we have Perplexity Labs. So again, I have given the example. If we just want to have quick information related with a conference in cardiology in India in 2025 and 26, we'll give the details and the whole format will be ready. So this is a very good tool, Perplexity Labs. Then coming to publication, we being medical teacher always overburdened with teaching and assessment of the students. We don't usually find time for the publication and research purpose. But yes, with these tools, you cannot give an excuse that I don't have time for literature review and preparing the manuscripts for the publication process. All these tools, Consensus, Cite AI, Elicit, Semantic Scholar, this will help us to organize, cite, annotate various publications. It will prepare the drafts ready. It will summarize over 200 million research papers for us. So summary is ready-made given to us with the help of all this. In this Cite AI, this tool is specifically important for citation purpose. We'll get to know whether this work is in the next or the newer papers, whether it is having evidence, contrasting evidence or supporting evidence. So we'll get all the information with these various tools, AI tools which are available for literature search and analysis. The next is for reference management and writing. Most of you must have heard this Mendeley reference system. Very good tool which will cite, annotate and prepare the ready-made format ready for publication. And Mendeley is approved by most of the journals. If you use ChatGPT for that, those summaries and those ready-made manuscripts will not be accepted by many standard journals, but Pepperpal, Mendeley, all these are the platforms which are acceptable by the standard journals. Pepperpal, again, I would like to tell it is a very good tool. Okay, it is literally a PAL which will help in academic writing. It will give the language suggestions. It will check our academic tone. It will also have the AI reference finder. So Pepperpal, Mendeley, Trinca, Quillbot, all these are the essential tools for reference management. Coming to teaching tools, we have just seen. Now coming to assessment tools, in that knowledge assessment, yes, Emboss, UWorld, these will prepare the MCQs which are having USMLE style questions. So very good for the students who are preparing for such exams, USMLE or other based exams which are outside India. And this also will help the teachers to have variety of assessments. So they will have their whole medical curriculum. They have question banks. Everything is ready. You need to just approach these tools to get benefit out of it. Again, the last is automated essay scoring system, which will utilize the natural language processing, NLP, with the help of which the long paragraphs, the essays, the case reports, everything will be read by that AI search engine and it will score automatically, so bias will be reduced with the help of such AI tools. Then coming to the next very important clinical skills and simulation assessment. So most of this AI-powered virtual patients, this is already in use by the Miami University and Harvard University. These are the interactive computer simulators which will literally talk to the students. They will check the students' interaction. It will also check on the students' decision-making, students' diagnosis and treatment planning. Okay, the surgical simulators, they will also check the precision of the surgical skills. They will intervene in between if the student is making something wrong. It will give feedback, real-time feedback will be available. Performance analytic platforms, it will analyze the student's past performance and it will predict the future outcome of that student's skill if he is doing something wrong, and it will immediately intervene in between. And the last is image interpretation tools. It is very important tool for interpreting images for radiology students mostly, where MRI, X-rays or CT scans will be read by the students. He will give his decision and the AI will interpret whether it is matching with his diagnosis or not. Then integrated learning and assessment platforms where the content delivery will be there, various assessment tools will be there, and it will track the performance of the students. So it is all inclusive, integrated platforms. Neural Consult is very famous. It is AI-driven platform which provides learning paths, customized tests, mind maps, and this allows students to focus on areas where he or she needs improvement. So it is a tailor-made approach is available for Neural Consult. And the next very important part is AI and health data, being this community medicine conference, predictive analytics in public health. So dengue outbreaks or waterborne disease hotspot, all these things can be collected by the AI and it will predict that. Then real-time dashboards, how much is the bed occupancy is there in the hospital, okay, or how is the ICU trends, or where is the antimicrobial resistance trend in that particular hospital. Everything is been told by this AI tools. Population health management, where defaulters or the high-risk diabetic patients, everything will be detected. If you feed the correct data, the AI will give us the future things in advance, which will help our job to make it more easier. But again, as madam already told in her deliberation, that human oversight is very, very important. Source verification, whether it is coming from the authentic, this is mainly for the research thing, publication and the literature review, and privacy and security, again, very important part of this AI. So future of medicine, yes, definitely there will be personalized medicine coming in next future 5-10 years. It will be there. Wearable techs, smaller sensors will be available on our body, which will track the continuous whatever data or parameters from that person, and AI and big data. Good data will create good AI. So it is very essential to feed the correct and authentic data to this AI search engines. Again, there are various challenges, data-related challenges, algorithmic and ethical challenges, as well as implementation and human challenges. But yes, you should not fear the technology, you should not resist the change, you should learn it, challenge it, improve it, and use it with wisdom and expertise. And lastly, coming back to the theme of the conference, I would like to tell that AI will not replace, definitely it will not replace the health professionals, but who use AI will definitely replace those who don't. So together we can build a healthcare system that is digital but compassionate, data-driven but equitable, AI-powered but human at its core. Thank you.
Thank you, ma'am. Thank you so much for saving us 9 minutes. I request my chairperson, Dr. Goel, to give the conclusive remark.
Thank you all the speakers for their valuable presentation, and all the audience for patient listening. And we have seen that the first speaker, Kadam ma'am, has spoke about the augmented intelligence, use of simulations and the various skills, AI-related skills. Dr. Rashmi mentioned about various digital tools, use of Kahoot for various quizzes, and ChatGPT, Gemini, use of Gamma, different AI tools for the preparation of PPTs and videos. Then Dr. Deepali mentioned about AI in content creation, the integrated learning management platform, AI and the big data analytics. So I see that with respect to these use of AI tools, the future of teaching is very, very, I will say, very interesting, and use of digital things, and the learning will be more learner-centered. So with this, I feel in interest of time, we close this session officially on behalf of the IAPSM Young Conclave. Thank you all.
Thank you, dear speakers and chairpersons. I now request our chairpersons to felicitate our speakers, Dr. Yugandhara R. Kadam, Dean, KIMS, Karad, Dr. Deepali Jankar, Associate Professor, KIMS, Karad, and Dr. Rashmi Hullali, Assistant Professor, Department of Physiology, KIMS, Karad. I request Dr. Jagdish Kakodkar, Professor and Head Department of Community Medicine, to felicitate our chairpersons for this session. Dr. Kapil Goyal, Associate Professor, Epidemiology, PGI, MER, Chandigarh. Sorry for the wrong designation earlier, sir. And Dr. Hemangini Kesha, Associate Professor, Department of Community Medicine, Goa Medical College. We now move on to the first keynote address for today on the theme of YLNC 2025, which is digitalization, data and decisions, youth at the forefront of health tech. Unfortunately, the speaker, Dr. K. Madan Gopal, the advisor and head, Public Health Administration, National Health Systems Resource Center, New Delhi, cannot be here with us today, but he will deliver his keynote address on digitalization digitally. I request the chairpersons for this session, Dr. Manish Kumar Singh, Professor, Department of Community Medicine, Dr. R.M. LIMS Lucknow, and the Secretary General of IAPSM, and Dr. Jagdish Kakodkar, Professor and Head, Community Medicine, and the Organizing Chairman, YLNC 2025, to kindly take the dais. I request Dr. Aparna to welcome our chairpersons for this session. Dr. Madan Gopal, we welcome you to YLNC 2025.
Okay, thank you very much. Am I audible?
I request the chairpersons to kindly begin the session.
Hello, good morning, sir. I have the pleasure to introduce Dr. K. Madan Gopal. He's a senior public health leader with over 3 decades of experience in strengthening India's health system. And he's the advisor and head of the Public Health Administration Division of NHSRC, Ministry of Health and Family Welfare, and has been instrumental in major national initiatives, including the Aspirational District and Block programs, Vision 2035, disease surveillance, senior care reforms in India. And he has also been earlier as a part of the Niti Aayog, he has helped design the State Health Index and contributed to reforms in surveillance, governance, and public health preparedness. He is widely respected in his systems thinking, clarity of approach, and commitment to building a resilient, data-driven, and equitable health systems while mentoring the next generation of public health professionals. So we are very delighted and very fortunate to have you as one of the keynote speakers for today's Young Leaders Conclave. And we are pretty sure, sir, considering your vast experience and expertise, all the audience sitting over here and those who have joined online will be immensely benefited by your lecture. So I welcome you, sir, to start with the presentation. Thank you so much for joining
Thank you,
us.
Manish. Thank you, Manish. Am I audible, no? Am I audible?
You're audible, sir.
Okay, that's fine. First, apologies because that things are beyond my control. The order which was released in January 2024 to be effective from November. So some of the people, that's the when we are into the public procurement, other thing, we say that we should not be monopolizing things. And things happens when things are monopolized. And the effect of that, yesterday my flight was cancelled. And because I was knowing that the flights are going to be cancelled, that's why I requested Jagdish that we should be having a backup plan. I'm very grateful for the organizers for having this backup plan so that I can interact with the young leaders who I usually love to interact with young leaders so that at least whatever which I have learned during my career span of more than 3 decades, at least I can share with the younger lot so that they can take and actualize the vision of our highest leadership, that is Vision 2047 Viksit Bharat. So I think my screen is visible. Is it visible screen?
Yes, sir, it's visible.
Okay, I would be just quickly running you through what this digitalization is this. So the theme today brings 3 powerful ideas. That means digitalization, data and decisions, and puts youth right at the center of this transformation. We have been always listening about the data-driven governance. When I used to work with Niti Aayog, Amitabh Kant used to say that we should be focusing on data-driven governance. And as a result, the Aspirational District program and the Aspiration Block program were conceptualized, which are basically data-driven governance models. So we see that how that has resulted in the adoption of the data for other things. Besides that, I was also involved in the State Health Index, which talked about competitive federalism and creating a culture of use of the data for generating indexes so that a sense of competition can happen and the people can work towards improving the performance and other things. In India, we are not discussing pilots and small experiments. We are not talking about platforms that touch hundreds of billions of people from COVID to ABDM, from eSanjeevani to IPHS dashboard. In fact, Manishji, I would like to share that during my NITI's days, I was involved as a part of the team for developing the digital data tools. That means which form the background for this, background for the National Digital Mission, that is the National Digital Blueprint. So let us see that what this digitalization is. This is my slide moving?
Yes, sir, it's moving.
Okay, that's fine. Thank you. Thanks for confirmation. So we see that we are now used to say that roads, water, electricity are basic infrastructure. For public health, digital is becoming part of core DNA. During COVID-19, India did many thoughts. Many thought that it was impossible. Over 2.2 billion vaccine doses administered, registered, tracked on a single digital platform, that is COVID dashboard. We saw in real time how digital tools can support beneficiary registration, stock management, certification, data for policy, all at a population scale. Now the challenge is that if we can take the same energy to routine immunization, NCDs, mental health, senior care, and public health, though we have started that thing, and you see that how all the three things are linked. We have to take it to the next level now. Now you have to see that what globally we are moving, what we are doing. Because in the previous speaker, it has mentioned, I also usually used to say that we should not be worrying about the AI. We should be worrying about the people who are having content and who are using AI. And they are the biggest threat. If we are not using AI, then the AI will replace you, and the people who are using AI, it will be replacing you. It's not, but I would want to add one more thing. The people using AI and having content and experience, they are going to replace most of the people who are not using or having these two things. Globally, we are moving from analog to digital, from reactive to predictive, and from episodic care to continuous care. The market for AI diagnostics alone is projected to grow more than threefolds between 2024 to 2030. Different estimates suggest that the market will reach around $5 to $7 billion by 2030, with an annual growth rate of 20 to 30%. But for me, the most important point is not the size of the market. It is the size of the opportunity to improve lives. Earlier diagnosis of TB, faster stroke detection, low-cost triaging in rural experience. If we do not prepare our health system and our young professionals for this way, we risk of being passive users of imported technology instead of active shapers of global health. It's very sad that we have the largest market. When we started the medical device sector, at that time, 5 years down the line, 80% of the medical devices were imported. Now, at least the push for Make in India, the local for global, at least now that number from 80% has reduced to 60%. That means you see the kind of potential which we are having. That's why I'm saying that we should be, instead of passive users of imported technology, we should be active shapers of global health tech. If we talk about the India health system, you see that we are at a moment of transmission. We are having Ayushman Bharat, which is giving a very high digital push. If you talk about why digital push, because way back in 2010-11, when we had the Clinical Establishment Act, which talked about electronic medical records as a mandate for any health establishment. But you see that what is the uptake of that. But this is now all the elements of the things which can give a digital push for this. You see the trinity of the things which has happened, the public good which we have created, the Aadhaar and other things which is there. We see that how that can be utilized in this kind of settings. So sorry, my battery was going on, so I just to connect that. So you see that what we can, India health system, if you have, I have talked about the digital infrastructure, ABDM, HMIS, RCH portal, and there's many portals are there. The previous speakers are also talking about the digital goods which we are having. but they are all in a siloed system. We have to see that how we move from a siloed system to an integrated platform. So we are having a simultaneous transitions which are happening. The demographic transition is happening, epidemiological transition is happening, economic transition is happening, and technological transition is also happening. We see that how from that transition from a siloed system, integration can happen. Digital health is emerging exactly at this inflection point. It can help us bridge gaps in access, quality, and financial protection if we design all the things well. Then if you talk about, I will just now mention you about the 3D framework, which we all talk about. We all are aware about the digitization efforts. We all talk about data, we talk about decision and the impact. But every digital initiative should be viewed through only three Ds. That means digitization, data, and resources. 2 decades back, it was focused on digitalization. Now, after digitalization, a lot of data was thrown. Now we are started talking about use of data for governance, that is data-driven governance. Now, when you start using the data for governance, then you start taking decisions, and that will be impacting your policies and the outcomes of other things. First, digitalization, we have digitalized it. We have digitalized workflows, we have digitalized telecommunications, we digitalized e-claims, we have digitalized the lab information system, ambulance tracking, IPHS system, all we have digitalized. Even our pay data, workforce, they are all been digitalized. But you see that the digitalization has resulted in a lot of data. And once we have identified and made all our processes digital, the data which is coming, at least we can ensure that the regularity of the data is there, but a lot of work is required for ensuring high quality real-time data. But after this data is generated, we have to see that how this data translates into a decision. The value is realized only when the data is translated into decision so that we can have smarter budgeting, smarter policy changes and other things. I just cite an example during the COVID time when I was involved in prioritization of the vaccine because we got only the 10 crore vaccine dose during the first phase. We have to prioritize this. At that time, we struggled to have the data because that good quality data was not available, but we could do the prioritization using the data which was available in a scattered way, did a lot of triangulation to arrive at a consensus and influence the policymakers how we can decide and prioritize the vaccination strategy during that time. We say that digitalization without data use is just computerization, which you have seen elsewhere. Data without decision is just reporting, which we have reached to this state. That means now we are just reporting, the administrative reporting is happening. But the decisions without accountability do not change people's lives. We have to see that how the three things, the 3D frameworks moves in the direction so that we can impact and change people's lives. But if you talk about the digital blueprint, which I was involved, I'm very proud that I was involved with this National Digital Blueprint, which formed the basis for the ABDM. This National Digital Blueprint talks about this pillar. That means we will be having a unique health ID for all the citizens, so that it can be embedded into electronic health record, so that a seamless electronic health record can be created. National Health Registry for the patients, the doctors, the facilities, the pharmacists can be apart. Apart from that, the unique ID will be having a infrastructure which would be interoperable. And besides that, we have also focused on the mobile first approach because the use of mobile, the penetration of mobile, penetration of the broadband is going to increase. So that's why this become very important for all the young innovators. Instead of building isolated products, we see that how the foundations which have been laid, we build on this foundation and see that how we actualize and capitalize on the foundation which is already available. Then if you talk about the digital public infrastructure, these are the things which we all know. Today we are recognized globally for digital public interface. Aadhaar, UPI, COBIN, and now ABDM are often cited as examples of scalable digital this. Under ABDM, as early as of early part of this 2025, we had crossed more than 74 crore ABHA IDs with over 49 crore health records linked and more than 3.6 lakh facilities and 3.6 health professionals registered. But this is just base work and the foundation which is happening. The actual thing will come when the data which has been collected, that is the digitalization which has happened, will create the data and then we start using the data for arriving at decisions. eSanjeevani, our national health electronic telemedicine services, has provided more than 36 crore teleconsultations as on April 25. This digital primary scale reaching places, you see that how we have utilized the opportunity during the COVID times when we were able to release the telemedicine practice guidelines. Now that has undergone a lot of iteration, but that was a game changer. How you have brought in the technology, the consultations right up to the home. See that how the small intervention, small change has resulted in the how we have managed the catastrophe during the COVID times with the use of this technology. The COVID has registered over 1.3 billion doses in under a year, shows the potential of digital public infrastructure. We have now data of all the 210,000 facilities. That means, and now we can pinpoint that which are the facilities are missing, what are the gaps there, and what is the performance of that facility. This is where the digitalization is this. That means we can identify the standards of the facility no longer just in the book. They are just visible as a benchmark. Now, these are some of the achievements which are worth celebrating. As I already mentioned that the CoWIN is one of the greatest platforms. eSanjeevani, over 36 crore consultation. Nischay, end-to-end digital management of TB. Then eRaktakosh, digital blood bank. Early adoption of Arogya Setu. You have seen that how you are using it. Apart from that, AI use cases emerging, over 5 million X-rays and deployed across 17. This Cure AI, I was associated with that when they were doing the piloting and developing the proof of concept in Baran district of Baran district. So you see that how small things we can do when we get associated with the digital things. These are not the achievements that India can design, build and scale digital solution, but not for India, but this. But other important thing is why the youth matters. India has the largest youth population in the world. Around about 65% of our population is under 35. We have vast startup ecosystem. Reports show that over 10,000 healthcare and health tech startups were active by 2024. Many of these companies are founded or led by people in their 20s and 30s. They work on AI-based diagnostics, tele-ICUs, remote monitoring, e-pharmacies, wellness platforms, and digital therapies. This generation is tech native. You are comfortable with data, algorithms, mobile interfaces. When this energy meets the public health thinking, we can transform service delivery in this. You see that how the youth is building the health solutions. These are some of the examples. India health tech startup Cure AI, when they were starting at that time, I was working with Niti Aayog. I got connected and they wanted to pilot their X-rays digital district. So you see that how the youth people who came in now, they have perfected the X-ray chest scan for TB, lungs and stroke. They have already supported more than 15 million patients every year across multiple countries. Platforms like Healthy IFI are working with global pharma companies to provide digital coaching and support this. Previous speaker also mentioned about the use of the AIs in your medical education. We see startup using wearables to monitor. This was also mentioned by the previous. I usually had a chance to hear the previous speaker. They have also mentioned about the using wearables to monitor high-risk pregnancies as well as the other medical conditions. The common thread is young teams using digital tools solving India's health problems with global resilience. If we talk about the skills required for the future health workforce, let me list out some of the skills which would be required for this. One of the important thing is data literacy. That means the person should be able to read and question the dashboard, not just as filling the registers or just as a consumer. I usually always been telling my consultants, others that you should be creator of data, not consumers of data. And many of the more than 95% people, they are consumers of the data. We should see ourselves data creators. Basic understanding of AI and ML, not to become a code models, but to understand their strength, limitations, and use. Public health and the systems thinking, how one interpretation affect the entire system. Human-centric design. Then designing solution that ASHA nurse patients can actually use, not the system. You people who are using at the system at the front end, who are the cutting edge of the whole public health system. We have to think that from that perspective. Then ethics and data protection, knowing what is responsible use of health data in this. These skills should become the basis as a stethoscope and sphygmomanometer for the next generation. Then if you talk about the education and the training needs, these are the education and training needs. It has been mentioned how we can utilize it. Curricula in MBBS, MD, nursing, and allied must mainstream digital public health and health informatics. In our PSM classes, in the community medicine textbook of PSM, we have a health informatics chapters. But this is a specialized job. Now you see that how we invest our time and energy in understanding the use of digital health and the public health informatics. The other thing which we have been pushing is the public health management cadre and programs by PHFI, APSM, other institutions. They can embed the modules of digital data, health use, and health tech innovations. We should encourage youth residencies in youth residents in the use of digital startups, innovation, cells in governance. We see that can we have a thesis give a thesis to a youth and say that we find a digital solution for any of the problems which are there. Then interdisciplinary mentorship, we see that how we focus, we can have regular hackathon challenge grants where the student techies and public health professionals solve real health problems. Now you see how the IITs and others, they are partnering with the medical colleges and bringing up solutions, the digital solutions for this. Other thing which I have mentioned about that the data-driven governance, how I have mentioned two use case, how we are using the data for planning. The other third example which I'm currently working is the IPHS gap assessment. Now we are having the data of all 210,000 facilities. Now in the coming PIP, the project implementation plan cycle, most of the states have been asked to use this data for identifying the gaps and asking funds for fulfilling these gaps. So these data dashboards are there, and we know that where to build, where to post the staff. That kind of inputs are already available with that. Besides that, in the National Ambulance Services, you see if you go to any of the command centers in the state of Tamil Nadu, Goa, or any other place, you see that the tracking of the ambulance happens, the response time can be also taken. Similarly, for NCD and RMS's dashboard, the new portals are coming. You can always help identify high risk blocks, low coverage pockets, and service gap. That kind of thing is there, so that we are generating evidence for better budgeting, better planning, and better outcomes. This is where the digital and the big data becomes cornerstone, not just reporting formats. We have to see that how the decision making happens at this. At the national level, the digital data guides policy. At the state level, dashboards can drive budgeting, HR deployment, and program review. At the district and the block level, medical officers and CMOs can use data for micro budgeting, outreach session, VHSND, and other things. At facility level, managers and other things, they usually can use this data and work on improving the quality of that particular facilities. But these are not there. There are some use cases also which are there. The predictive analysis of outbreak, which has been mentioned by previous speaker also about the predictive medicine, precision medicine, the predictive analysis using syndromic, because when we had that Vision 2035 document on the surveillance, we have predictive that we would be using predictive analytics as well as the electronic health records for monitoring and doing the surveillance activity and managing the outbreaks. The AI triaging in the emergency services, it's a tool which is already happening in some of the states, so that we can pretty quickly prioritize and guide the pre-hospital care and decide the right facility for referral. This is happening. It's not that just a theoretical thing. This is happening. Tamil Nadu is a very good example. You see, they know which are the patient. The pre-hospital care has all been managed through AI triaging. The GIS mapping for ambulance is MMU is there. The digital claims analytics under the insurance scheme. Now, to address the delay in the claim settlement, now they are using an algorithm, which the AI tool, in which 80% of the claims are now automatically processed based on the AI algorithm and other thing. Only 20%. You go to an airport now in Delhi, where the new scanner machines are there. Automatically they will scan, and the things which are detected to be subjected for secondary scan, they are already sorted out, and it goes into other other rope it goes there. But there are many challenges which we should not be ignoring. So first is the digital divide. That's a major important thing. Not everyone has smartphones, stable connectivity, or digital literacy. We must design for the last mile, not for urbanness. When we visited recently Assam for the CRM Common Review Mission, when I was leading a team there were many apps which were there. The beautiful app was given, the mobile set was given, but they were not able to use it because the internet problem was there. We have to see that whenever we are factoring and making a digital solution, we have to factor the last mile where the availability of the internet and the understanding of the person for using that app would be more or less limited. Privacy and security, health data are extremely sensitive, consent interpretation, role-based access, and this. Though we do have now a policy coming in place, but we see that that's also an important aspect we should always factor in when we are designing or when we want to do this thing. We should not be ignoring this. Third is the algorithm bias. AI models trained on unresponsive data can misdiagnose or underserve certain groups, women, tribal, this. When we were working and we were piloting that COVID-19, apart from that, when we are using the AI tools, they hallucinate. That means they give you perfect, the AI tools for generating the research paper, they give perfect thing, all the things, but you always need to cross-check what the AI is giving you, so that misinformation, other things can be taken care. I don't know, because the output which we are getting, even after having a good prompt, the AI tool usually has to hallucinate and give you the user perspective. You are thinking in one direction, it will try to just amplify your thought process in that direction, and it can give information which can hallucinate hallucinate information. The other thing, the last few slides only, other thing which we not miss is the human in the loop. Technology should strengthen, not replace care. ASHA, A&M, medical officers, specialists, program managers, data managers, they remain at the heart of the health system. Digital tools should reduce the burden. Automatic calculation, decision support system is all there, but everybody talks that they want to do it, but they want to create a system which is simple at the central level, but as a result of making simplification, they try to complicate the things that this. As a result, things will not work. We have to always keep these people in the forefront when we are making any digital solutions for them. Youth working in health tech must embed ethics, empathy, and usability into design. Talk to nurse, ASHA, the patient, not only the server. The biggest example is the Tata Consultancy when they designed the AIM software. They could not use that software because they have not spoken to the end users. After they have spoken to the end users, all the glitches and other things were rectified, and now they are having a very good software there. The best app is not the one who uses with most features. It is the one that an A&M at the remote center can use with confidence, even when the network is patchy. That means you have to always see that how we embed these kind of things in our designs. Now, if you want to see India as a global health tech, we should see that digital public infrastructure like Aadhaar, UPI, CoWIN, ABDM, they are now being discussed as model that other countries can adopt. We have a strong base of over 10,000 healthcare startup, a growing pool of engineers and public health professionals, and a track record of delivering at scale. But we see that how we can utilize the AI-driven companies like Cure AI and other things for our health, for our public health services. This is not just because that means India has developed so many tools and it has been exporting so many tools. But we see that it's how we can collaborate with the people who require the similar kind of solutions. That's why the South-South collaboration, the digital public goods and sharing of tools for universal health coverage in these countries also becomes very important. Now, the Vision 2047, what we want to see, when India completes 100 years of independence, we should aspire, because at that time, most of you would be at your prime of your careers and you would be at the helm of affairs. Some would be leading as director health service, some would be professor head, or some would be director of AIM, some other places. What we would like you to see, because at that time we won't be in the working space. So we said we want to see a fully integrated digital health ecosystem where the data flow, follow the patient securely with consent. Preventive and personalized care supported by AI but guided by human judgment. Resilient climate-sensitive health infrastructure with digital early warning systems for heat wave, floods, outbreaks. Why I'm saying heat waves, floods, and outbreak? Because these are all related with climate change. A workforce where public health, clinical skills, and digital are combined in every district. An ecosystem where Indian health innovations, products, platform standards are used not just in India but across the globe. But in short, a future where a tribal helmet, urban slum, or a metro hospital can all benefit from the same digital backbone adapted for their needs. So I think the future is yours, and you see that how you can deliver it. These are my 5 messages for all the young leaders.
Sir,
One is be
sir,
curious and keep learning.
Sir,
These are last
sir, with due
2
respect,
slides also.
we would just like to request you, sir.
Yes,
to
yes.
discredit.
This is my last slide, I think so. Yes. So be curious. Digital health is changing fast. AI genomics, IoT new regulation makes lifelong habit. Built for Bharat, not only for India, but designed for small screen, low bandwidth, multiple language, low literacy, use of data responsibly. Data is power. Use it with humility. Protect privacy. Never forget there is a person behind every data point. Collaborate across discipline. Then innovate with compassion. Remember that at the end of your algorithms, you are the human beings. But these are the other things. This is a call for action. So what you can do from tomorrow, join the national digital missions, develop new tools, apps, predictive models, work with government, startups, and academia. Wherever you can sit in the system, you are the bridge between digital data and the decisions. So to end, so digital health is not about technology, it's about people. We see that how we can innovate, how we can talk about public health along with this so that we can create a new health story. I thank you. Thank you very much.
Please give sir a very big hand. Sir, we from the organizing team, we are very deeply thankful to you. Despite all your busy schedule, you have made time. Despite all the glitches of the flight, your inability to come to Goa, we would have loved to have you offline, sir. But thank you very much for spending your valuable time and guiding all of us here. Can we just take one question, sir, because of constraint of time?
Yes, yes. Please.
One question from the audience, if anybody would like to ask. I think all of them have understood your explanation very well, sir. Please give sir a big hand once again. Thank you very much, sir. God bless you.
Thank you, Dr. Madan Gopal. We are disheartened you could not be here with us today, but we are glad that you could connect with us digitally. I now request Brigadier Dr. Kunal Chatterjee to felicitate our chairpersons for the first keynote address. Dr. Manish Kumar Singh, Professor, Department of Community Medicine, RM, LIMS, Lucknow, and Dr. Jagdish Kakodkar, Professor and Head, Department of Community Medicine, Goa Medical College. Thank you, dear chairpersons. I request the chairpersons to kindly continue to be on the dais as we move on to the second keynote address for this day. The speaker for this second keynote address, Surgeon Commodore Dr. Saugat Ray, Professor, Community Medicine, Indian Naval Hospital Ship, Ashwini. And the topic for this keynote address is From Data to Decisions, AI-enabled electronic health records for effective chronic disease surveillance. I now request Dr. Aparna to welcome Surgeon Commodore Dr. Saugat Ray onto the dais. Thank you, sir. I now request our chairpersons to start this session.
Respected Dr. Saugat Ray, we are very privileged to have you amidst us, sir. Just to briefly introduce, sir, he has a very vast biodata. Dr. Ray is a MD in Community Medicine, PG Nutrition at NIN Hyderabad, PG Diploma in Hospital Management. Presently, he is the Principal Medical Officer at the Naval Dockyard in Mumbai. I first remember meeting sir when he was here for EFICON 2023. And he is a professor of community medicine at the INHS Ashwini. Sir has a WHO fellowship in epidemiology and biostatistics from Thailand. He is member of the IPHA, IAPSM, NSI, EFI. He has 12 years as a professor and a UG and a PG examiner as well as PG guide. Sir has been the PI and a co-PI in 8 AFMRC and 2 ICMR research projects. Sir has been the editor of the Journal of Marine Medicine for 5 years. His areas of expertise include artificial intelligence in healthcare, nutrition, literature search, and medical journalism. With 78 articles in index journals with over 500 citations, sir has a H index of 12. We are very eager to listen to you, sir.
I now request our chairpersons to honor our second keynote speaker for today.
So we have our President-elect, Professor Atul Kotwal sir also joining us for this session, and I would request the organizers kindly send the link to him.
Yes, sir.
You can pass on to me as well the latest. Yeah, that link is not working, you see.
Distinguished colleagues, esteemed guests, postgraduate students here. I don't think there is an undergraduate student. There are? Okay, so please, a very good morning to all of you. At the outset, I would like to thank the organizers to have given me this opportunity for this particular keynote address, which is very much to my heart. And it's my proud privilege to address you today on a subject that is actually sitting at the intersection of modern medicine, technology, and public health. Now, this is my roadmap for today. I will try to find out the crisis which is there for managing the chronic diseases. So we'll try and understand the epidemiology a little bit, burden and the gaps. Then we'll go into the solution which I'm trying to bring out, and that is a patient-centric is important. AI, that is artificial intelligence and electronic health record narrative, evidence integration, and real-world impact. Then we'll go into the how to implement it, the limitations, challenges, and the safeguard. So the issue we all know, and it's almost 10% of the people adults are having diabetes and 10% pre-diabetes. The concerning thing is almost 50% are undiagnosed. Similarly, we go to hypertension, we find the same numbers, and these numbers are staggering. Diagnosed 37%, treated 30%, and controlled 10%. What it means is that the real crisis is not the prevalence. It's the patients that we are losing at every step. So there are some gaps. So there are some gaps in this particular care cascade where non-adherence is very important. Almost 40 to 50%, so there are irregular medication used by the patients. Some stop early, maybe because of financial issues, or otherwise also. There are lack of reminders. And then coming to suboptimal therapies, not going much into it, but yes, it is important. There are incorrect uses of drug combinations, which are very important these days. insufficient dosing, not using organ protective medications are coming up in a very, very big way. If you see SGLT2 inhibitors like the empagliflozin and GLP-1 semaglutide. Then coming to self-monitoring by the patients, again, irregular monitoring of HbA1c, blood pressure, then inconsistent follow-up appointments are very important aspects. So what do the patients get? What do the patients understand and actually what they need? Is suppose they get a lab report, which means, which has given him HbA1c 8.2. What does that mean? Creatinine in 2.8. Am I okay? Should I do something? But what actually they need is your sugar control has been slipping for the last 6 months. That should be the message that is given, that should be given to him. Like in a personalized context, at your present creatinine level, you will have a major kidney problem. Should be known to him. Now, these 3 lifestyle changes worked last time. Want to try again? Helps. So a message helps if all accessible in their phone, in their language. What are the different types of chronic disease patients? 3 types. One are the high-risk phenotypes. They have long-standing, poorly controlled diabetes or hypertension, multiple risk factors, early organ damage, or strong family history. Then there are some who have delayed recognition, no risk scoring, follow-up is irregular, and they continue to be in high-risk status unnoticed. And there are some patients with preventable complications. They are not flagged in time and not treated in time. So just giving you an example of the 3 patient archetypes and why they are failing the current system. Patient A, I know my numbers, but I don't know my story. I've been having diabetes for the last 5 years, visiting 2 to 3 different clinics. Never see the trend. HbA1c was 7.2, now 8.5. I don't know whether my kidney function is deteriorating. His eGFR is come down to 62. So system outcome, what happens finally to this patient? He develops CKD and discovers at a crisis stage. Patient B, he's been told to manage diabetes, but he says that I don't know how to do it. He takes 5 medicines, different types of combinations, prescribed by different doctors because, again, second, third opinions are also very common. So he doesn't know which drugs they are doing, which drugs are doing what, which combination is actually reducing his risk. System outcome, poor adherence and uncontrolled disease. Patient C, I want to prevent, but I need proof it matters. This patient is motivated to change his own lifestyle, but he doesn't know what to do, which diet, which exercise. He doesn't know whether he's actually getting better or just trying. Outcome, he gives up after 3 months, no feedback loop. Coming to the patient care, which is there presently in vogue. So it's mostly reactive. The diagnosis is mainly done during unrelated visits. Inconsistent protocols, very common. Minimal standardized guideline adherence is there. I mean, I'm not saying is very common, but it's there. Tracking definitely is less with HbA1c, BP, lipids. It's rarely analyzed systematically or longitudinally. The suboptimal combination is actually a very important understanding that very less use of combination drugs, especially for diabetes and hypertension. And this high-risk phenotypes are also important. Now, what are the challenges? The first challenge is the data fragmentation challenge. Patient information is scattered instead of a coherent story. There are discharge summaries, prescription slips, lab portals, imaging systems, SMS, WhatsApp, photos, wearables, and even paper files. We heard a very lucid presentation just before this mainly on EHR. Sir had told you everything about EHR, including ABDM, which the government is trying is basically EHR based and the government is trying its best to get all the hospitals on board. But there are huge gaps. So what's happening in reality is the population level surveillance cannot reliably track who's controlled, who's deteriorating, and where interventions are falling. Again, like ABDM or any other softwares which have been talked about till now, is mainly on a software. We have not come into the analysis part. So then there is, of course, the clinical decision support challenge, where the clinicians are overwhelmed. There are many patients who are coming, and at times, it's very difficult to give 100%. So like even my flight was cancelled yesterday, and I came today morning. I'm feeling groggy, so I'm not able to give you 100%. So I was trying to present a good presentation, but I'm not 100% fit because my brain is confused. Then you have a fight with your spouse, and you come to the clinic, the doctor I'm talking about, again the brain is a little bit confused. So there might be some errors. And it is very common, and the results are that 1/3 of the decisions, clinical decisions, they require a correction after a secondary review, or when you go to when the patients go for a second consultation, or they come for a review. So medical errors, but important thing what I'm trying to bring out here is that these errors are not inherent. They come from an incomplete information. So what is the solution? The solution possibly is, which we have been thinking of and which we have been discussing, is to convert the unstructured EHR into structured, actionable intelligence. It's not only converting to EHR, which I'm now trying to bring out, through artificial intelligence, NLPs, that is natural language processing, and LLMs. I will use a little bit of technical jargons, which I'll try to explain in the presentation only. So as, again, I was trying to bring out that whatever might be the confusion in the brain, we all are humans. So we will not be able to always act 100%. Whatever might be our challenge, but because of our experience, even the doctors, the clinicians, because of their experience, they always try at least to do the right thing. AI has data. The problem is the patients have the WhatsApp university. What we have to do is, in future, to balance all three. And this talk is about AI in healthcare. Definitely, yes, is there everywhere, but I'm definitely not proposing to replace anyone. This is about empowering everyone with better information. So what is this dynamic EHR? So what I'm proposing is a dynamic EHR. And this dynamic EHR is going to monitor disease and finally control disease. So continuously, the input should come from the patients and the doctors, where in a particular app, the lab reports, the case sheets, and the prescriptions and all EHR materials, structured and unstructured, can be uploaded. It can be passed by intelligent systems like LLM with OCR. So it can be scanned, even unstructured data can be scanned through OCR. Extract the unstructured data into structured field by NLP. That is the function of what natural language processing does. Then this model can predict risk. Very important. Now the models estimate the probabilities of the disease progression and the complications. So if you see the problems there, we are trying to now liquidate them. Automatically, they will give alerts. So they will flag HbA1c as elevated. You are having a possible resistant hypertension. You are having a eGFR decline, which is a bit rapid, and you have missed follow-ups. So the population surveillance can also take place simultaneously, where you can aggregate the dashboards for control rates, trends, and hotspots. So what finally, if we do something like this, what finally is delivered to the patient it's number one is real-time trends. Now they will say, the model will say that your HbA1c has been trending, has been increased over last 6 months. It's usually should be around 7.2, but now hovering up to 8.5. Then they will also say that you are pre-diabetic and also having a kidney disease. So you need to change your diet. So maybe personalized DASH diet can be given. Warning alerts. So your recent blood pressure readings have been more than 5 to 10 millimeter higher than usual. You should schedule a doctor appointment. Personal insights, your weight plus sugar control are correlated. So when you exercise regularly, your HbA1c will drop. Your adherence to medicines is 85%, and it's an excellent. So here the patient is seeing their story in their language, in either their phone or in their website, or in the particular website. So a similar kind of thing has been made by Stanford Medicine, which has come up with this chat EHR, which now, see, this is a difference. This is AI which helps the doctors talk to the patient records. So this is a LLM bot that uses LLM, NLP, and RAG. I'll come to all these things. And this is specifically for doctors. How do they do it? This is the healthcare data. The healthcare data is now put into, or ingested as they call, into the medical foundation model. They have the reusable components. So they can do question answering, chart summarization, image analysis, or labeling, risk stratification, and finding similar patients. And this is NLP, which will help in human AI collaboration. So a similar kind of thing had come to our mind, and so I'm a doctor in the Occupational Health Center, which has got around 10,000 industrial workers. So we thought of doing a patient-centric AI model, which we are calling it Asta, kind of a similar thing where we have got user engagement of users, doctors, and administrator dashboards. And whatever I told you is got a chat bot, got a medical summary for the user, recommended diet plans, exercise plans, health summary. The doctors will be able to analyze the medical report. They can recommend health summary. AI will recommend some health summary also, which the doctor might or might not take it for the clinical decision. The administrator also will be able to analyze the health report across all the departments of that particular industry and take necessary public health action. Now I'll just quickly tell you what are the technology behind. I mean, I think a lot of people, all of you have been talking about this AI. Now NLP and LLM, that is natural language processing, and LLM, what they do is they ingest this unstructured record to structured timeline for each patient. So can someone know about what is GPT full form? Anyone? Yeah. Okay, okay, just can you tell me, so what is ChatGPT a LLM? The GPT is the LLM, ChatGPT yeah, okay. So that is what exactly, I mean, some of you might be having this confusion. So he's from the field, so there's no point telling him or anything like that. So ChatGPT contains all the three elements: NLP, LLM, and I'll come to RAG, right? RAG is something very important and interesting also. But ChatGPT undergoes hallucinations, which have already been spoken about. So what we have done is, we are not using ChatGPT. We are using another LLM, which is a medical grade LLM. And we are training it on high quality resources. And we are putting standard codes in it. Knowledge sources are the standard ones. And then we will use this for generating the different recommendations. RAG is something which is a very interesting thing and should be known to people, is that it optimizes the performance of the LLM. So it pulls the most relevant guideline passage from, say, the national guidelines, plus they take the patient's structured data, and then the LLM will generate an answer conditioned on those which are retrieved with citations. You understood? I mean, so that RAG is something which should be there, introduced from the time RAG or an advanced version of RAG has been introduced into ChatGPT, say 5.1 or Perplexity Pro, the hallucinations have reduced. Am I correct? I think that is what everybody is saying. So this is the system architecture which we are following. It's got almost everything which is required, including the most important thing is security, which is also being taken care of. Now, if we do this, what are we going to achieve? So this is the integrated recommendation which we are planning, we think we are going to achieve. The beta version has been launched, so we have got around 400 diabetes patients who have been put into the system, and we are trying to train the system more and make it more robust. So a patient who's coming from, who's a 55-year-old male with HbA1c of 8.2, with a blood pressure of 145/92, eGFR 65, so is less with albuminuria present, AI recommendation will be consult your doctor. You might have to include ARB plus CCB. This is all you might have to include. And you might have to include SGLT2 inhibitors for renal protection. Also, they will suggest nutrition guidelines, exercise guidelines, and will tell the patient to monitor their HbA1c, albumin creatine ratio, BP home monitoring, etc. So that is what we are trying to do. And here, just to summarize, the LLM is using the deep learning to understand the complex medical text and create new content. The NLP is enabling the medical AI to interpret and produce human-like language. The RAG is helping to retrieve accurate information, and together they allow the medical artificial intelligence to generate summaries, write documents, and create educational material. So what is the impact? So we have got two types of impact. One is the patient and one is the population level. So for the patient level impact, we have evidence-based recommendations, which is integrated into the workflow that will be for the doctors and for the patients. Then tailored messages for adherence, lifestyle, and follow-up reminders. Then risk stratification, so early identification of the high-risk patients for proactive intervention, and personalized plans for customized therapy, nutrition, and exercise. So how does it look like? The patient empowerment and self-management. The patient is now understanding from passive recipient, being a passive recipient of a lab result, to active participant who understands their disease improvement or deterioration. The behavior change, that is from a generic advice of exercise more to a personalized evidence-backed insight. So your data shows that your walk has reduced your HbA1c. And of course, early detection of improvement might be there. So like your kidney function has dropped more than usual, you need an urgent appointment, or there is a complication which has been found, a CKD progression or uncontrolled hypertension. Impact 40 to 50% reduction in preventable emergencies. In the population level, there is a real-time surveillance across a setting. Targeted interventions can be carried out like red flags, moderate drugs, public health campaigns, and research acceleration and outcomes tracking. So this Dr. Mohan's clinic, I think, is having a EHR-based diabetes record for the last 15, 20 years. Though they have just started doing AI, but it's huge, and it gives you huge amount of data for research. And of course, data-driven research allocation. So what are the limitations? As I brought out, that hallucinations are one of the most important ones, and they can invent details, omit critical findings. Quality is important, garbage in, garbage out. You all know, so you put the good garbage, you put a good quality material, you will get a good inference out of it. Verifiable sources, yes, outputs always need a clear citation. Sir had already brought out this human in the loop concept, where humans should retain authority to override. That means the doctors, whatever might be the confusion or brain suboptimally working, because of the clinical authority which doctors got, the retention of they should retain the authority to override when outputs conflict with the clinical context. But the challenge, that one big challenge, is the adoption by the doctors, which have been found all over the world, that are not able to adopt AI or EHR. But so how to go about it? A return on investment is one. ROIs are the most important thing. Provide training. Multi-central trials are required definitely for validation. Any model has to be validated. Vulnerability assessment against cybersecurity. This DPDP Act, which has recently come, again on patient confidentiality. So informed consent is one thing important. UI/UX, so is a display board which should be very, very familiar to the patients, and they should be able to have a multilingual support. So to conclude, I would say that we are possibly moving towards, not only till now it was evidence-based, now it should be intelligence-based care and control, evidence and intelligence-based care and control, where EHR analysis anchored in national and international guidelines will offer a realistic path. So from the fragmented records, passive patients, reactive crisis care can move to a unified narrative, engaging the patients. The whole system which I am talking about is engaging patients and not only doctors. All models till now are focusing on doctors. Proactive self-management is again what I'm trying to bring out here, and thus can control chronic diseases. So I have finished. So the road ahead is clear, but we should know how to drive.
A very big
Thank
hand
you.
to sir for a masterly presentation, worthy of a keynote address. Our National President-elect, Dr. Atul Kotwal sir, is online. May I request Kotwal sir to kindly give his remarks. Kotwal sir, please. Can you just admit? Yes.
Thank you very much for this. It's been an honor to chair this session along with you too. So I would request both my co-chairs to first provide their comments, then I'll come in towards the end.
Thank you, sir. It was a very informative presentation, and I hope the audience should have been benefited with it. Even the session by Madan Gopal sir also had a lot of new things which we can do, like he talked about innovation fellowships, hackathons, and youth residencies in digital health startups. And I also liked your presentation, how you are giving personalized care using the digital technology. So thank you so much, sir. We have lots to learn, and maybe in the lunch break, some youngsters who are interested on working in this digital health can just discuss it with sir. And if you have any suggestions, you can always put it forward to us. What we can do as an association to strengthen your capacities and at the same time benefit the society out of it. Sir, over to you, sir. Kotwal sir.
Thank you. I must thank the speaker for an excellent presentation, and I know him personally as a friend and a colleague since many years. And Sergeant Commodore Swagat, I don't know if you are aware, I missed the part where his CV would have been presented. I joined slightly late. I think it was the second slide when I joined in. He's been, ahead of his time. Not only now, we have been talking about, ABDM. We've been talking about IHIP. We've been talking about CDSS, integration of all the portals. But to have this kind of approach where you are looking at the artificial intelligence, to create this kind of ecosystem going ahead. And I'll give you an example. In 2008-9, when we started research methodology in MUHS, which later on was picked up by the MCI and subsequently NMC and DNB and everyone, and FMC was the initial, it was the brainchild of that. And there's a time when we started conducting these workshops, we just, asked them that take a session on review of literature. So that time review of literature, we had a different approach that time. It was the basic approach when we saw his presentation. It was totally unique. He had used all the internet resources and all, and the search strategies. It was unique for everyone, for all of us also in the field who had been working in epidemiology and research methodology earlier. Similarly here now today, I'm sure the previous speaker, I couldn't attend that session as I had a prior commitment, would have spoken about the digital initiatives, ABDM and all, and even IHIP definitely would have been covered. But now to link all that together, that how it can be further utilized for the community. I'll just have few comments on Swagat on your presentation. Firstly, excellent. It is very, very topical, and it was and as the audience would have definitely made out, it's not only theoretical. It's based on the actual work which he is leading, and which can be subsequently replicated and upscaled. Going ahead, my request is if you can also look at preventive models in this. Why only talk of patients? Look at entire community, how they can be given this information that okay, these are your values and this is what your lifestyle is and this is what your diet is when they can feed in the data, and this is the advice being given to you. IHIP PHR linkage with this subsequently is very important. One issue which you mentioned about the human resources for health, the change of mindset. I'll give an example. We were doing a continuum of care implementation research project when I was ED and HSRC along with WHO CRO. And in 13 districts, we enabled CDSS in NPNCD portal. And from all 13 districts, we faced vehement opposition towards CDSS. Even though there's a option, very easy option was available to ignore the CDSS. The doctors had that power but still they didn't want to do that even that one step. Because firstly, they didn't want to use digital prescriptions. And so they had given to nurses. Nurses said it will save a lot of our time if CDSS is not there. We can use the NPNCD portal at CHC or DH, but we will not use CDSS. So we had to stop all that. So that's where we need to now look at how we can change the mindset, that capacity building, and also the HMIS usage in all the facilities. All this is possible once HMIS is fully functional, and for that all HRH have to be on board, the technology has to be there, infrastructure has to be there, and linking of these with the IHIP, which is ongoing. And yes, excellent. As usual, Swagat, thank you very much for this presentation. I'm sure a lot of young minds in the audience who would be probably knowing much more than people like me now about artificial intelligence would have gained and would have come up with certain ideas, and which they would definitely discuss with you during the tea break and lunch break. And going ahead, I think we would be very happy if you can share your subsequent success also on this model, and which can be discussed at a national level in some meeting and all, where we can look at how it can further be integrated into IHIP and even PHR of ABDM and all. Thank you very much once again, and thank you to the organizers for this opportunity. Thanks a lot.
Thank you for all the good words, sir. Always indebted to you.
Thank you so much, sir, for joining at a very short notice also. And we are very pleased to listen to you. Thank you, sir.
Thank you. Bye-bye. Jai.
Thank you, dear chairpersons and speakers, for this wonderful session. And thank you to Dr. Major General Professor Atul Kotwal, President-elect IAPSM, for joining us online. I now request our chairpersons to present a memento and a certificate to our second keynote speaker for this morning. I now request Dr. Sarit Sharma to present our chairpersons for this session with their certificates. The next session for this morning is on digital health intelligence, navigating ethics. I request Dr. Aparna to welcome our chairpersons, Professor Dr. Sarit Sharma, Professor Dayanand Medical College and Hospital, Ludhiana, and Professor Dr. Nishant Krishna K, Professor Community Medicine, Father Mueller Medical College. I ask our chairpersons to kindly take the dais. The speaker for this session is Dr. Lisa Sarangi, Professor and Head cum Vice Principal, Community Medicine, High Tech Medical College and Hospital, Bhubaneswar, Orissa. Dr. Lisa Sarangi will be joining us online. I now request our chairpersons to start this session. Chairpersons and speaker kindly note the session is for half an hour.
Very good afternoon to all present, and very grateful to the organizers for making all the last minute adjustments and making this event possible. And I can see quite a few number of people still, after all those problems, they are able to reach here and attend the session physically, and even grateful that there are a lot many people who are joining it online. So the next session is digitization, data decisions, that is youth at the forefront of the health talk. And Dr. Lisa Sarangi will be the person who will be delivering the talk. Well, ma'am is a professor and head of the community medicine, and she is also vice principal at High Tech Medical College and Hospital, Bhubaneswar. She is a fellow of Royal School of Public Health, London, life member of many associations, including Indian Association of Preventive and Social Medicine. She has WHO fellowship on COVID-19 recovery and immunization. Won many awards, including Seva Ratna Samman Healthcare Academic Influencer Award. Professional experience of more than 19 years in teaching and postgraduate guide, medical education coordinator, member secretary of the IEC committee, and also active as an editorial board member in many reputed journals. Her areas of expertise are ethics in health research, medical education, mental health, geriatric health. She has more than 20 research publications. So I invite Dr. Lisa Sarangi to please present her talk now.
A very good afternoon to one and all. Respected chairpersons and all senior professors and everybody who is out there, thank you for giving me this opportunity. So I can see that I have half an hour time, so I'll be very precise in my presentation. So I'll start my screen share. I hope it's visible. Please let me know if it's visible or not. Is it visible?
Yeah, it's visible, ma'am.
Okay, so as I belong to the land of Rasgulla, we would not like our Rasgulla recipe to be known to the entire world. Similarly, digital health intelligence, the digital data, that ethics needs to be kept in privacy. So we will know about navigating ethics, how ethics needs to be maintained in digital health intelligence. So we will walk through the foundation of digital health, the ethical principles and the governance, the challenges, few case studies, and what's the path forward. Now, there is a huge data that's being trained to the AI models, and there is telemedicine, which is predicting, transforming data, which is diagnosing, and that is how we are taking public health actions. And this machine learning, through machine learning, the AI tools are being trained. We are using big data, huge amount of data, and we are training the AI tools. And that is how forecast is being done about different diseases, about different epidemics, and real-time dashboards are created. It's also being used for screening, triaging. But the crux here is that we need strong ethics to regulate these huge data or the AI tools. Because these tools, they are influencing the clinical decisions. Now, there are certain doctors or public health personals, they are completely using AI tools like ChatGPT or any other AI tools to influence their decisions directly without even using their own clinical acumen. So that can actually cause error. during their diagnosis, and it will lead to inequity. And this needs to, and we need to protect the data and privacy, and the patient need autonomy over their data. So, and to build a trust in the patients as well as in the doctor fraternity, ethics needs to be built up. So, power of artificial intelligence, we need to prevent human pain rather than to cause war. So, as we all know, the core ethical principles are autonomy, beneficence, non-maleficence, and justice. But in AI, there is one more important ethical principle, and that is accountability. Autonomy, beneficence, non-maleficence, and justice, we all know, because these are the core principles. But accountability, where the developers, the clinicians, the hospitals, even the government, we must stay responsible. So let's go one by one. So when it comes to autonomy in digital health, now the patients, they should understand how their digital data, how their data is being used. So basically, when we are feeding the data of a patient, they should give a consent, and that should be a clear, simple digital consent. Now, when I also entered into this online, I give my digital consent that yes, my data is going to be recorded. So a simple digital consent is now mandatory. So a patient needs to also give a simple, clear digital consent, but that's not enough. He or she has every right to withdraw or opt out from that data sharing. There should be transparency, and that leads to trust and further participation whenever in future he wants to participate in any research or data sharing of his data at the national or the state level. The other two principles like beneficence and non-maleficence, like we know beneficence is it benefits the patient or the community, and non-maleficence means it does not harm the community or the patient. So very thin line of difference, like beneficence it benefits and non-maleficence means it does not harm. So AI should provide a clinical benefit to the patient, and this is possible only with a validation with the real world. And automation bias, now it means that we should not be, as clinicians or public health specialists, we should not be too much actively involved in totally believing what our AI tools are giving us a data. Like if the AI tells us there is a fracture, without touching the patient, we should not think that yes, there is a fracture. So that automation bias, over relying on AI tools, should be mitigated. And algorithms must be tested at the population level. And this is only possible through continuous monitoring. So research in AI is a very open, because at the end of my slide, I will be asking my young postgraduates are there, young faculties are there. AI research in AI is very promising, and you all should do research in AI. So this is only possible through continuous monitoring. This is possible. And the next is justice and equity. So the AI should not cause a huge divide either in the rural or in the tribal population, in languages, because in Northeast, and there are so many population where there is no AI tools in languages. There are some, like in Hindi we might get, but we might not get AI tools in some Northeast languages. So there should be regional languages must be interpreted, and data sets must represent diverse Indian groups. So there are certain guidelines, as I was telling you, ICMR, CDSCO, and DPDPA Act. ICMR we all are very familiar with, CDSCO and DPDPA. So one by one we will be going through very quickly. ICMR ethical guidelines on this AI says that human oversight is mandatory for all AI decisions. So human clinical decisions is the first and foremost thing. and it should just add to any AI decisions, and there should not be any black box algorithms. Now, what does black box algorithm means? Now, black box algorithm means that whenever there is any decisions made by AI tools, sometimes it just doesn't give any background now why it has come up with that decisions. Like there is a high chance of sepsis. If a patient is admitted to ICU, it just says that with the help of so many data, it will just give a prediction that there is a high chance of sepsis. But it does not say why there is a high chance of sepsis. So these are black box algorithms, and we should not trust these black box algorithms. And this is what ICMR tells us. So it should be more explainable and it should be interpretable. And these are only possible with field testing. So fairness audits are compulsory. There should be auditing of this data. And dynamic consent, as I was telling you, ICMR also talks about dynamic consent. Now, what does dynamic consent means? It means that when I give a consent means it's not full and final. I have every right to withdraw at any point of time. So special protection for vulnerable population, transparent reporting is also equally important, and secure storage of my data. CDSCO regulation for SAMD. SAMD is software that acts as medical devices. Now, I would like to highlight on this because there are software which acts as medical device, and they have been classified into class A, B, C, and D devices. And it requires evidence for its performance and safety, and it also requires cyber safety because of its ability to be hacked. And what are these risks? Risk A is with no clinical decision, which involves like a step counting. We usually wear smart watches which tells us about our steps, and there is no risk involved. But class D, where there is AI tools, AI apps which recommends cancer treatment, which has a very high risk. So where the risk is very high, it requires a safety test and an approval is needed, and a CDSCO approval is very strict in that scenario. That device approval is very strict. Then there is DPDPA 2023, which is Digital Personal Data Protection Act, and again there should be a consent for that. Whenever I'm giving my data to a hospital or to a doctor, I should be giving informed consent. And only minimal necessary data needs to be collected by the hospital. And patients have right to correction or deletion. If I'm a patient, I have every right. I can correct my data. I can erase my data. So a data fiduciary is any hospital or a doctor, and I have to prevent misuse of my patient's data. If I'm found misusing my patient's data, then I am liable in the court. I can be penalized. It could amount to crore, 1 crore. I am liable to a crore if I'm found misusing my patient's data. So security is of top priority. So there are certain ethical requirements for telemedicine also. So secure end-to-end encryption platforms are required for consultation. Now very commonly we use WhatsApp for prescribing. If some friend of ours may ask us to write a prescription, so very commonly we do write a prescription. So what is that? So recording only with explicit informed consent. So whenever someone asks us that I am having headache, what should I take? Please write a line. Should I write a prescription? If only he says that yes, do write, then only please write. Otherwise, it amounts to no consent. Doctors must verify patient identity, because sometimes someone else writes in the patient's for. That means the patient is someone else, A, and someone else is writing on behalf of the patient. Now B, patient is A and B is writing on behalf of A. So do verify that this is someone else. The patient is, you are writing the prescription for patient A only. and confidentiality has to be maintained, and do follow telemedicine guidelines, which is by MOHFW 2020. And I'm not going into the details of guidelines. I do not have enough time. Then there is Ayushman Bharat Digital Mission, which also says, talks about the federated system. Now, what does federated system means? It means the data stays with the owner. And there is a consent manager. Consent manager, the best example here is the Abha app, where there is a strong encryption. Only when the patient gives a consent, the hospital can access the patient's data. So a health ID will be required where the user gives permission and the health ID can be accessed. We will go through certain case studies where ethics is of importance. Now, how ethics is important in AI tools. Now, there was a study done in Stanford Dermatology AI study, where data representation was not done properly because AI was trained with lighter skin images, lighter skin tone. So when it was done in an Africa, the black people, so they were, since the images were uploaded to AI from black people, so it said that it was a benign tumor because it could not read. They thought it was a benign tumor, whereas it was a melanoma, and it led to a delayed diagnosis. So data representation is very, very essential. The case study 2 says it was on the South Africa's maternity early warning score, Muse score. Now, it's a very good predictive model. The Muse predictive model is a very good predictive model where a 28-year-old postpartum woman came with mild swelling and headache post-delivery, and the Muse predicted a high risk. Now, the result was it was a timely intervention that helped prevent eclampsia, ICU admission, and death. So this was a very good predictive model with correct training of the AI models. Case study 3. Here I would give you an example of what happened in AIIMS, New Delhi, where in 2022, AIIMS always maintains a manual mode because they don't over-rely on AI or on digital data. Since they had a backup plan of outpatient and inpatient data, they could immediately overcome the cybersecurity threat they had on November 2022. So it was immediately restored on the servers, the e-hospital data was restored and network was sanitized. And the last was a triage, flood zone triage AI, which was during a flood, all the elderly were over-triaged because it was over-representation of elderly, because we tend to think more about the vulnerable population sometimes, we think more about the children, women and elderly sometimes, and we over-represent them in AI. So they were unnecessarily, they were triaged more, and this resulted in mismatched and the resources were diverted more towards the elderly, and sometimes it led to more resource draining towards the elderly. So AI must match the context. So something about bias. So unrepresentative training of data should be really prevented, and ICMR requests fairness audit. So fair AI is safe AI. Let us talk a little bit on the cybersecurity threat. So ransomware, you all must have come across this term, ransomware, which could lead to shutdown of the entire hospitals. So, and this could lead to patient identity getting exposed. So cybersecurity threats could be minimized with data suppression, data generalization, data swapping, and noise addition. So data suppression is something like hiding or removing some sensitive data. Let's see for this example, where if a village has one HIV case, if that case is identified, then that would lead to stigma of that case. So in that scenario, instead of writing one HIV case, an asterisk or less than 5 cases could be written in. So there is a data suppression or a data generalization. So instead of writing exactly age 47, it could be written 40 to 50. Data swapping, so exchanging, like instead of writing one district's name, another district's name could be written. So swap the data. Or a noise addition, like blurring of data. We use portrait mode when we click a photograph. So in that case, instead of writing just exact 110 blood sugar, just 112 or 108. So by just making small random changes, the security is maintained. So public trust and acceptance is of vital importance in cybersecurity when the data is secured. So ethics is maintained, data is secured. Even the doctors start trusting AI tools. The patients, no doubt, they will also start engaging. They will start sharing their data with the public health personals, with us, with the doctors, with the hospital, and human in the loop approach, because once the public knows that it's the first check is the doctor, they are looking after us, and then they are taking help of the digital or the AI. So they are now assured that it's the doctor that they are taking care of us, instead of directly the AI which is replacing the clinical decisions. And continuous monitoring and surveillance is again very, very important in maintaining ethics. So a little bit on, whenever I'm talking of ethics, not talking about publishing is a big crime, because AI, nowadays everybody is using AI for publishing. AI is only allowed for grammar, structure and summarizing, and not allowed for data analysis and interpretation. And the authors are fully accountable for the content. So the research scope for AI in public health, it could be disease surveillance or outbreak response, health informatics, data analysis, preventive healthcare, diagnostics and screening, resource allocation efficiency, or any impact of climate change on health. So to conclude, AI should heal rather than harm us. So let us make AI our future, but responsibly, we all should take care of our patients, our public health system. So thank you. And this is all my references. Thank you. If you have any questions, so please let me know. So thank you very much. I hope I am on time.
Yes, ma'am, you are well on time, ma'am. The timer says you have around 9 minutes, 45 seconds left. Thank you, ma'am, for the crisp presentation. So to summarize, with great power comes great responsibilities. So digital health intelligence relies on AI, but ethics ensures safety. So the 5 core ethical principles must be followed, with greater importance on autonomy and accountability. Human oversight and explainability are mandatory, as we have been hearing since morning. There are many guidelines from ICMR, MOHFW, acts like that, DPDPA, which are there to regulate AI and artificial intelligence. Bias from unrepresentative data is a major threat, and AI must support, not replace, clinical judgment.
Yeah, you have very aptly briefed the whole session, and congratulations, ma'am, Dr. Lisa, for such an elaborate session on ethics in our not only use of AI, but also use of AI in publishing as well, which is a common domain for medical colleges and our young PGs, as well as the young faculty who are sitting over here. So this is very helpful. Thank you so much for such an insightful talk. Any questions? Because ma'am will not be here for the lunch, though she can have a digital lunch with us. So I think this is and we have about 8 minutes left. So any questions, if any audience has?
And that's one question over there.
Yeah, can you please raise your hand? Yeah. Can you please provide the mic over there? Yes.
Good morning, all. Thank you for this session. So my question is, since currently the digital literacy in our country is low, in that case, how can we ensure that we are actually getting an informed consent and the autonomy is preserved?
Ma'am, were you able to listen?
Yes, yes.
Yeah, please. Thank you.
Actually, there is whenever you hopefully you have seen whenever you are giving a consent, there is a box, and you have to tick that box, and then only you can enter into any questions or any other uh, uh, any site. Whenever you are going, suppose you have given your car to servicing, and they give you a feedback form, and then at the end you have to just tick a box that this response needs to be this is open for view, or this can be seen by all. So you have to give a consent in that box.
Yeah, and
So this
also,
is how consent can be given.
yeah. And also this again falls on the integrity of the investigator, because in the physical consent also, I mean, we can just go ahead with taking the things that yes, consent has been taken, but ultimately it is on us as investigators that we are actually following everything in letter and the spirit. So same thing, and I think will also apply for the digital thing. So it is on our
Yes.
conscience that we have to stick by the rules, and the consent means consent, and it has to be informed
Yes.
consent, and it has to be given by the person who is concerned. Thank you so much, ma'am. Thank you so much. I think, yeah.
Hello,
Yeah.
Dr. Lisa. Thank you for the
Hello, madam.
presentation. I have a question. Whenever a tertiary care hospital exists, they have a lot of data. So there are many other collaborators who ask for the data of patient record because they want to have it delivered to AI and get them trained to read the, like say, retinal scans or anything, any data is for that matter. How would you all go about trying to, do we have to have an MOU? How is data to be shared in this case? Or is it to be shared at all?
Without, madam, a very pertinent and a very important question, because without the knowledge of the patients, you should not be sharing their data to the even into the centers, because it's only with the knowledge of the patient you have to share the data. Only if they are giving consent, then only they need to be shared.
This is old data which is existing. So I do not know that time whether, this kind of a process was there, whether consent is documented. It could be just case records, ECGs taken, anything, reports basically which are there.
I think what ma'am is telling is when we are using it for these predictive models where we are using old patient data. So how can we share those data with the tech companies or whoever is doing these models?
Okay, but I don't think you should be sharing it with the tech companies, because DPDPA Act completely, it's from 2023. DPDPA Act is from 2023, and after 2023, you should not be sharing your patients' data just for the sake of training models, because they have said that without the consent of the patient, none of their data should be shared, because it's a federated structure. It's only with the owner, and that too unlimited data. It cannot be a complete, only that is necessary, that amount has to be with the hospital, and you cannot share the entire data with the whatever data you have. That much data at least you can share, not the entire data you can share with the not even with the center. So that is what is federated structure means. So you should not be sharing. That amounts to a crime. In fact, it amounts to a crime. You have to take the consent from the patient, and then only you should be sharing it. That is what is federated data.
Yes, absolutely, ma'am. Thank you so much for that input. And I'm sure it's very loud and clear to everyone now. Thank you.
Thank you, madam.
Thank you so much, Dr. Lisa Sarangi. Although we would have loved to have you here with us, we are glad that you could join us online. I request Dr. Himangini Shah to present certificates to our chairpersons for this wonderful session. Professor Dr. Sarit Sharma, Professor Dayanand Medical College and Hospital, Ludhiana, and Professor Dr. Nishant Krishna K, Professor Community Medicine, Father Mueller Medical College. The last session for this morning is on screening methods for cancer cervix. Which one to choose? I request Dr. Rukmita to welcome our chairpersons onto the dais, Dr. Yugantara R. Kadam, Dean KIMS Karad, and Surgeon Captain Dr. Rupi Chattopadhyay, Senior Advisor Microbiology, Officer on Special Duty at National Medical Commission. The speaker for this session, Dr. Pragati Chabra, Director, Professor, Department of Community Medicine, University College of Medical Sciences, Delhi, will join us online. This session is for half an hour. I request the speakers and the chairpersons to kindly make a note, and I now request the chairpersons to start this session.
Good afternoon to one and all. And at the outset, I would like to thank the organizers for having me here. And indeed, it's a proud privilege for me to be here because Goa Medical College is my alma mater where I did my MBBS from. So thank you, organizers, for inviting me to chair this session. So now to introduce our speaker for this session, we have Dr. Pragati Chabra. Thank you, ma'am, for joining us online. And we are indeed looking forward to hearing from you on this very important topic. Now, to talk a brief about Dr. Chabra, she is an MD in Preventive and Social Medicine, and presently she is the Director Professor, Department of Community Medicine, UCMS, New Delhi. And also she is a fellow member of FIPSM and FIPHA, and she has received several awards for her professional excellence, and she's an experience of over 31 years in this field. And her areas of expertise are nutrition, mother and child health, and women's health. And several publications to her credit, over 70 or 75 publications. So thank you, ma'am, for joining us here, and we are indeed eager to hear you. May I hand over to the co-chair, Dr. Kadam.
Yes, madam, you can start your presentation.
Thank you, respected chairpersons, for the nice introduction. And I would also like to thank the organizers for giving me this opportunity. In spite of our inability to be in this beautiful place, Goa, in person, we are at least able to connect to you online. So can I start, share my screen, please? Yeah. Is the slide visible?
Yes, ma'am, it's visible.
Chairperson?
Yes, ma'am, we can see the slide.
As stated, this is an important topic. Yeah, so I'll be talking about screening for cancer cervix. We all know we have made a lot of headway. We are talking about elimination of cancer cervix and screening being a very important part. We have many methods, and where do we stand? So I'll be discussing that, and I would be touching upon about the burden, then the natural history, because that is related to the screening. Talk about the risk factors in brief, what is the importance. Then, of course, our main topic, the screening methods, and what is the status of screening worldwide and in India, and what are the challenges we are facing, and we look forward to the way forward. So as we all know that globally, cancer cervix is the fourth most common cancer globally. And as per as the IRI figures, almost 660,000 women were diagnosed with cancer cervix in the year 2022, and it has a very high fatality. We all know that about more than half of them died. We had a mortality of about 350,000. And what is alarming is the large inequity, whereas the incidence is like when we compare the incidence and the death rate among the high, low and middle income countries and the high income countries, it's almost like 3 times the death rates, whereas the incidence difference is only about 2 times. So there's a lot of inequities seen in these figures. Like the low and middle income countries where it is a real problem can do much better. So let us look at the figures in more detail. So this is the figures of the International Agency for Research on Cancer, which shows that in women, it is the fourth most common cancer, the number 1 being breast, and the second is lung, and the third being colorectal. And when we look at the death mortality, we see that again, it's the fourth, contributing to almost 8% of all the cancers which were recorded by the IRI. And then, so it is a significant burden that globally we are facing due to cancer cervix. When we look at the figures in both the sexes, it is again the top 10. It comes both the incidence as well as the deaths are top 10 of the cancers. We know that it is causing a significant amount of both incidence and mortality, even if you look at both for persons, that is both men and women. So it's an important cancer and we know that it is amenable to prevention and treatment. So that's where we have to look at how we can detect and control this cancer. When we look at the burden in India, it is the second most common cancer, whereas it was fourth in globally. In India, it is the second most common cancer, only after cancer breast. And when we look at the figures, as many as, so it contributes to a significant burden of the burden by globally, like the proportion. When we look at the global, it was around 660,000, whereas almost 127,000 cases, more than 27,000 cases were recorded, and about a large proportion of deaths are dying. That is 79%, almost 80,000 deaths were reported. That is again the IRI figure, and the AIDS standardized incidence rate is considerably high at 17.7 per 1 lakh women years. And as stated earlier also, in India also the burden of the outcome remains poor as compared to the high income countries. And this has many factors, like there are delays in seeking care, the women are not aware of the warning signs, the risk factors, and what are the screening methods. So there's a lot of ignorance about this, that they don't recognize the signs or whether it can be prevented. There are screening methods. So that is what concerns us as public health personnel, that the ignorance is there. That we'll be considering in the subsequent slides also. I'll be talking about that. So again, looking at the figures by the IRI, we see that it is the second most common cancer in India, next only to, and a considerable burden, like about 17% of cases of all cancers among women were of that of uterine cancers, and again the deaths were about 18%. So it's a significant cause of burden of both cases and deaths in the country. It is indeed alarming. Again, when we look at the burden in both the sexes, it is number 3 among all the cancers in India. Second only to, third only to, we have number 1 at breast cancer, both cases as well as the deaths, while we all know oral cancer. So these are the 3 ones which we are also aiming at in our national program, NCD program. Also, we are targeting these 3 cancers for screening. Now, looking at the natural history of cancer, we all know that it is the human papilloma virus is the one which is responsible for almost 99% of the cancers of cancer cervix. And it is the at the squamous-columnar junction that it is identified. And the HPV viruses, HPV makes up, there are almost 100 types of these viruses, and of these, at least 14 are the ones so-called high-risk cancers, high-risk viruses which cause cancer. And the almost the HPV 16 and 18, they are together responsible for 70% of the cervical cancers. And HPV is a very common sexually transmitted infection, but most of it is resolved spontaneously and it causes no symptoms. But it is only the persistent HPV infection which results in the low-grade dysplasia, that is cancer in situ, and there could be low-grade squamous lesions or high-grade, which can again progress to high-grade dysplasia or HICL. And this over several years would cause cancers. So there is a window period, the silver lining, which we have to, recognize. When we look at the, what are the, when we teach screening to our students, and we say that it is one of the most classical example where screening is handy, that we can identify the early stages when it is asymptomatic and it is amenable to both prevention as well as treatment. So the ideal candidate of a disease where we have to use the screening. And so it gives us a long window period, about 17 years to 26 years it takes for the infection to develop into cancer. So we have to make use of this point. And they can, progress to invasive cancer. That is what is happening, that we are not able to identify these precancerous lesions, and women are reporting late, causing to the immense burden which we have seen in the previous slides. And of course, the progression rate depends on other factors also, like the high risk HPV, immune factors, and the other factors like smoking, HIV, which aggravate. In those people with these host factors are more likely to have a progression, earlier progression. That's why we are, when we talk of screening in HIV women, we require more frequent screening is advocated. Of course, now we have the HPV vaccine has been developed and it is being used in the developed country, though in our country we haven't been able to have it in the way, though it is being talked about, but due to various cost factors and other reasons, we haven't been able to have the HPV vaccine on the national scale. So as I talked of the risk factors, we are all aware that it's the more common in women, where the onset of sexual activities earlier, women with multiple sexual partners, and also with the STIs where there are chlamydial infection or HIV, and because of immunosuppression, it's more common. And again, more common in women who have the onset of pregnancy. The obstetrics is early, and at more pregnancy, they are also more prone to having these cancers. And of course, family history also plays a role. Oral contraceptives also increase the risk. And there is smoking. Circumcision has been shown to show a protective risk for has been shown to be protective for cancer cervix. So the silver lining is that cancer cervix is preventable and treatable. For prevention, we have the vaccine, and if identified early, we can, prevent the deaths in women if we identify them in the early pre-cancer stage. And that is why the role of screening becomes very important. And also, the ones who are diagnosed late can be managed. So we require a comprehensive approach of prevention, screening, and treatment, so that this is the only disease where at the international level we are talking of elimination. We have not talked about, normally when we talk of elimination, we think of, it's always been related to the communicable diseases. But here, because though it's a NCD, it's a cancer, but the causative is a virus. So that's why we are talking of elimination. So we all are aware in 2020, we had this strategy where we are talking about elimination of cervical cancer as a public health problem. And here elimination means that the rate should be like if there are less than 4 per 1 lakh women is the rate of the cancers. So this is what we are talking about. And in a big way, there's been a rollout for this elimination, so that by 2030, we are able to achieve this. Though it's a long way to go. And for this, the targets which have been set are that if we have 90% of the girls are vaccinated by the HPV vaccine before 15 years of age, and we are able to screen 70% of the women with a high-risk, high-performance test at least twice, like by 35 years and then again by 45 years, we can achieve this. And the women who are identified with the disease, they receive treatment, like for the pre-cancer lesions, and the ones with invasive cancer, we can treat them by anti-cancer treatment. So this is what is the, what we want to achieve. So this has been said to be the most effective effective strategy. It remains, and WHO has also said that to be one of the best buys. And it can be, these are the effective intervention which can be achieved by the low income and lower middle LMICs also. And we know that HPV vaccine has been licensed, but we haven't been able to have a rollout. So again, the screening remains an important cornerstone for achieving, preventing and controlling cancer cervix. And screening, we all know, is a public health intervention which is to be applied to apparently healthy, that is asymptomatic people, so that we can identify the disease and put into control the management. So coming to the screening methods, we all know that we have been, cytology remains the oldest method. Early in the century, which was used, we had the pap smear, where the cells are taken, and then we have the liquid-based cytology. We are also now trying for P16. I'll be talking more about these methods in detail. And then now the recommended method by the WHO is the HPV DNA testing. It can be done by the nucleic acid amplification test or the mRNA. We have methylation. And then, of course, in the low resource settings like ours, we have been having the visual inspection with acetic acid or with Lugol's iodine. It can be done by the naked eye or by using a magnified by a colposcope, the camera. So coming to the details of these methods, cervical cytology has been used for a long time now. And in the conventional cytology, also called pap smear, by using a speculum and or a brush, we are in a spatula, which is placed inside the vagina. We are fixing the cells obtained with alcohol, and then they are sent for cytopathology. Or there is the liquid-based cytology, which is refinement of this, where the cells are transferred to a liquid preservative solution, and then they are transported to a lab, where the slides are then prepared. So this is a diagram showing that how with a brush or a spatula, using the Cusco speculum, we are taking the cells. The advantage of the liquid-based cytology is that there would be a lower incidence of unsatisfactory smears, and we can also do a testing of HPV DNA with these abnormal smears if required. And since its introduction as a screening tool, definitely we have proof. And in the developed nations, the cancer incidence and mortality has remarkably reduced in the developed nations. But in the developing countries like ours, we haven't been able to achieve this. Especially the Nordic countries and like in the European countries, they have used this as an organized screening under the NHS, like in England and Finland. And then in the countries like USA and Canada, it has been used as an opportunistic or spontaneous screenings. In both in the developed countries, there is evidence. The studies show that we have been able to achieve success, reduce the incidence and mortality due to cancer cervix. But of course, we know that this is getting the cytopathologist, the lab remains a problem. Like the infrastructure, manpower, consumables, it's an expensive and it has to be done repeatedly. At least every 3 years, a pap test is needed. Then we have the HPV test. As I said earlier, that is the one now recommended by the WHO. That is the standard test for cervical screening worldwide. We have the nucleic amplification test, then where we have the HPV DNA-based test. That will detect the presence of viral DNA. And it can be the sample can be taken by the healthcare provider, or even now we are trying for self-sampling. I'll be talking about it in more detail. Then we have the PCR-based high-risk HPV DNA can also be detected. And we have the signal amplification-based HPV test, which may have a little lower it'll better to have it for the provider collected samples. Then we also have the mRNA-based molecular NATs, which are also being used. So these are the ones which have been validated. That is the hybrid capture. Then we have the COBAS HPV test, and we have the mRNA-based test. A little more about this thing, the mRNA tests, they are more specific because they identify the high-risk based mRNA. And they are more specific than the DNA-based assays. And we have the Aptima, or that is also an mRNA-based assay, which qualitatively detects the E6, E7 mRNA, which is more specific for the high-risk HPV. And also we have the oncoprotein detection, that also detects the actual oncogenes. So they are more specific, and they may be used for triaging. After we get a DNA positive, to be get more specific can be by using these E6, E7 oncoprotein detection. Then we also have the DNA methylation biomarkers. They are also more specific for this thing. And they are also able to tell that which HPV, because I've told you that many of the HPV, it will resolve. But they are more specific. We can know that these are the ones which will progress to HPV-related cancers. And also with cytology, we are combining these special stains, what is called dual staining. With P16 or K167 is being used. Normally in a normal cell, the P16 and Ki67 are mutually exclusive. But if we find both these markers, so it shows that there could be some oncogenic transformation due to these high-risk HPV infection. So you're being used with cytology, and this will increase the specificity of cytology by using this staining. So word about self-sampling for HPV as because otherwise, see in pap smear, it has to be taken by the provider, healthcare provider, which especially in our kind of milieu, we've seen that it is like not easy to ask a woman to give a pap smear. You know, she has to be motivated. And we have seen that. I'll be showing later on that we have not, though we say even getting a via done, visual inspection is not possible. So now the cell sampling is a major breakthrough where the women, you know, she can take her own self sample and give it for testing. So this is being used abroad. Now it is available in our country also. That cell sampling could be the game changer where the problems of women going to the provider are there. So this could be used for HPV self sampling. So it includes, studies have shown that self-sampling can improve the screening uptake. And there are some studies, not many though, and we need further studies for this. And also we can tell the women, like we had it in even during COVID and all, where self-sampling was being promoted. So we could have combine it with SMS or committee-based self-sampling, etc., can be tried so that we increase the coverage, because the screening has to be universal. If we could screen a very few women, it will not unless we are able to screen a significant number, only we will be able to aim for elimination and controlling the disease.
Excuse me,
Then,
madam, last 5 minutes.
We have
last 5 minutes.
Okay, yeah, I'll hurry up. Then we have the visual inspection test where we are either using the acetic acid or the lugolzidine to identify. The advantage of this is that it is easy to perform, and that is what it is recommended in our program, the NP-NPCD. Whereas, and there again, we can use the screen and treat, but it does have this thing that it needs a lot of training, and there could be a lot of false positive in this case. So there could be subjective interpretation, and it has, especially in older women, it has a limited sensitivity because we can't see the transformation zone. So to sum up, just all these methods I've already said in detail. The cost of the conventional is less. It is the HPV is the most expensive and viably though cheaper, but it is, and again, the needing the equipment is more for the PAP. We need experienced cytologists and a lab, which is not required for the viably. So code testing is another thing where we do the testing of both the HPV DNA as well as the cytological. It has the advantage that the frequency is less. Every 5 years only, the women, the negative predictive value is good for code testing. But again, it is expensive. So the guidelines have been issued, and the guidelines are that cytology we need to do every 3 years, whereas for HPV, the duration would be 5 years. So this is the algorithm which shows that in the good resource, we could go on from cytology, and if ideally, we should switch on to transition to HPV, whereas for low resource, we are still, though the WHO says we should have switch on from via visual inspection with acetic acid to low-cost primary testing, which is still under trial. And again, we can have two approaches. One is screen and treat, where we screen and treat. Of course, in this case, we have greater women going for Colpo. And other is there you get the treat of the women at that time only. Or we could have screen, triage, and treat approach, where we do another test to confirm, either by biopsy or by colposcopy. So coming to, because for we as public health person, economic evaluation is very important. Again, if we look at it, studies have shown HPV DNA, because the period, like how frequency of screening is increased. So that is most cost effective, but it may not be possible in resource limited countries like ours. Similarly, in India also, still via is on. But there is one study I would like to say in Sikkim, where they showed that through self-sampling, it was a cost-saving approach. Now, this is the status. As we can see that still many people most of the countries all over the world, in the advanced countries, in the developed countries, we are using the uh, cytology only. Some have only started the primary HPV screening. The dark blue is showing that, or the dual method. And countries like ours, the low resource are still for the thing. And the rate is very less. Still, only about 2 and 3 women have never been screened when they should at least get at least 2 tests. We are not able to screen almost 66%, 2/3 of the women are not getting screened. So it is low. So we have to, even the developed countries, it is not up to the mark, but it is much better. And we have know that NFHS shows a very dismal picture about screening in our country. But we have one good example of the Tamil Nadu Health System project where they could screen 81% of the women because of the, awareness campaign, committee outreach. All this is needed for, getting the women come take up. We had small study we also had where we saw that screening methods were not known to women. Very few knew just about the pap smear. So this is really a need we all as public health personnel need, that women have to be trained and made aware that this method once is the availability and also so there are a lot of challenges like about health system controlling. There's still the equipment is not there. There is poor follow-up. So all that is required to make so that we could achieve screening. So the way forward would be that there are studies going on that we could have a HPV, especially at the self-testing of women, so that we could get a high coverage and assured
Excuse
continuum
me,
care.
madam.
Once the women is
Time
yes,
is over.
yeah,
Just you fast.
yeah. I'll just finish that we could have a strengthening linkages and build capacity so that we could, and also of course integrate the HPV vaccine. Thank you.
Thank you very much, ma'am. If there are any questions, I think we can take one or two, and ma'am would be able to answer to those questions. Anybody? Thank you, ma'am, so much for enlightening us on this so very important topic of cervical cancer screening. And you have beautifully described the various tools available and how we should go about utilizing those tools to make our country cancer-free. So now I hand over to my co-chair, Dr. Kadam, to give the concluding remarks.
I think it was a very nice presentation. As a gynecologist, I think in the 90s decade, I used to collect thousands of pap smears by conducting camps. And that is the way we have moved ahead. And I think cancer cervix is the best candidate for all types of prevention. Downstaging, it's definitely it is available. So many screening tests are available, and now also we are able to find out the causative organism also. So very much earlier we can start elimination, but in spite of that, it ranks in the first 10 for the cause of death or the illness, morbidity. So I think we still are lacking in the implementation. Our willpower is still lacking, and we have to focus on that in this period of digitalization and AI and so many things. So thank you, madam.
Thank you, Dr. Pragdi Chabra, for joining us online for this very important topic. I now request Dr. Kunal Chatterjee to present certificates to our chairpersons for this session, Dr. Yugantara R. Kadam, Dean KIMS Karad, and Surgeon Captain Dr. Ruby Chattopadhyay, Senior Advisor, Microbiology, Officer on Special Duty at NMC. I'm aware that I'm the only thing standing between y'all and lunch, but a few announcements. Kindly keep your IDs safe, dear delegates, and visit the registration counter tomorrow morning to be able to collect your delegate certificates. The scientific sessions will begin today at 2 p.m. in the lecture hall complex and in the examination hall. Do visit our stalls to pick up some wonderful souvenirs from Goa. And as we come to the end of this wonderful morning, I thank our eminent speakers and delegates, those who were here and those who came online. We know that the journey was not easy, yet you chose to stand by us today. And for that, we are grateful to you in every way. Once again, welcome to our beautiful state of sun, sand and sea, Goa. We will begin the afternoon session at 2 p.m. Thank you. Respected delegates, speakers and chairpersons, we warmly welcome you back to the second half of the sessions of the first day at the 6th IAPSM Young Leaders National Conclave 2025, Digitalization, Data and Decisions, Youth at the Forefront of Health Tech, here with us at Goa Medical College and Hospitals. We trust that the break offered you a moment of rest, and we are grateful for your continued presence and engagement as we proceed. The first session for today afternoon is Ayushman Bharat Digital Mission. I request Dr. Rukmita to welcome our chairperson, Dr. Archana Caroline, Professor, Department of Community Medicine. The second chairperson, Dr. Madhu Gupta, Professor, Department of Community Medicine and Public Health, PGI Chandigarh, will join us online. And the speaker for this session is Dr. Yogesh D. Potdar, Assistant CEO, Ayushman Bharat Digital Mission, Directorate of Health Services, Goa. Dr. Madhu Gupta, warm welcome to YLNC 2025 Goa. We regret that we cannot have you here today, but we are glad that you could come online.
Thank you so much.
I request the chairpersons to begin the session.
A very good afternoon to one and all gathered here for the 6th IAPSM Young Leaders National Conclave. I am Dr. Archana Kerolin, Professor, Department of Community Medicine, Mallareddy Institute of Medical Sciences, Hyderabad. So I'm very thankful to the organizing committee for giving me this opportunity as a chairperson. And I'm honored to introduce the speaker of the hour, Dr. Yogesh, who is an additional CEO, Ayushman Bharat Digital Mission, Goa, qualified in the field of Bachelor of Dental Surgery, MBA in Hospital Administration, Licentiate Insurance Institute of India, specialized diploma in the health insurance, and he has professional experience in medical management and quality manager under Ayushman Bharat Pradhan Mantri Jan Arogya Yojana and Deen Dayal Swasthi Seva Yojana, Directorate of Health Service Goa, and implementation in the Ayushman Bharat Digital Mission in the state of Goa. His areas of expertise are health insurance and digital health. Dr. Yogesh, the stage is yours.
Thank you. Good afternoon, everyone. It's a privilege to be here with you today to talk about India's digital health revolution through the Ayushman Bharat Digital Mission, or ABDM. My name is Dr. Yogesh Poddar. I'm the CEO of, additional CEO for ABDM Goa, and together we will explore how this mission is transforming healthcare delivery, making it more accessible, efficient, and trustworthy for every citizen. So here's what we are going to cover this session. ABDM, Digital Revolution in the Healthcare System of India, the intended benefits for citizens, providers, and policymakers, core building blocks of ABDM, guiding principles behind the mission, key initiatives which are already underway, and finally, a look at Goa's model facility at Primary Health Center, Kollam. So, has everybody seen this change? Can we make it more interactive? What is it? See, we have lived through a digital revolution from a cash-based, offline, low productivity economy or system to a cashless, online, high productivity digital economy. Why does it happen? Why do we trust it? This was possible because of trusted actors, verifiability, and digital connectivity. The same principles are now being used or applied to healthcare. ABDM is bringing the same revolution to the way we deliver and experience health services. Now, what is the healthcare scenario over the world actually? Traditionally, healthcare has been burdened by manual processes and physical records. Patient histories are fragmented across hospitals, labs, and clinics. When patients move between providers, the data is lost. This leads to repeated tests, diagnostic delays, and compartmentalized care. The result is inefficiency and low productivity in our healthcare system. So what do we envision? A new paradigm. Imagine a system where every stakeholder is digitally verified and trusted. Health records are digitized and accessible anywhere. Data flows seamlessly between providers. What does it create? It creates a high-trust, low-cost ecosystem that benefits everyone. Now, the solution lies in 4 key components. We have an Ayushman Bharat health account. Anybody in the crowd has their Aadhaar created? Have you paid for it? It's a free service, actually. Good. So, Ayushman Bharat Health Account is a digital identity for every citizen of India. HPR, Health Professional Registry, is a registry of healthcare professionals. HFR is a registry of healthcare facilities. And then we have gateways. We have gateways such as HIECM, UHI, and NHCX. I'll be talking about it later on. So together, these building blocks create an interoperable healthcare ecosystem, just like UPI did for payments. So what are the intended benefits of ABDM? For citizens, ABDM means empowerment, cost saving, and continuity of care. For providers, it means efficient record management, better clinical decisions, and easier compliance. For policymakers and researchers, it means real-time data for epidemiology, resource allocation, and promoting health equity. In short, every stakeholder gains. So I'll just talk about the 4 core building blocks of ABDM. The first is ABHA, or Ayushman Bharat Health Account. It's a 14-digit random number designed to be a unique patient identifier for citizens. Easy sign-up using Aadhaar, voluntary and consent-driven. Individuals can access their health information seamlessly across different healthcare providers. Instant registration using scan and share feature. What does HPR do? Healthcare Professional Registry ensures that professionals are verified and discoverable. I hope the doctors have registered themselves for Health Professional Registry. So it's a centrally maintained comprehensive registry of all health staff, medical and non-medical, online presence and discoverability on a national platform, digital access to patients' records, which are of course consent-based, e-signed prescriptions, diagnostic reports, and discharge summaries. It helps in better clinical decisions and ease of doing business, quicker and easier access for license renewals, obtained NOC, CME point tracking, digital signatures, and access to CDSS. HFR is Find Care Easily, or Health Facility Registry. It lists only the authentic facilities with verified information. PHR are personal health records. Your health in your hands, that's what we call. It allows individuals to store their electronic health records securely, empowers patients to have complete control over their health. These are the main pillars of trust and transparency in ABDM. Now, ABDM is built on trust, security, and choice. Participation is voluntary. Privacy is embedded by design. It uses open APIs to encourage innovation and prevent vendor lock-in. It is inclusive, designed for everyone. And importantly, it uses a federated architecture. Record remains with provider and they are not stored clinically. They are not stored centrally. So federated architecture in the sense, wherever your records are made, it can be a lab, it can be a diagnostic center, it can be a hospitalist clinic, the records are stayed with the providers. So this is a closed restriction systems, what is happening right now, and we have unified health interface. So think UHI as the UPI of healthcare. Just as UPI allows any payment apps to connect with other apps, UHI allows any health app to interact with any provider. This means universal discovery, simplified booking, and integrated teleconsultation. Smaller clinics and individuals practitioners benefit equally, ensuring there are no monopolies. So the key advantage of UHI is open protocol prevents monopolies by large platforms, ensuring even smaller clinics and individuals are equally discoverable. This means, now some of the key initiatives of ABDM are scan and share, avoid long queues, scan and share records, and scan and pay. So what is scan and share? Now this photograph which I was shared is from AIIMS Delhi. Patients' demographic details are shared with the facility with any ABDM-enabled PHR app. It ensures quality data during registration in minimal time. So it has actually reduced patient waiting time at registration counters from 50 minutes to just 5. Scan and share records. Access, manage, and share your digital health history with healthcare providers for continuity of care. When visiting a new doctor or facility, use the app to give specific granular consent to securely share selected health records to limited duration. So when we say granular consent, you can select which records you want to share with the doctor. You can also select the time frame. So if I want to share only last 1 month's record, I can select that. I can also select how much long the doctor can see the records. And the new initiative is Scan and Pay, wherein digital payment services under ABDM, it empowers patients to make quick digital payments for healthcare services at ABDM-enabled health facilities. Now, these initiatives show how ABDM is improving efficiency and patient experience. ABDM integrates seamlessly with government programs like CoWIN, RCH, Arogya Setu, and DigiLocker, as well as private players like Practo, Narayana Health, and Paytm Health. This ensures that both public and private stakeholders are part of the unified ecosystem. Now, ABDM connects everyone: citizens, providers, policymakers, insurers, labs, pharmacies, NGOs, and tech companies. It creates a national digital health ecosystem where all stakeholders are part of the same trusted network. Goa is proud to host India's first fully digitized ABDM-compliant primary health center at Kolim. This facility showcases paperless process, teleconsultation, and e-Shushrut integration. Now, it was also highlighted during the G20 Health Working Group meeting as a model of digital health innovation. So I'll just request to put on the video, please. You want me to play? It's connected here. Okay. Pause. So has anybody used DigiYatra? Right? So it's the same thing you can imagine, at Goa Medical College after a few months or hopefully in a year or so. So we have a kiosk which is placed outside PHC Kolim. Can you please play the video? I hope it was self-understood. So let's address some common myths regarding ABDM. ABDM stores medical records. Is it a fact or is it a myth? I've shown what it is actually. ABDM does not store medical records. Records
So,
remain
one
with
more
provi-
minute more, sir.
Yeah, sure. Records remain with providers. ABDM only facilitates secure exchange. Now, creating an ABHA makes my data public. No. Records are shared only with explicit consent, which can be revoked anytime. And is ABHA only for socio-economical backward? No, it's an universal identity for all citizens of the country. So I would like to open the floor for your questions, if there are any. Please.
We are thankful to sir for his elucidative speech.
She has a question.
Yes, please.
Hello. Thank you, sir, for beautiful presentation. I'm Dr. Monalisha. My question is that though they say that they do not store medical information, but nowadays, like in digital health, whatever goes can stay there for until it is
No,
overwritten.
yeah.
So, like, how we are ensuring that it is not staying, because it's a big question, the maintenance of security. So,
Okay.
yeah.
So what I'm trying to tell you is that ABD is creating a pathway. It is not storing any information as itself. The information remains with the hospital provider or the clinics, whoever is creating the information. So we are basically creating a pathway. We are connecting one hospital, one clinic, different health providers through a secure pathway. We just verify whether the patient, the ABHA ID of both the patient, which is linked to all the hospitals, is same or not. That's it. So it is not saved by ABDM. We're just creating pathway through that.
Sir, I have a question.
Yeah, sure.
Patient consent is it not needed, right?
Yes. So ABDM is consent based. You cannot have an ABHA number without giving a consent. So when you create an ABHA number, therein that's itself is a consent based.
But accessing the health records?
Who will access the health records? Right now, hospital which is providing services. You go to a hospital, that hospital has access of your medical records? It has, right? You cannot share the medical records with any other without the consent of the patient. So that is why you should have a ABDM compliant HIMS solution. You cannot link my medical records to yours. Even my medical records will be linked to my ABHA only when I give consent to it. So OTP goes. How in banking sector, my transactions cannot be linked to somebody else. The same way ABHA sees that it is a unique identity. So even if I go to any hospital, if I don't give my ABHA, they have a CRN number, my medical records are linked over there. In case I give my ABHA, and then they will send me an OTP. Then it confirms that those records and me as an ABHA is same, and then only it will be linked. So all transactions will be linked to ABHA only with the permission of the patient or the beneficiary, and it can be shared with any other doctor only with his consent. So that is why we want people to use an ABDM enabled HIMS solution.
Thank you, sir.
Yeah. So any more questions? Sure, sir. Yes, ABDM Sandbox is actually, it's a trial room. So if any software wants to run first, they have to run through the sandbox. Yes. So if you want to have a software, whether you want to see whether it works or not, first we allow you to come into the sandbox. You have to do all the trials and everything. So once it is done, you get compliance with ABDM. There are 3 levels of compliance under ABDM. So ABDM itself is not going to do anything. We are actually making a fair playground for everybody to come and connect to each other. That's it. Yes, the understanding is very important. Any question, please? Yeah.
Hello.
Yeah. It's basically a lock and key. See what happens? I cannot ask everybody to have a ABDM HIMS because there are n number of softwares available. So I cannot ask you to change your HIMS and use mine. So what I'm telling you, you use your own HIMS, do the changes. It is API integration in the chains. Your software will talk to my software or ABDM. So there will be another software which also talks to me. So you can talk through me. Yes, yes, yes. You are not going to change your software. You're just going to make it ABDM enabled. So you're just giving that pathway to us. Please, yeah. API is a software. So there might be old software 10 years back and all, but you have to just tweak it so that it talks to me. So through me, it can talk to everybody because right now the data of patients is scattered. Yeah. You can go to our website abdm.gov.in. Everything is there, and you can also talk later if you want. Okay. Any more queries?
Hello. Am I audible?
Yeah, yeah.
Yeah, thank you, Dr. Yogesh, for such wonderful presentation. It definitely looks very, very promising, especially the comparison you gave from with the UPIs. So that is so successful. So I'm sure that within India also this will be really successful. So I also have query: what is the extent of implementation of this mission currently? As you are saying, one PSC here, and in Chandigarh also at the primary care level, we have initiated this system of online registration, and throughout the community, Aabha IDs are being made. And what are the challenges you see in its implementation? My second query is related to eSanjeevani app. So we are also providing this app, whether through Aabha ID linkage and also the patient can access eSanjeevani, the telemedicine services.
Yeah. The first, I will tell you what is happening in Goa. We have started a PHC Colim 2 years back, which is end-to-end digitization. But we also use papers right now for them. The reason being, if the patient wants to go to another hospital, he just cannot show his mobile phone to that hospital because that hospital is not ABDM compliant. Another thing what we have started, last year we started around 13 hospitals, 2 district hospitals, some CHCs and PHCs, where registration has started, digital registration has started, and dental OPDs we have created digitized. So this year's more 12 hospitals will start, and by the end of next year, all hospitals under Directorate of Health Services will be at least digital registrations, plus 2 or 3 OPDs will be digitized. So that is what is happening in Goa. Okay, because in Goa we just started 2 years back. The national launch of ABDM was in 2021. So next year we're going to start with ABDM 2.0. You won't believe that around 83 crores of people already have an Aabha identity of theirs. More than 90 crore health records as on date have been linked. So that is the challenges. I'll tell you. Biggest challenge is infrastructure. There has to be leadership. There has to be funding for that. And that is manpower. Behavioral change also. How many doctors are ready to use a digital solution and let go of their paper and pen? It starts with that. So many softwares have come right now where you can just talk to the software and a digital history is created. So there are n number of challenges. Behavioral is one of the biggest challenge because doctors actually don't want to use a digital solution. So that is it from my side.
That is what. And also their prescriptions will be widely available.
Yes. And another madam, you asked about...
Everybody will be able to read.
You asked about the eSanjeevani thing. So all government programs, they are right now in a process of interlinking. So they're going to be ABDM compliant because what happens, all programs, COVIN, RCH, you name it, NCDs, the history, it's a double work. It's duplicate work. It's not a proper work. Because every time I tell ASHA worker or ANM my name, they might write it in a different thing, right? So spelling mistake, there are many number of things. So that is why we want to do the entry in these systems through Aadhaar, because Aadhaar is again Aadhaar based. So once you scan the QR code, all your details directly are entered. So you don't have to re-enter it. So once all the systems are linked, you'll get a proper longitudinal access to patient's medical history.
Yeah, thank you so much. And with that, I would like to conclude this session with the note that this is the future. This is where we are moving to. And with all the challenges taken into consideration, I think we as health professionals will find out the solutions which are sustainable. And as we have said, with UPI we could do it. I think with UHI also we will be able to do it. And I want to thank the co-chair here and also the organizers for giving us this opportunity to chair this very important session. And a very special thanks to Dr. Yogesh for this illustrative talk. So, and the audience for such interactions. Thank you so much. Thank you all.
Thank you.
Thank you, Dr. Madhu Gupta, for joining us online. I request our chairperson to felicitate our speaker, Dr. Yogesh D. Potdar, Additional CEO, Ayushman Bharat Digital Mission, Directorate of Health Services, Goa. And I request Dr. Arundas H., Founder and Chief Physician, Medivell Clinics, to felicitate our chairperson for this session, Dr. Archana Carolyn, Professor, Department of Community Medicine, Malareddy Institute of Medical Sciences, Hyderabad. Thank you once again, Dr. Yogesh. We now move on to the second session for this afternoon, Drone Technology for Healthcare, a Flying Potential. I request Dr. Aparna to welcome our chairpersons, Dr. Monalisha Shahu, Associate Professor and Head, All India Institute of Hygiene and Public Health, and the second chairperson, Dr. Rakesh Kumar, Additional Professor, All India Institute of Medical Sciences, Delhi. I request our chairpersons to kindly take the dais. I welcome our speakers, Dr. Bobby Paul, Professor and Head, Preventive and Social Medicine, All India Institute of Hygiene and Public Health, Kolkata, and our second speaker, Dr. Rashmi Agarwala, Associate Professor, Community and Family Medicine, AIIMS Guwahati, will be joining us online.
Am I audible, madam?
Yes, Dr. Rashmi.
Okay, thank you.
Dr. Rashmi, although we could not have you here physically with us today, we are happy that you could join us online. Welcome to YLNC Goa 2025.
Thank you so much.
I request our chairpersons to kindly begin the session. Please note, the chairpersons and speakers, this session lasts for 45 minutes.
Hello. Very good afternoon, everyone, to this session. Whenever we hear about drone technology or we heard about UAVs, the first thing which comes to our mind is its use in military technology or maybe in photography. So first of all, I would like to thank IAPSM and also the organizers of this conference to have this very important and very innovative topic for the plenary session in this conference. And in this session, we will discuss how UAV can be used also in healthcare technology and how it is being used very effectively now in healthcare technology. So without further ado, I would request my co-chairperson, sir, to please introduce the speakers. Thank you.
Thank you. So now I'll introduce the first speaker, Dr. Rashmi Agarwala, who is from AIIMS Guwahati, and she is the nodal officer for immunization, climate change, and drone services at AIIMS Guwahati. And she had actually kind of many hats to her. I mean, she has got best paper awards, she has got best research paper awards, but not to go in much detail. Rasmi, if you can please start your presentation.
Sure, sir. So a very good afternoon to respected chairpersons, members in the audience, my seniors, my colleagues, and my friends. It's indeed disappointing that I could not join at the conference physically, but I'm thankful to the organizers for arranging this online session. Somewhere down the line, when the flight got cancelled, I really wished I could take the drone and land there at Goa Medical College. So thankful to the organizers for really arranging this online session. So without any delay, I would like to begin my presentations. Should I share the presentation myself or the organizers will do it, sir?
You can share yourself.
Okay. Is it visible, sir?
Not yet, yeah. Now it is visible. You can put in the kind of slideshow mode.
Okay. Now is it fine?
Yes, it's good now.
Okay, thank you so much, sir. So as we start, myself and Dr. Bobby Madam, who is here with me, we will cover through what are drones, what have been its uses, the challenges that we have faced as we did this drone operations at our institutes, and also the way forward for the drone technology for healthcare. Beginning, I would just like to brief about the drone and the drone rules, experience sharing from AIIMS Guwahati, and the challenges that we faced as an institute when we carried out the drone operations. As history, the public term drone was first coined because of the loud noise that it makes, like a male bee. So that is how the word drone has come. The origins of this unmanned vehicles can be traced back almost 100 years, dating back to, World War I. And now what we see in future is the drone wars, which is being carried out. But when we look at health, the very word inaccessible will slowly lose its meaning because of this drone technology, which is coming in healthcare sector. So the COVID-19 pandemic further accelerated the use of digital technology along with the drone services. The drone service medical application can be broadly categorized as public health and disaster relief, the medical transport, be it organs or blood, and the telemedicine facility. In public health and disaster relief, the application of drone has been done for mapping or disaster management, which has shown the highest contribution, search and rescue operations, transportations, and for training purposes of the human resource there. This drone can also be used in public health for epidemiological research and for the control of zoonotic diseases transmission. In medical transport, the drone technology use has been vast. A pioneering initiative was itself carried out in Northeast India in the terrain of Meghalaya, which is a very hilly terrain, and they are very difficult and hard to reach areas where they've successfully piloted and they're still carrying out drone operations for transport of medicines and also bringing in blood samples from these areas to tertiary care centers. So there is also a delivery program known as Uber for Blood, which is being used in Rwanda since 2016. Switzerland has been very effectively using organ and tissue transportation through drones, which gives you a direct green corridor. So there is no traffic hasslement for these samples to reach. Emergency medicines and drugs can be very efficiently transported if the drone line is clear. And studies have also shown that drone transport does not affect the accuracy of the routine biochemistry, hematology, or coagulation test results. This we have also seen at our institute. And not as of now, I would not say that they are very cost saving, but down the line in future, yes, they would prove to be a cost saving transport mechanism. So that's Uber for Blood in Rwanda. That's the Meghalaya government using the drone for transport of medicines to difficult to reach areas, and the drone being used in sectors of Assam. Drones can also be equipped with communication devices and cameras that act as a telemedicine communicator, particularly for use in inaccessible areas. So this is another vast field we are looking into drones for being used as telemedicine devices. Before we move on to what we did, I need to tell everyone that yes, we have something called a drone rule, which has been published by the Ministry of Civil Aviation, and then updating it also. Also, they have published the certification scheme for unmanned aircraft systems. So all unmanned aircraft systems need to be registered. The drones have been classified in India as nano, micro, small, medium, and large as per the weight that is there. So large one is the one weighing more than 150 kilograms. And the small unmanned aircraft system, which we've been using, is weighing more than 2 kilograms, but less than or equal to 25 kgs. The category of zones, as per the drone rule, is again very important. So before flying drones, we need to understand that the digital airspace that is above us is divided into three categories: the red, yellow, and the green zone. So red means the airspace of a defined dimension, which could be above land area or territorial areas of India, where there is an installation or notified port limit certified by the central government, and where you cannot fly the unmanned aircraft system unless permitted by the central government. So this is important. Red zone means no fly without unless permitted by the central government. The yellow zone means the airspace of defined dimensions above the land areas or territorial waters of India, where these operations are restricted. So the airspace above 400 feet or 120 meters in the designated green zone, and the airspace above 200 feet or 60 meters in the area located between lateral distance of 8 to 12 kilometers from the perimeter of an operational airport is a designated yellow zone. I'll show you a picture of this for better understanding. So green zone means the area, outside the 12 kilometer, which the drone can fly up to a vertical distance of 400 feet. And in the outer yellow zone, the drone can fly at a vertical distance of 200 feet or 60 meters. This is in the outer yellow zone, which can be labeled as a green zone. So like I said, the digital sky is where you can log in and put your, this place where you want to see whether it is in the green, yellow, or red zone, and it will show you. So the red zone, if you can see, it is the high security area, no fly without the central government permission. Then there's a yellow zone up to 8 kilometers from the center of this red zone, and then another 4 kilometers is the outer yellow zone. So this is how it has been divided. So I just put Goa Medical College on the digital sky, and it's showing in the outer yellow zone. So the permission has to be taken from the Airport Authority of India before doing flights here. But up to 200 feet, yes, the flight can be taken. It falls in the green zone. But if you have to fly above that, then there has to be a permission, and there has to be coordination with the Airport Authority of India because it falls on the outer yellow zone. So like I said, registration of unmanned aircraft system is important as per the rules. And also all pilots, they have to get a remote pilot license through a certified DGCA approved licensing organization. So this too is very important. And also made in India UAVs are promoted. Coming to what we did in the last 1 year, I would call it the last mile delivery and the public health impact that we have made, because we've done services from tertiary healthcare centers to the riverine islands and flood-prone areas of the islands which are near to AIIMS Guwahati. So in accordance with the Ministry of Health and Family Welfare, we launched a pilot projects, and we've successfully carried out transporting medicines, diagnostic samples from AIIMS to 3 specified hard-to-reach and flood-prone locations in the state of Assam. So we followed all rules. We fall into a military red zone. So with the permission of the military or with the Indian Air Force and permission from the Ministry of Civil Aviation, we have carried out these operations, and we'll be now moving on to our second phase. So we took the district and state level health authority approval because these health centers fall under the state, so you need to coordinate with them. For us, yes, we are a central government, so there is a drone delivery services available in GEM, which you can, tender for, and you can ask for a demonstration trial so that they fulfill your criteria. We've also trained 2 women as self-help groups, are also known as the drone didis for drone handling and helpers. And the permissions, like I said, have been taken for the red zone areas. So if you see, I've put a red pin for AIIMS Guwahati. And the 3 green pins are for the 3 locations where we've done these drone delivery services. So that's a Bongalpara subcenter. Then there's Botahidia, and then there is Goroimari PHC. So all these are very hard to reach areas. If you look at Botahidia, it's right in the middle of the river Brahmaputra. So if I have to go there from AIIMS Guwahati, I would first have to take my car, then park my car, take a boat to cross the Brahmaputra, then take a small vehicle which runs within the island, around 5 kilometers to reach the health center, Botahidia. But with drone, if I have to go, I can reach this health center within around 35 to 40 minutes from AIIMS, which otherwise I would take around 3 hours. Similarly, Goroimari is about 2 hours from AIIMS. The drone goes in around 45 minutes. So, these locations were chosen because of inaccessibility and also very difficult to reach areas, and they are very, very flood prone. So like I said, they are chore areas. We call them chore areas, unique in nature due to constant threat from flood and erosions in the rainy seasons, and they become inaccessible during these seasons. So these are some pictures of our visit. You can see in the 3rd picture, they usually make a very temporary bridge. Again, if this bridge collapses, then the area becomes inaccessible. So these were some of the areas where we've targeted through drone. So within 1 year, we've done 102 drone flights covering all the 3 health centers and reducing the time by an average of 73.48%. And also we have transported about 500 diagnostic samples for testing at the tertiary healthcare centers. And like I said in my previous slide also, all the samples were not damaged. We brought them under proper temperature and control, and we have shared the results with the PHC doctors for helping, which has helped him to come to further diagnosis and treat the patients. And whatever medicines have been required, we've also transported through drone to these health centers. We've had certain case scenarios, like we've transported immunoglobulins for dog bites when asked for. We have also, there have been outbreaks, like there was a waterborne disease outbreak. So we've transported samples to AIIMS Guwahati for testing. And we've also given results on time for treatment to begin for these patients on time. We've also done some drone-based health camps where our specialist doctors have visited these health centers. And as per the requirement, we have sent the sample to a tertiary care, to our health center for testing. So all multi-speciality doctors doing a health camp there, and whatever blood test was required, we have sent it to the health center. Nevertheless, it's drone. Just recently, we've had problems with a particular airline also. So we've encountered a lot of challenges with drones, and now we're trying to fix them as we start with the 2nd phase of these drone operations. As you know, Assam is hindered by frequent heavy rain and flooding. So we have to allow the drone operations during optimal times. You cannot fly the drone when there's heavy rain, unlike the aircrafts which go, because these are lighter in nature. However, water does not enter the battery, so that's not a problem. Also, the drone can carry a weight of just 5 kg of payload. And we cannot put it to the maximum level of payload, because then the battery consumption increases. So with one battery recharge, it can go up to 100 kilometers. And we had kept it so that it goes and comes back, the drone. So this is something like a challenge we face, because the weight carrying capacity of drone is still very less. Our drone pilot is needed at each end, although we had a trained self-help group members, but a pilot is definitely needed to, maneuver these drones. And this requirement we suggest can be mapped by mapping delivery points and training the manpower which is already there in the PHC. So in our 2nd phase, we are doing that. And we've encountered several regulatory challenges, like issue of tracking drone on the radar. The airport radar actually catches drones, which only the flights, which are flying. So drones fly at a very lower level, and these radars have difficulty in tracking the drones. So we had to share coordinate points with the Airport Authority of India because we were in the red zone of the military, and they tracked our drone through these coordinated points. We call them when our drone starts flying, and we call them when the drone has landed. So there is a constant communication with them also. And like I said, because of the red zone, we had to take clearance from Airport Authority of India, the Indian Air Force. Now, this permission, we suggest, Bobby Madam would also specify that we need a software where we can, ask for a common permission from all these authorities. Then the actual difficulty faced, because these are inaccessible areas, we had internet connectivity issues. The drone needs kind of a little connection while landing. During the flight, it may not need, but while landing and taking off, yes, it needs some internet connection. So we requested BSNL to provide us that along with a network jumper. And we ensured that the network problem was solved in these locations. Once or twice it did happen that we collected samples and the weather suddenly changed. A lot of rain and the drone could not come back, but we ensured that we received the samples on time through road by in the institute. So these were certain challenges that we faced while doing the drone operations at AIIMS Guwahati. The overall challenges are the regulatory and the compliance challenges. So there's a complex approval process which could lead to operational delays. So a lot of approvals are needed, and we yet do not have a common process through which we can take the approvals. There's lack of uniform interpretation of guidelines across states and districts. So many times the drone rules are not understood by the states and districts, and we had difficulty in taking permissions. Limited reinforcement mechanisms for unauthorized or unsafe drone flights. The airspace management issue is there. So there's absence of integrated unmanned traffic management system currently. And our civil aviation is yet to prepare for this drone systems in India. There's definitely safety and security concerns, drones being misused for illegal activities. The GPS spoofing, which recently happened, is something which can happen with the drones also. Signal jamming can take place. So we lack a standardized safety protocol for the drone operations. There have been technical and operational limitations, like I said, short battery life, limited payload capacity. Sometimes inaccurate positioning in dense urban areas can lead to signal obstruction. So we need to be careful when we are using them in dense urban areas. Again, they show poor performance in adverse weather conditions. So heavy rain, a lot of wind blowing or fog, they're not yet made to survive these poor adverse weather conditions. And we also have in drone ports, like I said, battery charging stations would be required, some maintenance hubs, limited indigenous manufacturers, so with very limited drone manufacturer companies currently. And once this company problem is solved, you have a lot of manufacturing companies in place, even the drone rates would decrease for transportation. We have shortage of certified drone pilots and technicians. And there's a need for specialized training in GIS, remote sensing, and data analysis for drone operations. This is what we felt also throughout our operations. So this was the first flight we took from AIIMS Guwahati on 20th February 2024. And we've been applauded by the Union Minister of Civil Aviation then because of the inaccessible areas that we reached out to. So on conclusion, I would just like to say that the pilot project that we did has successfully demonstrated that drone technology is effective in transporting the medical supplies and bringing in biological samples for testing. And this thereby reduces the delivery time and also provides diagnostics, the evidence-based diagnostic to the PHC doctors to start treating the patient on time. So there is overcoming of logistical challenges also. However, yes, there are regulatory barriers, suboptimal weather conditions, limited technical conditions, and network internet coverage, which we need to look into as we bring in drone technology for healthcare for India as a whole. So this is a small video. I hope it's playing. So that is the launch of the drone. So it is a vertical takeoff. So vertical takeoff and vertical landing. It does not take off like a flight which slides and takes off at an angle. It just takes off vertically and then lands vertically. So landing and taking off has to be little manually dealt, especially while landing, a person has to be there to make sure that it's landing on time. So this was, and Bobby Madam will definitely deal with all the way forward that we can come up with these regulatory challenges. So thank you so much.
Thank you, Dr. Rasmi, and I request you to stay back through the session, because at the end we'll have question and answer, so audience may have a questions. And thank you to kind of explain us the,
sure, sir, sure,
the regulatory issues and your experience at AIIMS Guwahati in dealing with this. Now I would request Professor Bobby Paul, who is Sub-Dean and Professor and Head of Preventive and Social Medicine at All Institute of Hygiene and Public Health, Kolkata. And she has extensive experience in mixed method research, bioethics and disaster management. So I request ma'am to make the presentation. Thank you. Mic is not working, so you can just...
A very good afternoon to all the esteemed delegates present on dais and off the dais. And my heartfelt thanks to the organizers for inviting us to present in this important potential health technology that can have a big future if properly applied. So my presentation outline will deal with our experience sharing and the report that we had prepared after we piloted the drone services at AIHPH Kolkata, and the potential for drones for disaster risk management, disaster risk assessment, monitoring and response, and the way forward. So at AIHPH Kolkata, we were asked by our Ministry of Health and Family Welfare to pilot this project. The effort started around December 2023, and finally we could do it in January, February 2024. And we selected the rural area, field practice area of Shingur, which is around 28 kilometers located away from the city. And there we have our field practice area composed of 64 villages and catering to around 1 lakh population. And this was started with support from DGHS, Ministry of Health and Family Welfare, the training division of the NHSRC, who trained our drone Didis, and the Government of West Bengal as a pilot project. And we simultaneously we took a rapid appraisal of the efficiency of this technology in delivering healthcare services in a rural setup following the rapid appraisal of health technology Niti Aayog guidelines. Here the principal coordinator was Dr. Ribu Basu. He is in our institute only as an assistant professor, Department of PSM. He was a nodal officer supported by other key members. And the patron was being the director, AIHPH Kolkata at that time. Dr. Ranjan Das was our director. So this was the team, and this is a glimpse of our rural field practice, the rural center. So basically, we plan to deliver medicines from the hub, that is the Shingur Rural Health Unit and Training Center, to the spoke, that is the Anandnagar PHC. So you can see that this delivering of lab samples as well as medicines from the spoke to hub 2 days a week, like Tuesdays and Fridays, was planned. The aerial distance being 4 kilometers, while the actual distance, you can see in the blue line, the actual distance being 10.3 kilometers. And of course, the drone that was chosen, we also procured it from our GEM portal. It carried up to 3 kg of payload, flight timing up to 40 minutes in one go, and the minimum mandatory elevation being 2000 mAGL. The order placement and the live tracking via ground control software was there, and it was operated by the third party, that is the GEM portal, the procurement people that we had selected. And they maintained the safety requirements as per DCGA guidelines. So the dedicated drone corridor was planned. This was the report that we had published in our DGHS newsletter later on. And see, according as Dr. Rashmi explained very well in her presentation, so the green, we had planned our services in the green zone, and which was way away from the yellow and the red zone areas. So the two NAMO drone Didis, who are basically are the public health nursing officers who were selected and trained by NHSRC. And the crew representatives were actually provided by the vendor. They only operated the entire thing for the, I think 3 to 5 months it went on. And the multiple meetings were held with the key state officials, and here lied the greatest challenge to convince each level and to institutionalize it. And awareness campaigns were actually done because it was in a rural area and the villagers were not aware, like they may, shoot down even, and or the panchayat people may also, actually we being representing central government, and in a state, if we do something, that is nothing, that has got no inkling with the national programs, then the greatest challenge lies, because the state government also becomes reluctant to provide support. And the successful demonstration was done finally in presence of the key district representatives so that they are convinced, and our lab technicians and pharmacists were designated to maintain the logbooks while the services were being provided. So finally, at the end of 3 months, our own team, headed by Dr. Rivu Basu and our PGs, they did a techno-economic result, presented this result. Actually, in the first 3 months, the flights were held regularly as per schedule. There was no technological glitch. The total distance covered was 480 kilometers. But while we were calculating the cost, actually the service cost calculated was rupees 300 per kilometer, while the land route delivery was only rupees 40 per kilometer. So the service was, for the ensuing service was discontinued while we presented this report to DGHS. And with this note that where the services are good, the roads are well connected, it is not probably wise to institutionalize drone services at these zones. And the stakeholder level challenges, while it was same as Dr. Rashmi told, but probably it was more for us because there was a lot of confusion amongst the district officials. That is, whose air is this? Who will give permission? Right? The district is telling go to police, the police is telling go to DM, the DM is telling go to Air Force, the Air Force is telling go to railways. So it went, the rounds of these permissions were, happening, and finally we could get permission for 3 months, and then we were asked to present the report. The risk perception among the community, it was dealt with by holding a number of meetings with the Panchayat Samiti members, but since, as I told you, it was not linked with the state services, so, they were also very skeptical. And there was a railway line in the flight path. So again, that was a big challenge. We were also unsure. And when we went to the railways, they were telling that, see, we don't know the sky above the railways. We can give permission to the sky above the railways. We know the railway line, we can give permission. But who can give permission above that? That we don't know. So finally, we did a SWOT. And the strength was, yes, of course, it was a good technical model with safety features like, flight logging, geofencing, lightweight lithium batteries, etc. The portable light drone that can be assembled and carried, it only required a small vehicle for carrying this drone. It can work at night too, carrying up to 3 kg. Of course, we selected that model. Very fast delivery, and even that is to cover 10 kilometers in 5 minutes. And temperature of the whatever was given was maintained for delivering the lab samples, and the loading and unloading were quite easy. Now the weaknesses. Actually, what happened? The drone Didis in NHSRC, they were trained for operating a drone that are meant to supply pesticides. So when they came back, they were asked to unload the medicines. They were quite confused. So that was one challenge that we faced. And actually 3 pilots, that is from the vendor side, they had to stay in the area and go to both spoke and hub manually, okay, because of this landing issues. Like you have to take off and land in presence of the flight operators. So anyways, they have to go. And it needs a lot of expertise and training for assembling, calibration of the drones, etc. And of course, in our area, there's no such drone training institute or expertise, even where we could get support. Yes, there are opportunities. So the final recommendation that went from our side was it can be used in hard-to-reach areas, as Dr. Rashmi correctly pointed out, as well as in disaster situations. Political commitment is high for starting the services, but it should be, of course, the regulatory framework should be in C2. The drone training institutes have been set up around India, and though in our part of the country, we don't have much such institutes. Well, the opportunity was it is acceptable if you do proper dissemination or proper awareness campaigns. The threat is the ecosystem, it has to be established. The single window required for permission and other necessary administrative services. That is very much essential. The procurement policies are yet not clear, neither the specifications, the guidelines for long-term maintenance, that should be there. And the Wi-Fi and electricity were required throughout. So technological improvement is necessary, because if you have to use in disaster situations, these are very utopian situations where you get Wi-Fi and electricity. So the potential for drones and risk assessment, monitoring, and response very much in vogue. And lately, in this Wayanad landslide that happened in July 2024, it was used extensively and successfully. So it was used for rapid damage assessment with high-definition cameras. They captured the detailed images and videos of the terrain, enabling authorities to assess the damage quickly. The search and rescue operations, actually the dense vegetations and unstable terrain made it difficult for the ground teams to navigate the area safely. So these thermal imaging cameras were used to locate the survivors trapped under debris. And the mapping and monitoring was done, like the high-resolution maps were created by drones to monitor changes in the landscape, such as if new cracks or potential landslides develop, so that this would provide information to the rescue team that are working so that they can be moved to safety. And additionally, the maps were used to plan and execute the relocation of the affected communities to the safer places. This was one part, that delivery of essential services. It was carried on till the routine services could be established or the transportation system could be established. And communication and coordination was also carried on between the rescue teams, where conventional networks failed. So basically, for using drones in the disaster situations, we need very highly technologically supported imaging sensors. For example, these visible light cameras, they are used to monitor the wild or urban fires, the thermographic cameras, the hyperspectral cameras, which detect thermal anomalies prior to earthquakes, the LIDAR that detects the landslide areas, and INSAR that assesses earthquake damages and to measure the surface displacements. So basically, these UAVs with advanced sensors can deliver high-resolution mapping, thermal monitoring, environmental data collection, 3D modeling, and generating high-definition maps for further planning in disaster situations, and of course for geophysical hazard detection. So in the disaster preparedness sector, it can be used for risk mapping, for infrastructure assessment, and for supporting emergency planning as well. And of course, for this, we need to use it in our mock drills as well. For we do conduct mock drills, and many states the mock drills are being conducted regularly. So if we can, pilot the drone usage for mock drill, then only this can be used in future. Till now, no such mock drills are being conducted using drones as a part of the mock drill. So this is a scope that we need to explore. And of course, for the search and rescue, the thermal imaging that was used, this is also used by NDRF and other NDMA teams. Now, the rapid health assessment, this can be another area where the drones can be used, to assess the injuries, displacement, and the supporting triage and deployment decisions. Sometimes, the volunteers, who are deployed or the QRMT teams who are deployed at the site, they get confused. So they can connect via telemedicine supported drones to, decide on whom to triage and send. The communication support, it can be used to ensure data flow between field teams and command centers. In the mitigation, it can be used for surveillance purpose, for mapping mosquito habitats post-flood, and for tracking zoonotic threats, for monitoring water stagnation and contamination. And in the environmental monitoring, it can detect chemical spills, air water contamination, provided they have high definition sensors, and prevent secondary health crisis and help prioritize mitigation action. Now, what is the future for drones? Future of drones in disaster management. Firstly, it needs to be supported with AI, advanced AI capabilities, so that they can operate autonomously. Otherwise, as I told you, Wi-Fi and electricity, if it is needed for operating drones, then it is very difficult. Number two, we need improved sensors. And number three, the swarm technology, that the use of drone swarms, as you see now, it is being used in warfares. Now, if it can be used for increasing the coverage area for large-scale mapping, then it is very useful for the planning the disaster response, activities. And the telemedicine-enabled drones, that is another scope, and integration of this drone technology with the NDMA, SDMA platforms is also needed for effective disaster management. So, the way forward. The way forward is the first and foremost that we and also AIIMS Guwahati team faced as the regulatory framework. Though they are in situ, but it is not disseminated, neither the higher officials at our state level or other ministries, they are aware. So strengthening the regulatory framework, simplifying and having a single window online system for application, developing clear SOPs for risk-based operations, and establishing a robust airspace management. So these are the few things that needs to be worked on before deploying this drone for healthcare management. And we also need to get trained. We doctors or health professionals also need to get trained. We cannot have third-party vendors for operating drone in the long-term sustainability. So that is one other issue. So also we need regular audit of the training institutions and certified operators. And we need to develop weather-resistant drones for healthcare emergencies, mandatory remote IDs for all medium and high-risk operations, and of course, is promote R&D under Make in India with incentives for high-end drone components, strengthen cybersecurity standards, as she's rightly told that where there is a high urban population, we cannot just simply move on with this drone software technology smoothly. And supporting innovations in battery technology, collision avoidance, and AI-based navigation. Setting up drone ports, charging stations, and regional maintenance centers. This is very important. Until and unless we think about sustainability, we cannot deploy drones for larger health care delivery services. So this is also very important. Not only preparing trained personnel who can operate drones at the health facilities, we also need to have this infrastructure and create an integrated drone hub in medical colleges and in disaster response units and agricultural universities. We can encourage PPP models for drone logistics, and we need to expand the DGCA certified drone training centers. Otherwise, the training centers will mushroom, and we cannot ensure the quality. Introduce drone technology modules in engineering, public health, and management curricula. Now, this is something that needs to be worked on before we have this mass scale deployment of drones for healthcare delivery services. And specialized training for the police, disaster response teams, and health workers also need to be carried on. And side by side, we need to also carry out community engagement and awareness activities. We need to establish grievance redressal mechanism for privacy concerns, promote transparent communication about data usage to build trust, and integrate drones into our regular immunization supply chains, telemedicine, and emergency response by specific national level guidelines that can be implemented throughout India, and use the drones for environmental monitoring, vector surveillance, and disaster management, and link it with our HIP portal so that we can get the data as quickly as possible and with ease. So these are some way forwards that we thought and we brainstormed after our own experiences. So thank you for your attention. This is the institute where I belong. Thank you.
So we now have just time for just a couple of questions. So if anyone has any queries or comments.
So no question. So thank you, Dr. Pal, for such a beautiful presentation, and Dr. Rashmi Agarwala. And we had a very two very different case studies, and how it was actually very useful in hard to reach areas, and how if it is the areas are well connected. Even during my experience as a EMR monitor of central team during COVID time, we saw how it was used for crowd management and also long distance thermal tracking. So way to go, and very importantly, the way forward and the infrastructure development, it is much needed, and also the bio waste which will be generated, and also the electrical waste which will be generated due to the drone parts. So managing that kind of biomedical waste also, when we are using it in generalized way, that we need to think about it also in long-term usage.
Course.
Yes. So thank you to the speakers and to the audience. So with this, we end this session. Thank you.
Thank you, dear chairpersons and speakers.
Thank you, madam.
I request our chairpersons to hand over the certificate to our speaker, Dr. Bobby Paul, Professor and Head, Preventive and Social Medicine, All India Institute of Hygiene and Public Health, Kolkata. Dr. Rashmi Agarwala, although drone technology could not bring you here today to us, we are happy that you could bring the session on drone technology to us. I now request Dr. Sanjay Qureshi to present our chairpersons for this session with their certificates. Dr. Monalisha Sahu, Associate Professor and Head, All India Institute of Health, Hygiene and Public Health, and Dr. Rakesh Kumar, Additional Professor, All India Institute of Medical Sciences, New Delhi. Thank you once again, dear speakers and chairpersons, not only for this wonderful session, but also for making it here today, despite all the difficulties. The next session for this afternoon, not just a clinic, how I created a scalable preventive care ecosystem as a PSM doctor. I request Dr. Sweezel to welcome our chairpersons, Dr. Sanjay Qureshi, Professor, Head of Department, Bharati Vidyapeeth, deemed to be University, Medical College Hospital, Sangli, onto the dais, and our second chairperson, Dr. Ashwini Katole, Assistant Professor, All India Institute of Medical Sciences, Raipur, will be joining us online. I also request our speaker, Dr. Arundas H., Founder and Chief Physician, Mediwell Clinics, to kindly take the dais. Chairpersons, kindly note this session is for half an hour. I now request Dr. Sanjay and Dr. Ashwini to kindly begin the session.
Well, a very good afternoon, and at the first, I would like to thank all the organizers and the IFSM for giving me this opportunity to chair this very important session. And I introduce our speaker today, is Dr. Arun Das, who is the founder and chief physician, Mediwell Clinics, and he has a fellowship in diabetology. He is the member of Epidemiology Foundation of India, certified palliative physician. And the topic for his is a scalable preventive medicine, a PSM doctor. And I think the answer, he will answer the question which usually a MD preventive medicine, when he decides that when he comes to preventive medicine, what to do afterwards, what are the scope as far as community medicine is concerned. And I think he will give all the answers for this. Please proceed with the topic.
Very good afternoon, everyone. I would like to thank Goa Medical College and all the organizers, especially Dr. Jagdish, for giving me this opportunity to present about my center and how I developed it. So I'll be discussing about my clinic. It's not just a clinic. I'll be telling you how I created a scalable preventive care ecosystem as a PSM doctor. I did my MBBS from Amrita Institute of Medical Science, Kochi. After that, did MD in Community Medicine from KMC, Manipal. And after that, did a fellowship in diabetology from Aster Health, Kochi. Along with my MD, we had an integrated program where we did our certification in palliative medicine in Manipal itself. Also have other trainings in lifestyle medicine, family medicine, smoking cessation, and other key areas where we are not properly trained during our MBBS or MD curriculum, where whatever skill set I wanted, I have taken special trainings under all these areas. So what are the things which we have started from our side? One, the first thing is founded Mediwell Preventive Clinics. Mediwell Clinic was started in 2020 as a proper preventive clinic, but we started as a very small clinic. I'll be talking to you in detail about all these things later on. Second thing, we, along with some dermatologists and some other doctors, we've co-founded a cosmetology and skin clinic. We have also started a health academy, Mediwell Health Academy in India, and Elite Vista Research Consultancy, which mainly focus on research and development for small and medium centers, for assisting for data analysis for DNB students, and giving much more importance for research from 8th standard itself. Because those students, they should be critically looking at what they are learning, what they are seeing. So we have conducted a lot of workshops to give an insight into what research is. How should you critically read an article? How should you critically understand a thing? So these kind of activities we are doing under all these different verticals. So we know that preventive care is still undervalued in India. When it comes to a modern medicine, everybody is thinking about that curative medicine. If you come with an illness, you have to get a treatment. But preventive care is the core, or the primary care is the core, which is being undervalued. We know that there is a rising trend in chronic disease in India. When we look at the GBD-WIS diagrams, if you check, you can see that earlier it was many communicable diseases. Now, the rising trend is therefore non-communicable diseases like diabetes and other lifestyle diseases. And we know that before coming to a hospital or a clinic, the patient will be mostly getting influenced by a lot of social media influencers and all. And community medicine specialists, mostly what we have seen is they are limited to either academics or the public programs, or they are just following what is already there. We know that there are a lot of healthcare problems, a lot of problems are there. So all these problems are an opportunity. We can't say that there is no opportunity or there is no work for a community medicine doctor, or it is something entirely different. It has nothing to do with the clinical aspects. We have a lot of roles. First thing is we have to identify what all problems are there, and we have to find solutions for it. And all these solutions are an opportunity. And if PSM doctors, if we don't lead the preventive care in India, then who will? I'll just tell you my journey in short. After my MBBS, I joined a government hospital as an ad hoc doctor, where I was working with the pediatrics, casualty, and many other departments, along with the administration of that government center. During that time, I opened a very small clinic. It was there for like 2 to 3 years. I worked in this government hospital, and then during that 3 years, I understood that, okay, community medicine is a specialty which will help me achieve my goals, because I wanted to become a doctor, not a specialist. I wanted to see the people. I wanted to make a long-term change in the community. That is why I chose community medicine. The first question when I joined community medicine department during the icebreaker session was, why did you choose community medicine? Was that by choice or by chance? Most of the PSM doctors might be hearing this question. For me, it was by choice. I have thoroughly researched. I've discussed with a lot of faculties. I've had contacts with many national faculties. During the postings in the government hospitals, we have interacted with the national program coordinators. So we had gone for different meetings with in the collectorate and all. So during that time, I understood, okay, this is a specialty which many of us during MBBS might not have realized how beautiful it is. So that shaped my idea, and I thought, okay, this is a specialty which I should be taking. And for my MD, I just selected only MD community medicine. So it was purely my choice of selecting MD in community medicine. And I'll be telling you all these steps because it was my journey. I'll have to tell you because many of you might be in that situation, little confused whether to do it, whether to start a clinic, or you will be still thinking that I should take an MBA. I should take a PG diploma in hospital administration. After so much of years, I'll do it. Because I had this idea and I had discussed with some people, seniors and all, they were like, okay, no, Arun, like by the time you reach around 40, 45 years, you will be a little more mature enough to handle all these things. After that, you can start your own centers and all. But at 20 years and 21 years, you're not going to do it because you don't have any idea about what is happening or what is the reality. But after my MBBS, during the course where I was working as a medical officer in the government center, I started a very small clinic, and that clinic has grown into our medieval ecosystem with main 4 verticals, including a research consultancy, academy, clinics. And this is the center which I started in 2020. The very small clinic was started in 2018 itself, but this is the proper center which I launched in 2020. That is our MediWell clinic. MediWell, it's basically medical and wellness. That's how we created that name, MediWell. And why a preventive care ecosystem was needed. We know that there are a lot of gaps in the real practice. First thing is chronic disease being diagnosed very late. As of now, let's take an example of diabetes mellitus. Diabetes mellitus, we mostly check the HbA1c of a patient. We know that the natural cause of diabetes mellitus, where there is insulin resistance happening, hyperinsulinemia, all these things are happening in the first phase itself, right? But mostly what we see is when a patient gets some wound which is not getting cured, they'll end up coming to the hospital, or they have a recurrent urinary tract infection or some other problem, they'll come to the hospital. That time they will be diagnosing with the disease of diabetes. But that's not the time. We have to identify it very much early. When? With the help of HbA1c, yes, maybe in the initial stages we can identify. Even before that we can identify. We know that in the natural history there is something called insulin resistance and hyperinsulinemia. So how do you identify hyperinsulinemia? You can check the serum insulin in the early morning. You can check the HOMA-IR. You can, so even before the HbA1c rises, we can identify that this person has a high risk of developing diabetes mellitus or pre-diabetes. So second thing, patient always depend on Google's Reels, influencers more than the doctors. If doctor says, okay, you have to take this medicine, doctor, one of my relatives told that this is not good. Or they will have their own idea from different, because a lot of information is being bombarded in these times. And preventive care, when it comes to preventive care, or when you say that you're a community medicine doctor, they mostly, okay, you will be doing some health talks, or you'll not be practicing anything. You'll be just giving talks. One more example I can tell you, when we talk about antibiotic stewardship, we will do a lot of workshops and we'll say that, okay, antibiotics should not be used unnecessarily, rational use of medicines should not be there and all. But how many of us have given a proper training, or how many of us have got a proper training during our curriculum, how to properly differentiate between a bacterial and viral infection? How to properly read a CBC? What are the different ratios which we can analyze from a complete blood count, which will tell you this could be a bacterial infection, this could lead to a hospital admission, and what are the other parameters, cost-effective parameters which we have. So we have to show them, we have to show exactly what we are doing. So it should not be just giving some talks, we should be showing them in reality what exactly is community medicine or preventive medicine. And the primary care is fragmented. As we all know that we have a huge out-of-pocket expenditure in India. Even though we have a lot of government centers and with a very good stratification of primary, secondary and tertiary center, most of the people are dependent on private sectors. Those who are financially well and good, financially well, for them it's not a problem. But there is a particular people, maybe just above the BPL line, not very much affordable for all these costly treatments. Since they are not BPL, they might not be going to the government centers, or they might not be availing a lot of other facilities. They mostly end up selling their personal properties for treatment. Or they'll be actually turning into poor only because of the medical expenses. So out-of-pocket expenditure is one thing which is there. And majority depends on private hospitals. In a private hospital, if you look at the private hospital, 70 to 80% of the patients coming to a private hospital can be managed in a primary care center. They might not require a specialist care by a cardiologist or a neurologist. So the primary care is actually fragmented in our country. There is no continuity, no team-based approach. See, I've been telling a lot of problems. All these problems are an opportunity for a community medicine doctor. We can create solution for it. And over-medicalization and unnecessary tests are very common. Because when a 60 or 70-year-old patient is coming to an OPD, when you look at their prescriptions, you can see that X, Y, Z medicines from an orthopedician and a lot of other medicines from a rheumatologist. There could be overlap between it. There could be drug interactions which an orthopedician might not be noticing it, or the patient doesn't know that what all medicines they have. They will take this red pill, green pill, other one, half a tablet of this one. They might not be knowing what to take. And now we can see that with a lot of Indians are migrating to other places. Every house is an old age home. Most of the houses are changing into an old age home. Majority of them doesn't know what to take, like the basic needs itself are not being covered properly. So, and this community medicine expertise is rarely applied in the private sector. We know that we have job opportunities in national programs or other WHO or medical colleges and all, but in private sector, in a hospital, what is the role of a community medicine doctor? How can we pitch in? How can we use this particular, I've been telling a lot of issues, problems that we are facing. So how, as a community medicine doctor, we can provide a solution for it. And another thing is lifestyle medicine. Lifestyle medicine has to be approached in a proper way. I hope all of you know about the 6 pillars of lifestyle medicine. So if any lifestyle disease has to be treated under all these 6 domains or 6 pillars, you should not be just telling that, okay, you should do diet and exercise and then prescribe some medicine. In that way, if you say somebody that, okay, if you are telling a patient that, okay, you should do a diet, exercise and take this pill, mostly that patient after some months or some years, they'll come back, the medicine dose will be increased. Later on, they might develop some complications also. So a very good interaction with the help of a proper team is needed for reversal or at least management of all these community medicine, all these lifestyle diseases with the help of a community medicine doctor as a team lead. So our vision is to create a trusted, community-centered preventive care ecosystem that integrates family medicine, lifestyle medicine, and public health. In our medieval clinical ecosystem, we have a family medicine OPD. We have other specialists as well, but still, any patient walking in will have to meet the family physician. They are either a community medicine doctor or an MBBS doctor who has been trained under our curriculum. We have made guidelines and SOPs. So any MBBS doctor is joining our team, they will have to undergo that 3 months of training with us. Then they will be managing the family medicine OPD. So any patient, irrespective of the reason, whether it is chest pain or a preventive health checkup or just walking in just to see how they are or any acute emergencies, all these will be handled by the family physician initially. The family physician will decide and then they will tell, okay, if that can be managed at that level, they will manage. If that patient require a higher referral, in our hospitals, clinics itself, we have specialties, but they cannot directly go and see an orthopedician. The patient cannot directly go and see a pulmonologist. The family physician has to properly refer. We have our specialty to OPDs depending on the need with the help of data because it's been from 2020 I've been starting this. So we know that, okay, what is the patient load, what is the age category, which all diseases are more prevalent and all. So according to that, the specialties are there in all our centers. Then we have a specific lifestyle medicine and nutrition department where dietitians, physiotherapists and health coaches are there who help us in designing a proper lifestyle management for all the patients who require. And a physiotherapy and rehabilitation, especially for stroke rehabilitation, we have a specific unit with all the latest machines like IFT, UST, and other basic physical rehabilitation equipments. Then we have our own dedicated diagnostic labs and procedures where one center will act as a main hub where most of the equipments are there, and the other centers, small peripheral centers, from there the sample data, the blood collection will be done in that particular place and it will be transferred to the main center where the procedures are done. And we have our own pharmacy and a Medimart. And home and community-based care are there where our staffs, including the nursing care, as I told you, like majority of people are there who are, most of the houses are like an old age home right now. So majority of the people are alone. They don't have anybody to take care of them. For them to reach the hospital, they'll wait. If they have a mild issue, they will wait. They'll wait for a couple of days. Once they set into a severe breathing difficulty or a severe problem, they'll visit the hospital. By the time there will be a need that they'll have to get admitted in the hospital. So before that, they can give us a call. Our team or our health coach will talk to them. If needed, our team will go and visit. And if teleconsultation is required, our doctor will do the teleconsultation. So this is a trial thing which I am doing, and I'm not doing in a metro city. I'm doing it in a very small village in Kerala called Alapi, which most of you might have heard of. So we have different verticals. First one I have already told, Medieval Clinic. And, another one is Medieval Health Academy. In Medieval Health, everything was initially under Medieval Clinic only. Then we have a different team for everything right now. Because with the help of our chartered accountants and our guide people, they have told that these things has to be separately registered. And so we have 3 companies right now. And the second company is because the GST and all these laws, everything is different for the clinic and for the academy. So we have a Medieval Health Academy. We are conducting many national skill development courses through the Medieval Health Academy. We are giving training for a lot of nurses because there are a lot of nurses in Kerala. They have completed their course because of many family reasons or other reasons. They have not practiced for 5 years, 10 years, 15 years and all. Now many of them wanted to work. So we give them training up to 6 months in our clinic, and we try to get a job for them somewhere in and around. We have connections with the other small centers or other places. Somehow we try to get opportunity for them to work on. And many people are working with us on freelance basis also, especially for this home care and all these nurses who are trained under us, they are working. Also under Medieval Health Academy, I have launched a flagship program for doctors, and the first cohort will be completed in this December 30. That is FCLM, Foundation Course in Lifestyle Medicine, where I have a lot of community medicine doctors, gynecologists, pathologists, many doctors have enjoined. First cohort of 20 doctors have completed their 3 months training in the Foundation Course in Lifestyle Medicine, where we teach all the 6 pillars of lifestyle medicine, where international faculties from NHS UK, British Society of Lifestyle Medicine are taking the classes. And we have this Elite Vista Research Consultancy. Through that, we give an insight to school students, especially 8, 9, 10, 11, 12 standard students, what is research, how to critically think. If you're listening to, or if you're reading a news or an article, you should not be just simply blindly, take it. You should be critically asking questions. And what exactly research is. Because with the help of research, it's not only for publications and for promotions. Through research, evidence-based approach, we can do a lot of things. So we have collaborated with a lot of schools and colleges. Also, we have a data analysis unit where multiple data analysts are there who help DNB students mainly. DNB students, they don't have a proper guidance from their college. So we help them in doing their data analysis. We guide them through their thesis. We have a team for that as well. So that is Elite Vista Research Consultancy, which is actually under Medieval Health Academy as well. Then, if I am running a clinic, I am seeing a lot of patients. And if I am not there, if the clinic is not functioning, that is not a sustainable model. I have to create a system. So I have created a system, and that system is working even if I am not there. Even if I am sleeping, the system will work. So with that, I wanted to expand. Like, I'm a beginner. So in this phase, I don't have so much money to invest. So we had gone through a lot of models and developed a medieval franchisee model where anybody who is interested can take up our franchisee. And we will do all the operations, activities we'll be doing, and only the franchisee have to invest. So we are trying to scale up our clinics by medieval franchisee models. And we have our medieval home care services and medieval Ecobites. Ecobites, as I told you, we have a pharmacy and mart. Through these mart, we are trying to give healthy food items, healthy snacks like mueslis, millet snacks, and we are with farmers to collect their own homegrown food items, and we are distributing it through our center, and that is medieval Ecobites. And we have exported also to Netherlands some of our products. So that's mainly mueslis, snack bars, chicky, those kind of healthy alternatives. Because I have been to many schools to deliver talks on healthy lifestyle. So during the talk itself or after that, what we can see is there will be a small snack bar where all these items, which I have told that not to take, is available readily. Because after the sessions, during the break, the students are going to that particular place, taking a ma or fruity or whatever it is. So what is the whole point in me taking a session? What is the whole point in the whole school conducting such a session. So I have told the school people that this is not feasible. You have to, so if you are telling the students not to do something, you have to give them a different opportunity. So from that was a problem, and we tried to find a solution for the problem. That's how Medieval Echobytes originated. So we have multiple products right now. And since we are not using so much of preservatives, the span is very less, maximum 3 months or 6 months. And we have our Medieval Social Responsibility Initiative, which was thought by my father since my childhood. Whatever penny you are earning, 5% should be for charity. So whatever activities I have been doing, including my clinic staff, some of them are interested. So we have our own savings. Every month we dedicate some amount, and this, with the help of our chartered accountants and all, we are actually kept it in a liquid mutual fund. Through that liquid mutual fund, obviously that fund is growing. And if at all any patient needs any financial support or any sort of activity, we use it from our social responsibility initiative, and we conduct camps and every other activities through our social responsibility initiative. And if somebody wants to donate us, we collect it under this initiative, and we do the activities in Medieval Clinic. And we have our corporate wellness. We have collaborated with multiple companies in InfoPark, and other small and unorganized companies are there in Alapi. So we have collaborated with them. We have given them privilege cards so that they'll get discounted doctor consultation. They'll get annual checkups. Many factories, there are sound-related problems. So we conduct regular checkups in these unorganized companies. So these are the different verticals which we are working. And I'm not doing this alone. I have a team for everything. I've made a system for it. So even if I am not there, all these centers will work properly.
5 minutes.
Okay, sir.
Yeah, okay.
So I'm just skipping these things I have already told. We have franchisee models. One thing, branding and digital presence. As we know that most of the people are looking at social media. So we, as doctors, as public health experts, we have to have a proper branding. And our health education, we know that we have a lot of health education portals. So social media is now has to be used as a ethical health education portal. It should not be used just for giving some, it has to be properly used as a health education portal. So clinical care, support service, knowledge and training, growth and outreach. These are the main 4-pillar framework of Medieval. And from a one room that started in a multi-branch, we have around 7 branches right now. Out of which, 2 are branches, 5 are franchises. And the main challenge is nobody trusts a new model, especially when you talk about preventive health. They're like, what is preventive health? You give us medicine when we are sick, that's it. And another is building team. Building team was a tedious task because there were a lot of people, but none of them were trained. So training them, keeping up the protocol, keeping up the standards which we need, everything was a tedious task. And operational financial process. Initially, we had this operational financial process because when I was not there, it was not working. When I was there, I will tell, okay, this has to be done this way. So that is how we try to create systems for everything. So with the help of systems, now operation is fine. And for finance, for scaling up, we have franchisee model so that somebody else is investing for us. And we are expanding as the branch. And lessons learned, it's not an individual, system has to work. And preventive care needs communication. You have to communicate with your patient. You have to communicate with other stakeholders. Then only you will grow. And a team-based care is a future. You have to start small. Don't keep thinking that I'll be starting a clinic or I'll be doing this venture. I'll be starting some health tech company. If you keep thinking, you will keep on thinking. And by the time somebody else will start. So even if it is small, please start. And branding is not optional. You have to do proper branding. And public health knowledge is a superpower. So these are the future things which we are planning to run 24 centers. Mostly, I have clear-cut plan for the next 5 years, what exactly has to be the position of Medieval clinics. To every PSM doctor here, so the crowd is less. I think since this is online, I think many might be watching it online as well. So for everyone, you already have the knowledge. So what you have to do is convert this knowledge into skills and and you create a platform. What you need is a very small platform, and you should have that courage, that guts to start. Even if it is wrong, even if you make a mistake, it's okay. Start it, learn from it, then do it. And thank you so much for this opportunity, Dr. Jagdish, and all the organizers of this event. I'm very much thankful to all of you. And I want every community medicine doctor to know that there are a lot of opportunities out there. Nobody is going to come and give you the opportunity. You have to create it. So find out, look into the problems, and then find a solution. And research, I don't have so much of publications, but whatever things I have done through data-driven approach. Simple example, if I am starting a clinic, you know that qualitative analysis is there. If I am starting a clinic, we train our staff first, we send it to that particular location. There will be a quantitative survey done. There will be a qualitative survey done. They'll go to the auto stand. They'll go to multiple places. They'll talk to them. And they'll get their feedback. And sometimes we do record it as well, just like the qualitative study. And we get a proper evidence-based approach that this particular place needs a center for medieval clinic. And this is how I apply research in my practice. I don't have so much of publications, but still I do apply it and try to grow with the help of community medicine. And whatever I have done till now is purely the basics which I have learned from Community Medicine Park textbook and through the guidance of all my teachers. Thank you so much.
Well, Dr. Arundas, it was quite a good presentation. No wonder you have got a Best Preventive Clinic Global Healthcare Awards, I think.
Thank you, sir.
2025. And it was an eye-opener for all the ones who are in public health and preventive medicine. Because scope of public health and general preventive medicine has been very aptly given how the journey goes for a preventive medicine clinic to start. And the core clinical preventive medicine, which he has told was very rightly about the 6 pillars, and the emerging clinical areas for a preventive medicine is nothing but a wellness clinic. Wellness clinics comes under all the levels of prevention where we can apply, I think. And the most important part of this topic was he has supported it with the research consultancy, and that is the very good thing which will keep him going on, extending and going to what you say, learning scope, learning curve which is there, which will really reduce early, and he will be, you are also doing research, that's a good thing. Thank you so much. And just to share a coincidence, myself, I have been a gynecologist for last 20 years. Lately, I stopped practice, and now recently, I have started Sparsha Preventive Medicine Clinic and Geriatric Care Services. And believe me that when I started that and when I was preparing the flyer for that, the sky was the limit. Sky was the limit. What services I should give, I can give and everything. Okay, it was an eye-opener for me also and a good guidance for all of us. Thank you so much.
Thank you, dear chairpersons and speakers. I now request our chairperson to hand over the certificate to our speaker, Dr. Arundas H. Founder and Chief Physician, Medivell Clinics. Thank you, Dr. Ashwini Katole, for being here with us at YLNC 2025 Goa online.
Thank you so much. Thank you.
I now request Dr. Hemangini Kesha to present the certificate to our chairperson of this session, Dr. Sanjay Qureshi, Professor and Head of Department, Bharati Vidyapeeth, deemed to be University, Medical College and Hospital, Sangli. Strengthening of MPH programs in India is the next session of this evening. I request Dr. Sweezel to present our chairpersons, Brigadier Dr. Kunal Chatterjee, Professor and Head of Department, Community Medicine, Armed Forces Medical College, Pune, and Dr. Avinash Kavi, Associate Professor, JN Medical College, KLE Academy of Higher Education and Research, and welcome them with a flower onto the dais. I also welcome our panelists, Dr. Anand Krishnan, Professor, CCM, AIIMS New Delhi, who will join us today online, Dr. Pankaj Bhardwaj, Director, ICMR, NIIR, NCD Jodhpur, and Dr. Bobby Paul, Professor and Head, Preventive and Social Medicine, All India Institute of Hygiene and Public Health, Kolkata. Dear panelists, kindly take the dais. Panelists and chairpersons, kindly note, this session is for 30 minutes.
Yeah, thank you, the organizers, for giving this opportunity. We have a very distinguished set of speakers today for this session. I would first like to welcome Dr. Anand Krishnan, a name well known to everyone in this audience. He is a professor in AIIMS New Delhi. He's got multiple fellowships and many awards. Dr. Krishnan has been a very erudite person and a guide for so many people. So many students remember him. And he's got his area of expertise is non-communicable diseases, mortality surveillance, influenza, primary healthcare, and pedagogy. Numerous research publications, 425 with an H index of 65. He's been cited amongst the top 2% of global researchers from 2020 onwards. So it is indeed a privilege to hear Dr. Krishnan in this for the young IAPSM, young leaders in this conclave. Dr. Krishnan, sir, the stage is yours for your talk, please.
Thank you. I hope all of you can hear me. Can you please confirm that you can hear me?
Yeah, we can hear you. We can hear you, sir.
Okay. Thank you. And I request Dr. Bobby Paul to start the slides. Or you want me to share from here? I'm okay with either of them.
Sir, we are sharing it from here. Are you able to see the slides?
Not yet.
Not yet. So we request the organizers.
I can see all of you. I think
yeah. So I request
the
organizers to share the slides to Dr. Krishnan also, if that is
possible. Yeah, now I can see.
Yeah, that's great. Yeah. Thank you.
Thank you. Thank you, sir, for your kind introduction. And my most sincere thanks to Dr. Kakotkar for giving us his time for this session when I requested him. And also it is very fitting that we have somebody from Kaher, Belgavi in the chair, because this whole thing started from there. If you all remember, there was a session in the previous IFACon in Belgavi about the MPH programs. And some of the names that you see here, some of the issues were raised there, and then this is a next step from that. So this, we are going to discuss about the need for MPH courses. And I think in some ways this session segues well with the previous courses. All we are saying is that either the previous one, and I congratulate Dr. Arun for that wonderful presentation and his work. There are multiple options available to you. Stay grounded in the community medicine traditional, move to the preventive medicine as he has done, or move to public health. So you have different options. It is just your choice. These are not competitions amongst each other. So can we go to the next one? So the frame, as you can say, is framework for restructuring MPH programs in India. And this is the initiative which I said started in Belgavi when three of us, which is myself, Prabdeep and Biju Soman, were there in Belgavi. And there was a panel discussion on the state of MPH. And most of us were lamenting the fact that most of the MPH graduates are unemployable. Then somebody said to me that, sir, you have to do something. We cannot continue in this situation. So this initiative follows that prodding by Prabdeep and Biju. And then we decided to include all premier public health schools in the government sector. So you have Rajiv from JNU, Lakshmi from PGI, Shamanna from University of Hyderabad, Sitanshu from Jipmar, Senthil Amudan from Nimhans, Tarun from ICMR, Harshad Thakur from Tata Institute of Social Sciences, and Biju from Sri Chitra, and Prabdeep is from Indian Institute of Science. So we got together, we identified our questions, and we have had multiple online meetings. We have had one physical meeting hosted at IISc Bangalore to discuss threadbare all issues related to MPH program. This is completely for national good. There is no hidden motive for any one of us. All of us are very well established people in our own fields. So, and we are open. So feel free to discuss any issues that we come. But I think it's time that we address the elephant in the room of MPH programs. In fact, I was told that why do you have an MPH this session in a IAPSM where MPH students are our competitors. We should not encourage such. So we hope that after today's session, you will be more open on it, but I'm not so sure about it. Next slide. So we'll start with a discussion on need for MPH programs and why we should have a better customized programs in Indian context. And three of us will discuss the three issues that are to be taken up for this. The report is going to be wide-ranging, but we will focus only on three issues on as highlighted here. Next. The first and foremost is the question of, as you said, who is a public health professional, or who is a public health workforce, and how many do we need? So there is always a confusion. A public health workforce is generally defined as people who work in public sector, doctors, nurses. Obviously, that is not a good definition. But there is no alternative definition. One option is obviously to look at public health cadre, which the government recently announced. But that is also a very narrow definition of public health people. Are only people those who work in the government within NHM are public health people? Obviously not. So public health workers should be people who are responsible for providing the essential services of public health, regardless of where they work. But that raises the question, what do you mean by essential services of public health? Do we have a clear definition? And then say who delivers these services. And it does not matter where they work. Next. So this is one definition where public health functions have been defined as health surveillance, health protection, health promotion, health planning, regulation, health services organization, delivery, and evaluation. And correspondingly, workforce can be defined. Most of the time when we are defining public health in this context, we only define health program administrators and managers. Whereas there is a wide variety of people: occupational health, environmental health, epidemiologist, biostatistician, nutritionist, health promotion people, health educator, researcher, teacher, social scientist, economist. Aren't they all also part of public health workforce? And they can be in government, community-based organization, academy. So we are asking for a much broader definition of public health workforce. Next. And then the question is, how many do we need? Again, since we have not defined well, getting this number is very difficult. But if you purely look at the government cadres, as you can see from Tamil Nadu, Odisha, Maharashtra experience, they are less than 1 per lakh or around 1 per lakh. And there is a normative standards of about 3 health managers per 100,000 population. Again, based on the public health cadre. But we believe this is a very, very small number and very narrow definition of public health. Next. So, next. If you look at US as an alternative experience, you can see their ratio is 158 per 100,000, including federal, state, and local public health authorities. But here we are talking of 3 and 4, and there it is 158. And in some places, they have also estimated 55 per 100,000. And USA produces about 17,000 MPH students every year. And you can see bulk of them are not working in government. They are working outside government and academia. Next. Whereas India has about 129 MPH programs. And we produce about 3,000 MPH students and about 1,500 to 2,000 MD community medicine. So around 5,000 products per year. And India's population is around 4 times that of US. So clearly, we have very few people, because we have defined community medicine in a very narrow way. We are saying that there are very few people are needed, and therefore we are creating a competition where actually there should be none. Next. Why should we customize MPH programs for India? Because India's system is very different from most other systems, Western systems. Our disease burden is different. Other challenge that MPH programs in India faces is of diversity. Different students from different sciences come, and a wide variety of institutions, medical, non-medical, offer these courses. So how do we convert all of them? Yet we want a uniform product at the end. How do we convert such varied kind of people and yet ensure a uniform product is our greatest challenge? Plus, we already discussed a high degree of medicalization of public health education in India, which neglects managerial social sciences. Next. And our MPH programs are highly classroom-based, theoretical. They have very little exposure to practicality, to the health system. Those departments and institutions are extremely under-resourced, and there's a poor regulatory oversight. And with the national education policy, even those are facing serious challenges. Coupled with a poor career-defined opportunities, people struggling, and we expect MPH graduates to know everything. Even though from epidemiologist to a manager to a policymaker to a researcher. So clearly, we are not producing the people whom we want. Next. So I will stop with this group of recommendation that India needs a clear, comprehensive definition of public health workforce, and we need to estimate its need. We need to get the demand and supply issue correct. Otherwise, what will happen is what we saw with dental education. There's too much, no demand, but too much supply, and we'll end up in the same boat. But currently, we believe that we have a very low number of public health workforce per population. And finally, we need to develop India-specific MPH programs while adopting best global practices. Better exposure to primary healthcare, health system is needed. So my parting message to all of you is do not fight with each other. Do not fight for crumbs, but fight together to make the cake bigger. Thank you. Next slide. And with this point, I would hand over this presentation now to my colleague, Dr. Bobby Paul, who will focus on the multidisciplinarity need for in MPH programs. Dr. Bobby, please.
Thank you, sir. Before we proceed, I would like to introduce Professor Dr. Bobby Paul. We just now heard her regarding the drones and technology. She is the Sub-Dean, Professor and Head of Department of PSM at All India Institute of Hygiene and Public Health, and multiple fellowship with 18 years of professional expertise, and with a H index of 29 that speaks the volume of the research she is into. Over to you, madam.
Thank you, sir. So moving on to the next part of the presentation, that is imparting multidisciplinary in MPH programs. As we had initially looked into sir's presentation, so defining the public health workforce, while defining it, we have seen that only medical professionals, that is only MD community medicine, won't suffice. We need various cadres, various trained professionals rather, to be pooled in together to have an effective public health workforce. So since delivering public health is inherently complex and requires coordinated efforts across multiple sectors and demands an inter and multidisciplinary whole of society approach. Now, what should be the entry criteria? We had, delved into it deeply, and we had multiple rounds of deliberations on that. And to bring the non-health graduates as well as the medical graduates together is a bit difficult issue. It's not a bit, it's a, it's a very difficult issue. The non-health graduates coming from social sciences, humanities, management sciences, law, natural sciences, etc. Now, we thought that they must demonstrate at least 1 year of health sector experience to understand the, the crux of MPH program. Otherwise, we at All India Institute, we have number of non-medical public health courses. And what we face while teaching when these fresh non-medical graduates do enter, that is, they do not have the basic understanding of public health. And now when they go on to move on to doing any diploma in public health workforce, there also we face the difficulty in making them understand. So this we thought that while we are, being inclusive of having this non-health graduates in the MPH program, so 1 year of health sector experience may ensure the baseline competency. So the entry eligibility that we thought that maybe the health graduates, that is the Bachelor of Public Health, we do have this course across India in many institutions, and specifically in PGI Chandigarh we have in the government sector. And the graduates are, if the graduates are registered at any of the councils of the allied sciences, so this automatically sets a standard that they have in their understanding. And of course, those non-medical graduates, they can have a mandatory foundational course through NPTEL for both as well for health and non-health graduates for cross-learning. Now, what should be the core competencies? See, we have MPH programs across India, but if you match one MPH program curriculum with other, you will see a lot of discrepancies are there. Somebody is focusing on some particular competency, the other institute having their similar type of workforce is focusing on another type of competency. So basically we should, that is good, but we should have a clear-cut, spelled-out core competency in public health. We do have it in our MD Community Medicine as per NMC guidelines, but this is, uniformity in this curriculum is lacking in MPH programs. So basically, we thought of all these 9 competencies, that is the principles and practice of public health, health system skills, evidence-based public health, health management principles, design and evaluation of public health programs, leadership and team building, determinants of health, public health policy, health promotion and communication, and all this should be, skill-based. See, we have not delved into possession of clinical skills much because we are trying to be inclusive of both medical and non-medical graduates in, being inducted into this program. And if you have a broader vision, you can see that possession of clinical skills actually does not value add to most of these competencies. So it is not mandatorily required. And of course, the institutions which are carrying on these MPH programs, there has to be a set guidelines for those institutions as well. See, for our NMC courses, we have a set standardized guidelines, okay? And by this, we also tend to improve our programs. But for MPH programs, mushrooming across India, we don't have such set standards. And so here we thought that for ensuring this multidisciplinary approach, we should also ensure multidisciplinary faculty. The faculty composition should ensure that the institution has core strength to teach the core competencies, and it should not borrow faculty for these courses from outside. We also acknowledge the challenge to recruit faculty from all disciplines. Yes, it is very true. So for the initial period, this may be difficult to implement, but if we have such clear-cut guidelines, national level guidelines, I think in the long run, this can be institutionalized as we have institutionalized NMC guidelines across medical colleges. So, and if specialized MPH courses are run, it should be based on institutional strengths and their faculty. Now, another important issue is MPH in medical schools. The strengths, and we also thought about this, like what should be the, we have different schools of public health. Even PGI Chandigarh has a school of public health. AIIMS Delhi, of course, it has, and many other institutions do have schools of public health despite the Department of Community Medicine. So what is the strength if both are together? And if the medical schools, they run MPH programs, so what are the strengths? What are the strengths and weaknesses? The strength being it has got if the medical schools run MPH, there's a close working relationship with the health system so that the MPH students can be trained, and presence of a well-developed field practice area which can be useful for their training. The weakness is the multidisciplinary faculty. That is a weakness. And if the MPH, medical schools runs the MPH program, basically it lands up in medicalizing the training in public health. And for any medical school, medical undergraduates and postgraduates, always remains the focus. So the MPH students, the non-medical MPH students, may have the chance of getting lower priority. So what should be the models? We also thought about this. So both can be separate entities where the Department of Community Medicine runs the community medicine program, and and the School of Public Health runs the MPH program. That can be, it is there in AIIMS Jodhpur, I think. This type of model is there. And the problem is, like, there may be constant friction between the two entities. That is one major problem. The both are merged into one entity. That is, it can, the same institution, the same department, that is, it can be named as Center for Public Health and Community Medicine. It can run both the courses together. But the issue is, again, NMC has got a clear-cut guidelines that one department cannot run two separate similar courses until and unless it has got dedicated faculties for the two different courses. We have, our institute has got this model. We have run, we run the MD MPH epidemiology program as well as MD community medicine program. But we have dedicated faculties for both the courses, as well as some, there are faculties who are shared for both the courses. And so this is one example that I gave for my institute. This is a collaborative model where two are distinct entities, but formal arrangements are in place and informal collaborations are encouraged. So there is no superstructure, or both entities are headed by separate persons. But this requires, of course, administrative provisions. Now, managing MPH in medical schools. That is the guiding principles. What should be the guiding principles? The Department of Community Medicine in medical schools is a mandatory requirement for recognition by National Medical Council and must be retained. And public health is essentially a multidisciplinary discipline, as I told you. So we need multiple faculties of different disciplines to be put together to train properly an MPH graduate. But for MD community medicine, this is not mandatory. We doctors are have been training across India. So if we have the two courses together in an institute, we should have two types of faculties, as well as there should be complete professional and administrative equality between these two types of faculties to be taught in that School of Public Health. No discrimination should be allowed. And final choice of the model depends upon the institutional strength mechanisms as well. So after we again experience these models, we can better evaluate their appropriateness. In our institute, we have this unique course of MD MPH epidemiology program recognized by NMC. Nowhere in India it runs. So this course actually was initially started as this is a curious case, like we started it off as a 2-year MPH program, but then it was scaled up to 3 years, and it was accredited by NMC. Now these graduates that they pass out, they are taken up both as medical faculties, as wide UPSC guidelines, as well as they are taken up in other programs as well.
Request you to wind up, please.
Yeah.
Thank you.
So I hand over my mic to the next speaker. Thank you.
I'd like to introduce Professor Dr. Pankaj Bharadwaj. He's a director of ICMR National Institute of Implementation Research in Non-Communicable Disease, Jodhpur. Sir has been a fellowship from IPSM, IPHA, FAMER, and many other such organizations. Received R.N. Mehta Gold Medal in post-graduation. He is cited among the top 2% scientists from the Stanford list of scientists for consecutively last 3 consecutive years. Sir has been the chief editor of Indian Journal of Community Medicine, currently the president of IPSM of Rajasthan chapter, dean research and vice dean research, academic head at SPH IAIMS Jodhpur, and a number of research, more than 200 PubMed indexed article with an H index of 70. Over to you, sir.
Thank you so much. Thanks to the chairs and thanks to the organizers for the opportunity. So now let us take me forward. So what is so far been shared by Professor Anand Krishnan and Professor Bobby Paul. So when we have a lot of elephants, it's not a single elephant in the room, we have a lot of elephants in the room. So the first one was that it's a degree which is actually having a kind of a conflict, as Professor Anand Krishnan said, that let's expand the cake and do not fight on the crumbles. But the second issue was that it's not just the speciality where there is a division, that what is public health actually? Is it being professionally done by masters in public health or community medicine? The second elephant in the house or in the hall was what Madam shared, that there are a lot of models, which is good, which is bad, which has been working well. And I'm standing here because not as a representative of Indian Council of Medical Research, but as I run the School of Public Health for past 9 years in All India Institute of Medical Sciences, Jodhpur, as a head of School of Public Health. So I'll share that what exactly the group of frame thought that agar itne sare elephants in the room hai to karna kya hai. Now there is a need of accreditation of these masters in public health schools in the country. So now the question arises, if we actually accept this degree as a professional degree, then being a professional degree, we need to understand and make a consensus, an agreement that there is a specialized knowledge which is needed to be delivered to these students, number one. If it is a degree, if it is a professional degree, we need to acknowledge that a kind of an autonomy is needed to be delivered to these, because that means autonomy. If I am a community medicine fellow, and thanks to Arun when he said that yes, we can run a clinic, a standalone clinic, then these masters in public health students, when graduated from PGI Chandigarh or AIMS Jodhpur or AIIPH Kolkata or JIPMER or NI Chennai, they should be able to practice public health. So there should be an autonomy to that. Number three is that it should be governed by some kind of ethics. It's, you know, some kind of integrity to the profession is needing. And number last, which she says very rightly, that there should be a quality of the final project, the product which is needed. Now, how to ensure this quality of public health graduates in the country? I think when Professor Bobby was delivering her talk, she said that unfortunately there are mushrooming of masters in public health courses in the country. So now it's the onus on the institutions, more so ever on the government side, but at the same time the private medical schools as well as universities, to ensure the quality of these passing graduates or postgraduates. So the quality or standards will depend on these factors which are being listed over there, and I'm not going to read it because that applies to each and every one, not only to public health, MPH, but to even community medicine, that we need to understand the institutional strength, the faculty expertise, the kind of a course curriculum which is going to be implemented to all these courses, as very rightly mentioned by Professor Anand Krishnan in the very beginning, that it's a public health course. It needs more practical than the school or the kind of a classroom teaching, and a kind of an accreditation which is required to run these courses. So what are the pathways which are there? So when the group set in IISc Bangalore, and thanks to Prabdeep for hosting us there in a beautiful campus of Bangalore, then we thought that how to ensure this quality of MPH programs. And again, the agreement was built on these few bullet points, that there should be an entrance examination which should be of the order of at least of the country level or the state level, where there should be a kind of an entrance exam. As Professor Bobby said, it's a multidisciplinary course. Beside medical, we do have non-medical people, and they are coming from the diverse backgrounds of social sciences, economics, engineering. A kind of a course structure which we need to make a kind of a consensus on how much to be classroom, how much is the practicum, and that should be a kind of a uniformity. Thesis kaise hoga? If there are 20 postgraduates in NMC, in MD, in any program, we say one graduate or postgraduate, one guide. So if we have 50 MPH in a class, are we going to have 50 guides? How we are going to do that? Faculty numbers, quality, mix, exit kaise hoga fir iska? If in MD we ensure a kind of a uniformity, there are guidelines. So how are we going to accredit it? So that was a question. As we said, कि अगर इसका entry exam होना, if there is an entry exam, who is going to be the regulatory authority? Who is going to conduct these exams? Is it going to be at a level of CUET, university, or how this entry exam is going to be there? And is it going to be written or MCQ based? Or as it is a professional degree, there is a kind of after the entry exam, there are marks, and are we going to interview them When we initiated in 2017 in AIIMS Jodhpur, what we used to do is that, first of all, we have an entry exam, which is an MCQ based exam, and then we have an interview also, and based on that the students were selected. But later on, it was actually because of some political issues, it was then we need to have only entry exam through MCQ. Thanks again to NI Chennai, Tarun Bhatnagar, my close colleague. He shared this, that how to use a kind of some of the quality indicators. This is an FETP program. We all know who run this MD community medicine in all medical schools. That in NI Chennai, they have this FETP field epidemiology training programs where they have made some input indicators, some process, output, and outcome indicators. Can we develop a same kind of logic model for the curriculum which we are going to build for these MPH graduates or for these MPH courses? So the consensus was made that based on or with a similar example of this FETP, can we prepare a comprehensive set of indicators and put in place to have a measurement of internal validity and external validity. Now the question arises how to ensure quality of public health training. As I said that we need, as I said, that first of all there is no disagreement on the issue that MPH needs to be there in the country, culturally specific, context specific. But again, there was one thing which every one of us were of the value, that it should be having some accreditation and a continuous professional development of those who ensure a kind of a quality training. Now, the central coordinating body, that was an important part, that there should be the central coordinating body which should ensure that there is a uniformity. But the question lies that who is going to do it? Like for example, in the United States, as it is written, there is a Council on Education for Public Health. We call it as CEPH. So, but the question lies, who will do it? Is it UGC, NMC or NEP? So if it is NMC, believe me, it's not going to do it, because NMC only does it for MBBS schools. If they are not MBBS in the entry, they are not going to accredit it. So question is out. So NMC is not going to do it. Then who else? Is it University Grants Commission? No, they don't have. University Grants Commission don't have any experience of running a professional degrees. They only run degree for academic bodies, BA, BSc, BCom, MCom, MSc. And also that these UGCs, they actually don't have this structure of saying that there is a 2 years degree program. So this was also a big no. Then the consensus was on this, and that was on a National Public Health Education and Practice Council. So frame the kind of members who were there. So we made a consensus or kind of an agreement that the possible way forward or the future forward lies in a kind of having this council which is looking more viable and which is having a kind of a more participatory approach, because it can accreditate a kind of a medical as well as non-medical body. And the mandate will be standardization of curriculum and competencies, accreditation of programs, regulation of admissions, implementation of standardized exit exams, and creation of professional registers. Thank you so much once again to the organizers for the opportunity. And the entire report is been given to all of us and all the partners who were initially shown in the second slide. And the entire report will be released in the month of February 2026. Thank you so much once again to the organizers. Thanks.
Thank you, Dr. Bhardwaj. This is an important topic. We are glad that it was introduced, and some young leaders would have had an opportunity to listen to it and understand parts of it. If there are any questions, we can take up a few questions, or even some comments or suggestions for the expert panel of speakers. Any questions from the audience? Okay, so since we do not have questions as of now, I hope in future when this issue comes up more often, then we will have questions and we will have to take a call on our own where we stand in this very important path ahead for public health in the country. Thank you to the esteemed panel, Dr. Krishnan, Dr. Bobby Paul, and Dr. Bhardwaj. Since we know very well that public health cadre has to be expanded. There is no two ways about it now. And what is important is the quality of the training which is being imparted. So that needs to be regulated, that needs to be enhanced. And we have to, as I remember during our childhood days, हम लोग Phantom comics में पढ़ते थे ना कि Phantom used to say कि it is better to talk rather than kill. So rather than fighting amongst ourselves, we need to get up together, our own act, and become one public health group. At least we should project ourselves in that manner. So I just hand over to my co-chair for his remarks, and then we'll hand over to the organizers.
Yes, sir, that's indeed a great presentation by all three speakers. As sir has rightly mentioned, the quality of the public health is the real issue, and probably what we are seeing today, what madam rightly mentioned, there are mushrooming of these institutions. That has to have a regulation, and probably this document which the team Frame India is going to have will get this into action, and probably we'll have a strong regulation for the public health cadre. And of course, public health cadre is the need for the need of the hour and need of the future, but without regulation, that may spoil the whole show. I think Frame India is going to give a solution for that. Thank you so much for this wonderful deliberations.
Thank you, dear speakers and chairpersons, for this wonderful session. I request our chairpersons to honor our panelists with a certificate. Dr. Anand Krishnan, although you could not be here with us physically today, thank you for gracing us online. Dr. Pankaj Bhardwaj, Director, ICMR, National Institute for Implementation Research on Non-Communicable Diseases. Dr. Bobby Paul, Professor and Head, Preventive and Social Medicine, All India Institute of Hygiene and Public Health, Kolkata. I request Dr. Jagdish Kakurkar to present the certificates to our chairpersons. Brigadier Dr. Kunal Chatterjee, Professor and Head of Department of Community Medicine, Armed Forces Medical College, Pune. Dr. Avinash Kavi, Associate Professor, JN Medical College, KLE Academy of Higher Education and Research, Belgavi, Karnataka. We now come to the last session of the first day of the 6th IAPSM Young Leaders National Conclave 2025 at Goa Medical College. And we end with the Dr. Sushila Nair Young IAPSM oration. The chairpersons for this oration are Dr. Manish Kumar Singh, Professor, Department of Community Medicine, Dr. Ram Manohar Lohia, Institute of Medical Sciences, Lucknow, and Dr. Jagdish Kakodkar, Head of Department, Community Medicine, and the Organizing Chairman of Young Leaders National Conclave 2025. I request Dr. Sweezelt to welcome our chairpersons with a flower. I now call on stage the Sushila Nair Young IAPSM orator, Dr. Mohammad Shoaib Qazi.
So good evening, everyone. Now we come to the very important session of the Young Leaders Conclave, that is the Young Leader Orator. And for this, we had many applications of which 3 applications were shortlisted, and we had a presentation before a jury, and the best presentation was found out to be of Dr. K. Mohammad Shoaib. He is an MBBS MD in Community Medicine and MSc Public Health. He's pursuing right now. Currently he's working as an assistant professor in Department of Community Medicine, Navodaya Medical College, Raichur in Karnataka. He was ranked as 10th in the RGUHS of MD Community Medicine. He has 3 international travel grants for India, Malaysia, and South Korea. He has a professional experience of 14 months as senior resident in Department of Community and Family Medicine, AIIMS Mangalgiri. And his areas of expertise are population health data analysis, large-scale survey epidemiology. He has around 18 publications with 3 in journals with impact factor of more than 3.5. Communications medicine impact factor 5.4 in 2024. So I welcome you, Dr. Shoaib, to go ahead with the oration.
Thank you for the introduction, sir. First of all, I would like to thank the jury members and the organizers for providing me this opportunity. So I'm here today to present my work titled From Clean Water to Care, that is mediating effect of women empowerment between WASH access and barriers to healthcare seeking among Indian women using National Family Health Survey data. Yes. So coming to the introduction, let us have a look at this map where it is, the map shows that the households with tap water. You can see that in 2019, there were many districts with only just 0 to 10% of households with tap water. Next, we can see that in 2025, it has increased significantly thanks to Jal Jeevan Mission. Yes. So when I talk about WASH, it includes water, sanitation, and hygiene. So do you think that the water is associated only with water wash diseases, water-based diseases? It extends beyond. So improved WASH access provides relief from time burden. That is, the people are no more burdened with the time that they spend for fetching the water. It provides safety, and it provides mobility also. And with WASH access, there is increased privacy for the women. And finally, it provides relief from psychological stress also. Now let us see how WASH access provides empowerment to the women. First is, it empowers the women through knowledge, leadership, economic opportunities, as they have a lot of time for themselves to engage with various occupations, and it provides overall well-being. We also have evidence that with improved WASH access, there is improved utilization of healthcare services, which is better WASH is better utilization of healthcare services by the women. So when WASH is associated with so much related to women, let us see how it affects them when there is low WASH access or there are WASH inequities. First of all, women are not able to fulfill their biological needs, that is the menstrual hygiene and other aspects related to the hygiene and sanitation. The water collection. In India, even today, the collection of water is more focused, or it's a gendered chore at the village and urban levels. Women are exposed to gender-based violence also. We have multiple reports where women are were assaulted when they were going to fetch water, when they were traveling through the isolated areas. Infections, yes, as we all know, due to lack of sanitation. It also impacts the education. Adolescent girls, we can see that there is a lot of absenteeism, especially during their days of menstruation. then it also contributes to economic burden, leading to the health inequities, and it promotes to psychological stress. And as we know nowadays, due to climate change, we have higher proportions of drought and floods, and women are also affected. And finally, they are deprived of human rights. This brings to the research question: to what extent does women empowerment mediate the association between household wash access and Coming to the methods. Now, as given in the title, the data sets from NFHS5 were used. Here we have used the recoded files. So the recoded data sets, the first one is individual record that contains the details of all the women who were interviewed during NFHS5, where it is 7,24,115 cases. By cases, I mean the observations in the data set. Next is the household record file, which contains the characteristics of the household which was selected during the survey. And even men were interviewed during NFHS5, but unfortunately, they were not in such high sample size. It was only above 1 lakh. And the NFHS5 survey was conducted during 2019 to 21. Let us have a look how the sampling methodology was used. So among the states, districts were selected, and they were divided into urban and rural areas. In the rural areas, the primary sampling unit were the villages, and in the urban area, it was census enumeration blocks from the census of 2011. So for the primary sampling unit, we had more than 30,000 primary sampling units. And under each primary sampling unit, 22 households were selected using systematic random sampling. So that was about NFHS. Now let us have a look for the tools that have been used. First is a wash index. This is an index we have constructed using 5 variables which are related to wash. First is availability of the water at the site of hand washing in their household. Next is the source of drinking water. Third is the type of drainage. Fourth is the use of clean fuel for cooking. And finally, the type of toilet facility. Coming to the next tool, we have Survey-Based Women Empowerment Index, in short known as SWPER index. This index have been validated on the global data for the DHS survey, and DHS survey in India is also known as NFHS survey. So this index has 3 domains. The first one is attitude to violence, that is justifies beating. So in this NFHS survey, women were asked if they justify beating of the wife by the husband for the following reasons. That is, if wife goes out without telling husband, so do they justify that husband should beat the wife? Similarly, if wife neglects the children, if wife argues with the husband, or if she refuses to have sexual intercourse with the husband, or if she burns the food. The responses were yes, no, don't know. Next, second domain is the social independence. That is the frequency of reading newspaper or magazine by the women, education in terms of completed years of schooling, age of women at first birth, age at first cohabitation, and age difference between woman and her husband, that is woman minus husband's age, and education difference between woman and her husband, that is woman's years of schooling minus husband's years of schooling. Third domain is about the decision making. Who decides on the healthcare of the respondent? Next is who decides on large household purchases such as appliances. Finally, who decides on visits to family and relatives? So here the responses were either the respondent or the woman, or was it a joint decision, or it is by husband only, or it is by someone else in the family. Next tool is the perceived barriers. So these women were also asked at the time of survey that in the preceding 2 weeks, if they fell ill, which of the following barriers prevented them from seeking health care? So we had 8 barriers. First is money, that they require money and it's a barrier for them to seek health care. Next is the transport, that they do not have transport to visit the healthcare facility. Next is the availability of an attender, that is they want a companion to visit the healthcare facility. Next is the no female healthcare provider availability. That is, they are concerned that there won't be any female healthcare providers. Or the next barrier is no healthcare provider at all. Another barrier was non-availability of drugs at the healthcare facility. Next barrier is they require permission to visit the healthcare facility. And the final one was the distance. That is the distance a barrier for them, which is preventing them from seeking healthcare. Here I would like to talk about the wealth index. Wealth index is an asset-based index which assesses the households based on the assets that they possess, such as vehicles, domestic animals, or type of fuel, etc. Now, since I'm evaluating here the factors related to WASH or the WASH variables, in the wealth index, even the variables related to a WASH are included, such as type of water supply, type of drainage, type of cooking fuel. They form the integral part of the wealth index, and it is created by using the method of principal component analysis. As you can see from the screen here, that the type of source of drinking water, they form the significant part of this index, and that was the need for, that gives the need for creating a wealth index without the inclusion of WASH related variables. Now coming to the final number of cases included in this analysis. So from the IR data set or individual record data set, we had 7,24,115 cases. We had to remove 4 lakh plus cases because they were either currently not married or they were not in union. By currently not married, I mean to include those who were divorced, separated, or widowed, etc. From that, again, we had to remove more than 2 lakh women because they were not asked about the domestic violence module. Finally, the missing data was there for 2,000 plus cases. So in the final analysis, we included only 74,735 cases. Coming to the statistical analysis, so here we did a 5-step analysis. First is create the wealth index without WASH variables. Next is we have created the WASH index using the 5 variables related to WASH using principal component analysis. Next, we created a perceived barrier index, and here after creating it, we standardized it to obtain the Z scores. Finally, the model, that is mediation analysis, was done using generalized structural equation modeling, that is also known as GSEM. Finally, model validation was done using sensitivity analysis. Now, there are some of the structural components for this model for which it needs to be adjusted. That is, one was religion, where we had recoded the religion variable as either they belong to Hindu religion or non-Hindu religion because of the proportions. Wealth index without WASH that we had created, the state they belong to, type of residency, that is urban or rural, and finally whether the survey was conducted before COVID-19 pandemic or after opening of the lockdowns. Coming to the results. Coming to the descriptives, in the women which were included in the final analysis, 81% belonged to Hindu religion, 69% of them was residing in the rural areas, and 67% of them answered the questions of NFHS survey before the arrival of COVID-19 pandemic. So in this set of women, 40.51% women never faced any of the 8 listed barriers. And Z score for the barrier index was ranging from minus 0.91 to 2.42. So among the included households, for 89% of the households, the water was present at the site of hand washing. Thanks to Jal Jeevan Mission, that 96% of the households were receiving water from a protected source of drinking water. 79% of the households had improved type of toilet facility, with only 37% of them having a protected type of drainage system. and 57% of the households use clean fuel for cooking. Coming to the descriptives of the Women Empowerment Index that we have used. So the attitude to the violence, we have categorized it into 3 categories, that is low empowerment, moderate empowerment, and high empowerment. By high empowerment, I mean that they are against justifying beating wife for the listed reasons. So it was found that 60.48% women were highly empowered in this domain. Coming to the social index, 42.74% of the women were moderately empowered. Coming to the decision making, here we can see that high empowerment was only found in 4.52% of the women. Now let us see the descriptives for the barriers faced. So here is the radar chart with all 8 barriers. So now we can see that most of the women, that is between 40 to 50%, face the barriers of non-availability of drugs, followed by non-availability of healthcare provider, and between 30 to 40% for no female healthcare provider, and rest of the barriers were between 30 to 20%, and the least was that they require permission to attend the healthcare facility. Coming to the final model that I was talking about, the mediation model. First was the WASH index and the 3 domains, that is violence domain, social independence domain, and the decision domain. And finally was the perceived barriers. So initially we assessed for mediation through these 3 domains, which was the indirect effect. And finally the dotted line shows the direct effect of WASH on perceived barriers. Okay, let us look at the coefficients for WASH that is impacting the barriers. So as we can see from this table that with very high WASH index category, the coefficient is minus 0.264, that shows, and it is graded from low to high, that shows that with increased WASH access, the women perceive barriers to a lower extent. Coming to the mediation analysis proper. Okay, so WASH to violence domain. That is, higher WASH access showed strong positive associations with 2 of the domains. First was violence domain, and here also you can see that from low WASH category to very high, we can see a graded increase in the coefficient, and for very high category it was 0.375, and it was tested using wall test, and it was also found to be significant. Now, as we have adjusted these domains for covariates, so wealth index, that is the newly formed wealth index, showed a strong gradient. Rural residency is associated with reduced empowerment. COVID-19 period is also associated with lower empowerment. Now, at the large state level, we found large set of variations where empowerment was high in the north and northeastern states, and it was empowerment was less in the southern states. WASH to the social domain, that is the social independence. Similarly, as compared to that of violence domain, here also we can see that it is significant, and higher empowerment is associated with improved WASH access. Coming to the decision making, where we have seen that the least proportion of women were highly empowered in the decision domain, that was found to be not significant with respect to WASH. Coming to the covariates, again the wealth gradient was found to be significant, and it was a very strong gradient that poorest women have nearly 1 full unit lower social empowerment with coefficient of minus 0.99. Rural women show lower social empowerment. Again, similar patterns of differences in the state were found. Again, COVID-19 period was also associated with lower empowerment. Decision domain, though, as I said, it was not significantly associated. So let us look at the covariates for decision domain. So again, wealth index as seen for other 2 domains, but in this case there was no rural or urban difference, and similar patterns was found in the states. And as expected with other domains, COVID-19 period was also associated with reduced empowerment. Now, the total effect. Coming to the model as a whole. So, WASH impacting the perceived barriers. So, WASH could, with improved WASH, it could bring 66% change in the perceived barriers in the Z-score. The direct effect contributed to 77.5%, and the indirect effect through these three domains of the women empowerment contributed to around 22.5% effect. Finally, let us have a look for how the covariates are influencing barrier index. So low empowerment was associated with higher barrier index, which was expected. Wealth has always been critical. Rural residency again increases the barriers. And here different pattern of state disparities was found. Key takeaways from this study. COVID period linked to higher barriers. Poverty, rural residence, and geographically sharp constraints women's empowerment. So these are the factors that prevent women from rejecting the justification for violence. Decision-making empowerment is driven mainly by wealth state, but here effect of WASH was not significant. And social empowerment reflects deep socioeconomic and geographic inequities. Coming to the strengths of this study, it has high internal validity because for the missing data, we have not used any of the imputation models, because with imputation, it brings in the assumptions which may not be true. And for such a huge population, the representative women were near to 7 lakh plus, and so with that shows that one woman can be really different from another. Then we have assessed the women empowerment as integrated multi-domain empowerment assessment, and we have included the survey design, and it has used survey-weighted frameworks. Coming to the limitations. So since this is a survey with cross-sectional design, it limits the causal inference. Less number of cases were considered for the analysis, as it is less than 10% number of cases. And there might be other confounding factors which may not have been included here due to the non-availability of the data. And the multi-dimensionality is limited because there are many theories with respect to the person's behavior, how they behave with respect to seeking healthcare behavior, such as like how they are going to delay the seeking of healthcare behavior, or with respect to WASH. For example, like a person who is fetching water from long distance, if you provide them the water supply, apparently the value of the water in their eyes decreases. So then comes in the water segregation, that they start segregating that this set of water or this bucket of water is for washing, that is for cleaning, and etc. So this is one type of behavioral theory associated with WASH. So such details could not be included. Coming to the future vision with respect to this study, I would like to expand this research to national framework so that the other details of the multidimensionality can be included with primary studies or primary projects. There's this model on the global and regional scales because the NFHS survey, also known as DHS survey, is conducted in multiple countries in various WHO regions. Finally, as a community medicine faculty, I aspire to train the future physicians or future community medicine persons to adopt a preventive and gender sensitive systems thinking care, because right now, whatever the research we are currently doing, it is restricted to only few systems. Coming to the declaration and references, so some of the images, that is those with, the maps were from the Jal Jeevan Mission dashboard, and the other images were generated through AI. And these are the references. Thank you for listening.
Thank you, Dr. Shoaib, for the excellent presentation. And This presentation was shortlisted out of the many presentations which were there by esteemed jury, which included Professor Dr. Atul Kotwal sir, Dr. Bhupen Tripathi, who is from the Bill and Melinda Gates Foundation. Dr. Jagdish was also one of the jury members, Dr. Ribu Basu, and one more member was there from the governing council. So, and he was chosen as the best. Now, any questions from the audience? If you want to ask something?
I request the audience to give a big hand to our Dean, Professor Dr. J.P. Tiwari, who has come here on time. Thank you, sir, for making time to be at our occasion. So I think Dr. Nadia can proceed. Very well presented.
Thank you, sir. Thank you, Dr. Shoaib. I now request our chairpersons to honor our orator. I request Dean, Goa Medical College, Professor Dr. J.P. Tiwari, to kindly take the dais to hand over the citation to the Dr. Sushila Nair, Young IAPSM orator, Dr. Mohammad Shoaib Qazi. I also request Dean Goa Medical College to present the certificates to our chairpersons of the oration. Dr. Manish Kumar Singh, Professor, Department of Community Medicine, Dr. Ram Manohar Lohia, Institute of Medical Sciences, Lucknow, and Dr. Jagdish Kakodkar, Professor and Head, Department of Community Medicine, Goa Medical College. And with that, we conclude a wonderful day of deliberations at the 6th IAPSM Young Leaders National Conclave, Digitalization, Data and Decisions, Youth at the Forefront of Health Tech. I request everyone to kindly take the seats in the front rows. We will begin the inaugural of the 6th IAPSM YLNC shortly. I request everyone to occupy the middle row so that we can get a nice picture later on. While we wait for the scientific sessions to end, we will watch the advertisements of the advocacy competition that we had online for our delegates. The theme was Health Tech for All.
Some days, health begins with a simple step, like wearing a smartwatch that keeps an eye on my heart, my pulse, and even my stress. When things feel heavy, one tap reminds me to breathe. Tech nudges me to pause, hydrate, and take care of myself. At lunch, I choose better because my apps show me what my body really needs. Small decisions, big change. In the evening, I move, track my steps, feel proud of every little milestone. And at night, I trust my sleep tracker to guide me toward better rest. But some mornings, stress returns. And that's when I remember, I don't have to handle everything alone. Telemanis connects me to mental health support within minutes. No judgment, no waiting, just someone to talk to, and real help when I need it.
This is health made simple. This is support made accessible. This is health tech for all.
अरे वो राजू का एक्सरे ढूंढा था इधर रखा है ओह गॉड अब कैसे ढूंढूं उसका एक्सरे में
अरे इतना परेशान क्यों हो रहे हो? राजू का एक्सरे चाहिए ना, मैं अभी दिखाती हूँ, 1 मिनट। ये देखो मिल गया। प्रॉब्लम सॉल्व।
यार ये आरसीएच के इतने सारे रजिस्टर में एंट्री करनी पड़ती है, बस एक तो मोटे मोटे पेपर खुद फंस गई।
क्या परेशान हो रही है? तुझे तो सिर्फ ये रजिस्टर भरना है, मुझे तो इतने सारे रजिस्टर भरने के बाद ये ऑनलाइन भी भरना पड़ता है, और ये तो इंटरनेट भी नहीं चलता है। कितना प्रॉब्लम होता है, घर पे जाके भी यही काम करना पड़ता है। मेरे तो पेट क्यों दर्द कर रहा है? गूगल से पूछती हूँ। हाँ, कैंसर, फूड पॉइजनिंग, मुझे कैंसर तो नहीं हो गया ना?
अरे इतना क्या टेंशन ले रही है, वो फोन रख बाजू में, ये ले, सिर्फ एंटासिड की जरूरत है तुझे, नॉर्मल एसिडिटी तो है।
Please give a big round of applause for all those ads and all the participants who made those. You can never cross the ocean until you are ready to lose sight of the shore. Christopher Columbus. A very good evening to everyone present here today. On behalf of the Department of Community Medicine, I, Dr. Nadia Clare, would like to extend a warm welcome to all who have gathered here for the 6th IAPSM Young Leaders National Conclave at Goa Medical College and Hospitals. Having over 8,000 members from across India serving in medical colleges, national and state governments, various health institutes working in the field of research, training, epidemiology and surveillance, the Indian Institute of Preventive and Social Medicine is dedicated to the promotion of public health by bringing its members' expertise to the development of health policies, and advocate for medical education, health research, healthcare, and health programs, and providing a forum for the regular exchange of views and information. Standing tall atop the Bamboli village, first started in 1842 as Escola Medica and subsequently renamed to Goa Medical College, we are proud to be one amongst the oldest medical colleges in Asia. We here at the Department of Community Medicine are elated to have given this privilege of organizing the 6th IAPSM Young Leaders National Conclave 2025. The theme for this conclave is digitalization, data, and decisions, focusing on the youth who are at the forefront of health tech. We stand at a moment where healthcare is being reshaped not by gradual change, but by rapid digital transformation. Digitalization today is no longer a technological upgrade. It is the new language of public health. From electronic health records to AI-driven surveillance, digital tools are redefining how we diagnose, monitor, and respond to health challenges. We sincerely thank you, dear delegates, for attending the 6th IAPSM YLNC 2025 here in Goa, even though the flights did everything in their power to make sure you didn't. Clearly, your dedication is stronger than their schedules. For those who could not make it here, we understand the circumstances that prevented their travel, and we appreciate their commitment nonetheless. I now request Dr. Jagdish Kakodkar, Professor and Head Department of Community Medicine, and the Organizing Chairman, YLNC 2025 Goa, to escort the Dean, GMC, Professor Dr. J.P. Tiwari, onto the dais. I request Dr. Hemangini Shah, Organizing Secretary, YLNC 2025, to escort Dr. Manish Kumar Singh, Honorable Secretary General, IAPSM, onto the dais. In the darkness of digital health, it is the youth who lead with light. And what better way to ignite it than by lighting the traditional lamp? I request our dignitaries to kindly light the traditional lamp. May this light remind us that every great journey begins with a single spark of purpose. A captain is someone who tells you what you don't want to hear, who has you see what you don't want to see, so you can be who you have always known you could be. And this team would not have been what it is today without the constant support of its captain. I now call upon Dr. Jagdish Kakodkar, Professor and Head, Department of Community Medicine, and the Organizing Chairman, Young Leaders National Conclave 2025 Goa, to welcome the gathering.
Good evening to all of you. On behalf of the Department of Community Medicine, on behalf of Goa Medical College, as Organizing Chairman, on behalf of our entire organizing team, led primarily by the young brigade of senior residents, junior residents, and you can see even student volunteers, I have this privilege of welcoming each one of you for today's inaugural ceremony. At the outset, my deepest gratitude and thanks to Professor Dr. J.P. Tiwari sir, who has been a pillar of strength for us. He has given us access and availability of this wonderful infrastructure, of this auditorium, of all the lecture halls where the oral paper sessions are going on, the poster sessions in the exam hall, as well as all the setups by the various HODs in the super specialty block yesterday, where we had the pre-conference workshops. So very warm welcome, and I request all of you to give a rousing round of applause to welcome Professor Tiwari sir. This conclave has been organized usually at the All India Institute of Medical Sciences. It is a rare occasion where the IAPSM conclave, that too a youth leaders national conclave, has come to Goa Medical College. And I cannot forget, for that I must thank my good friend and who is now the Honorary Secretary General, Professor from Ram Manohar Lohia Hospital, Lucknow, Dr. Manish Kumar Singh. Thank you, sir. Professor Bharadwaj, sir, a warm welcome to you from all of us. Thank you for giving us this wonderful opportunity. No organization can be possible of a conference or a conclave of such a nature without the active support of the entire organizing team. So besides welcoming our Dean, besides welcoming the Secretary General Dr. Manish Singh on behalf of the office bearers of IAPSM, we are missing Professor Bharadwaj sir, whose flight got cancelled, otherwise he would have been here with us. And also the entire IAPSM team, all the illustrious faculty members. I can see here Brigadier Kunal Chatterjee sir from Pune. A warm welcome to sir, please give applause. I can see Madam Patrikar also from AFMC. Professor Pankaj Bharadwaj sir, thank you for coming all the way from AIIMS Jodhpur. Give a big hand to sir as well. We have Professor Kshir Sagar, who is representing West Zone in the Governing Council. Thank you sir for coming from Maharashtra. I have a young person sir, Dr. Arun, who has come from Kerala. He set a shining example as a community medicine person to set up a chain of clinics and polyclinics and pharmacies and all. He has been a speaker today. So like him, Dr. Maltesh, Dr. Shoaib, Dr. Minakshi, our own faculty from the department, our own colleagues from across various colleges. I welcome you all, and I must tell you that this would not be possible to organize all this had it not been for these young people out here. So a big hand to all of them, a warm welcome to them. They have been the people who are working behind the scenes. You know, when we were in school days, Pankaj sir and all my counterparts would remember, there was one Nadia Komenichi who had scored the first perfect 10 in Olympics. We have our own Nadia here. Where is she? Nothing short of that. You can listen to her as she conducts the comparing. We are privileged to have her. She has conducted the Eficon comparing in a masterly manner, and so she is doing today. So Nadia and all our senior residents with her who are there, Vishakha, Rajat, Vishal, Malvika, all over here, and the junior residents, I welcome all of you and thank you for coming here today.
Thank you, sir, for those warm words of welcome. It is a pleasure to have amongst us today our esteemed dignitaries who have been instrumental in making this day possible. I request our postgraduates to welcome our dignitaries with a bouquet of flowers. Dean Goa Medical College, Professor Dr. J.P. Tiwari. Dr. Manish Kumar Singh, Honorable Secretary General, Indian Association of Preventive and Social Medicine. Dr. Jagdish Kakodkar, Organizing Chairman, Young Leaders National Conclave 2025. Dr. Hemangini Kesha, Organizing Secretary, YLNC 2025. Thank you, dear Aparna, Sweezel, and Rukmita. We express our profound gratitude to the Secretary General of IAPSM. His confidence in our institution, his steady leadership, and his constant encouragement have been instrumental in bringing this gathering to life. I now call upon Dr. Manish Kumar Singh to address the gathering.
Thank you so much, Nadia. Good evening, respected dignitaries on the dais. Professor Dr. J.P. Tiwari, sir, Dean of this Goa Medical College. Organizing Chairperson, Dr. Jagdish Kakodkar, sir, and Organizing Secretary, Dr. Hemangini Shah, Madam, and the dignitaries of the dais, my elder brother, Professor Bhardwaj sir, Pankaj Bhardwaj sir, and I can see many other senior faculty members, Dr. from AFMC, Professor sir is also here. So I welcome you all to this today's inaugural function of Young Leaders Conclave. Yes, we were very confident with Goa putting up its interests to host this, and we're very sure that it would be a grand success. And as I came to know, there are around 300 registrations. But that's the beauty of Goa, that we are having it in the evening and most of the people are enjoying Goa. So no issues. But yes, that's a good number, 300, and around 140 posters and paper presentations. Okay, so that's a huge number. So the participation has been there, and that's really encouraging. And this is a new platform like Young Leaders Conclave, where the youngsters come forward and do a presentation, and it provides a unique platform where we have seniors also who can guide them, and together we can develop a roadmap like what we need to do in the next 5 years or next 10 years to upgrade our community medicine graduates and make them more skillful. IAPSM has been doing its part this year as well, and there are a few announcements that I wanted to make. This year, IAPSM did recently an ICMR joint initiative that was on One Health, and we did it in more than 300 colleges all across India. And there was a huge participation by all our postgraduate students, as well as students from other universities, other streams also. So we conducted rallies, we conducted this quiz competitions, CMEs, and also extempore competitions, and many of our PGs and all participated very enthusiastically in it. For this, we are thankful to Dr. Pankaj Bhardwaj sir. It was, he connected us with the right person in ICMR, and we got this MOU done. This is the first time that IAPSM has a joint initiative with ICMR. And we are also giving 10 research grants to postgraduate students and senior residents. So today I got to know that there are 80 research proposals that we have received for the research grant, and we'll be shortlisting 10 best out of it, and they will be provided with 25,000 cash grant money to complete that project. Apart from this, we did a lot of other initiatives as well through IAPSM. There was a health, like Maharashtra State Assessment of Health Services, which was done for the first time, and IAPSM was one of the key members of it. So all districts of Maharashtra, we did a health services assessment, and IAPSM, NHSRC, and Government of Maharashtra were the partners in that. Apart from this, Young Leaders Conclave had to be announced last year, but it couldn't be done by the previous body, so we took this up, and this is being organized so successfully here. For we have few more announcements that we want to do is, like we are announcing one award, that is Upcoming Talent Award, that is for our postgraduate students and senior residents. If you have done anything commendable in the field, any copyrights, any patents, you can apply for that award, and that award will be given. There will be there are awards from each zone, so the exact numbers we'll be sharing shortly, and you can win that award in the national conference. There are 4 awards this year, 10,000 cash prize each, that are for innovation and entrepreneurship. So that is open to all members, and that award will also be given in the national conference. We have a PG refresher course coming up, and the dates will be announced very shortly. They are in the month of January and February. So 2 workshops in each zone, and these are 4-day workshops, 2 days for the first year postgraduates and 2 years for the second year and third year graduates. So we have a set of skills that these postgraduate students need. As a first year student, what all skills you require, and then when you pass on to become a second year or third year PG, what all skill sets you need. So there is a central team which has worked out on the PowerPoints, the agenda, the facilitator guide for it, and we'll be sharing it with the states, and we will be having these workshops, 2 workshops in each zone. I had a discussion with Dr. Hemangani and Dr. Jagdish. We can have one in Goa as well. so that it can cater to the western part of Maharashtra, Goa, and some part of Karnataka as well. This time we are starting with the Lifetime Achievement Award also. IAPSM is 52 years old, but there was no Lifetime Achievement Award. So this time we are starting with 2 Lifetime Achievement Award in each zone. And this will be, all the expenses for the Lifetime Achievement Award will be borne by IAPSM. So we'll be selecting, getting the nominations through the state chapters, and then the governing council will be deciding on who all the 16 members of IAPSM will be bestowed with this Lifetime Achievement Award. These are some things which we are doing. We are open to suggestions from all members, from the young PGs. If you have any suggestions, we are most welcome. We'll try our best, whatever we can do in our capacity to fulfill them. And apart from this, we organized one Nutri Challenge competition, which was very much appreciated. We had a World Breastfeeding Week this year, which we got many good entries. Then the membership also we have increased a lot. This year we have 680 members till date this year, and we are very close to reaching 10,000 members as a professional body, IAPSM. So we need all your support. Whoever is not a member in this hall, please register yourself and become a member. We are also, this time the World Health Day quiz is going to happen in the month of March. It has been in practice since 2017, but this year the IAPSM has decided to provide some fund to all participating colleges. So we'll provide some fund from our end, so that you can cover some of the expenses, although it's not a big amount, but still that something is better than nothing. And then we'll have the World TB Day. There are many prizes to be won by the postgraduate students. A lot of competitions are coming up for the World TB Day. We have started with a new series called Legends Ki Kahani, Unhi Ki Zubani, and we had Professor Jile Singh, who had the first episode, and very soon, maybe in a day or two, we'll be having the next episode of Legends Ki Kahani. The idea is to inspire you from the stories of our legends who have worked so hard for this discipline. We have introduced, also announced one book, IAPSM textbook on digital health and AI, and we have got the chapter's first draft, and the editorial team is working on it. Very soon we're going to release it in the national conference. We have also working on 3 online courses. One is on AI and data analytics, one is on preventive oncology, and one is on diabetes and hypertension. So that is our, we want our postgraduates to be sound in clinical skills also. At the same time, we are experts in research methodology, statistics, but then clinical side also needs to be strengthened at the same time. So these are some of the initiatives that we have been trying to do. And I would encourage all of you present here to please enroll as many of your postgraduates to become members of IAPSM and take advantage of all the announcements that we are making. And also we are open to all suggestions. So thank you so much, Dr. Jagdish sir, for organizing such a wonderful event, and which has so good participation I could see. Thank you.
Thank you, Dr. Manish, for your words of encouragement and for all the initiatives under the IAPSM. Every gathering leaves behind a trail of memories, impressions, and inspirations that deserve to be preserved. In these pages lie the echoes of our journey, the spirit of our collective toil, and the dreams that shaped this conclave. We now unveil the souvenir of the 6th IAPSM Young Leaders National Conclave 2025, a tribute to every mind and moment that made this gathering possible. Most definitely, we all want to live forever young at the Young Leaders National Conclave 2025. As a mark of our sincere respect for the dignitaries whose presence and contributions have enriched this occasion, I request Dr. Jagdish Kakodkar to present a token of our appreciation to Dean Goa Medical College, Professor Dr. J.P. Tiwari. I request Dr. Hemangini Shah to present a token of our appreciation to Dr. Manish Kumar Singh, Honorable Secretary General, IAPSM. It is said that anything is possible when you have the right people to support you. Dean Sir, with his unwavering assistance and encouragement, has stood behind every milestone we reached and every step we dared to take. I now call upon Dean Goa Medical College, Dr. J.P. Tiwari, to address the gathering.
Good evening, everyone. Dignitaries on dais, Honorary General Secretary of this society, Dr. Manish Singh, Professor PSM from Ram Manohar Lohia Institute of Medical Sciences, Lucknow, Dr. Jagdish Kakodkar, Professor and Head Department of PSM, organizing chairman of this conference, Dr. Hemangini Shah, organizing secretary of this conference, dignitaries from different prestigious institute. Already Jagdish has mentioned their name, faculties, delegates, friends. It's my pleasure and to be here among such a learned faculties who gathered here to share their knowledge, and their delegates and students will learn and apply for their day-to-day practice. I thanked the organizing committee to give this opportunity to be here in this evening. You know about Goa Medical College already. Our comparer has told that this is the oldest medical college of the Asia. But unique about the Goa is here all the facilities, whatever the treatment for any, the cardiology, stenting, CABG, transplant, IVF, everything provided to the patient free of cost. And that is the government of Goa taken care of each and every one. And if patients comes to the casualty, our casualty, everything is free. All the super specialty, DM, MCS courses, MD 144 seats we have for the broad specialty, 16 super specialty, and 200 MBBS seats. But organizing such type of conference is a prestige for the institute, because everyone is coming far away. But the problem is whatever Dr. Jagdish was telling about the flight disruption, and so many faculty has not reached, and some faculty has suffers for the problem waiting at the airport and other places. I was going through your brochure and time, whatever the program. I'm a nephrologist. Whatever the digitalization, data and decision, we are dependent on that. We are dealing with the nephrological problem, dialysis, transplant. We are running the DM program also, but we are totally dependent on the data. What we have noticed that our patients, if you see the registry of chronic kidney disease in India is huge, but we don't have proper data of these patients, how many. If you see the incidence and prevalence is rising over and the current incidence is very high, around 17% in the world, not only in India. And patients used to come to the hospital when even they are not knowing they are suffering from the chronic kidney disease. That is the scene in India. This also seen in the US also, the survey done in the US. Why young patients used to die with the myocardial infarction? And they were not aware that 30 years. And they did the study, and they found the underlying disease is the chronic kidney disease. There's no symptoms of any uremia, but they're losing the protein in the urine, and there's damage to the blood vessel, and that affects the coronary artery, and they use the coronary artery disease. So what is the problem? You know that once patient develop hypertension, diabetes mellitus, ischemic heart disease, they will come to the Goa Medical College or any other medical college and the hospital, and doctors are there, they will treat. But if you see this, our population is staying in the village and other places, and they are not able to reach. Here everything is available. It's not seen everywhere in our country. That is the biggest problem. The only thing that what we have learned, that prevention is the solution of these diseases. Because they are coming, if you see the cardio-metabolic syndrome, and patients come to the hospital, once they cross the cardio-metabolic syndrome, stage 3 beyond, and they comes, only you can treat. If you coronary artery disease, you can put the stent. If renal replacement therapy, you can do the dialysis and transplant. And other diseases also you do the treatment. But this is the tip of the iceberg. We are not able to treat all the whatever the people in the periphery, and they are suffering. So prevention is the major thing. You have to take care what preventive medicine. I used to go back to the 1980s, and I am trained in the Institute of Medical Sciences at Banaras Hindu University. And we used to be posted in the periphery, in the village, those days, 80s. And our teacher was I.C. Tiwari. He was connected with the ICMR, he usually see the Dr. B.M. Gupta. And we used to go every day in the evening to the village, home, to every home to home. And we used to see what is the calorie, how much cereals, and used to distribute the jaggery cereals those days. And to many used to take the antenatal care so that we can prevent the intrauterine growth and preterm labor. I have seen your program, there was a preterm labor and preterm birth and mortality in your program also. It's mentioned is that. And that is the main thing, that those days, but still we are not able to prevent that. And that the Baker's hypothesis, if intrauterine growth is retarded and baby weight is low, and that reflects in the elderly, in the adolescents, and they will develop the obesity, hypertension, insulin resistance, and diabetes mellitus, ischemic heart disease, chronic kidney disease, and everything. And that is the problem, that we have to prevent that intrauterine growth retardation. Once patient develop diabetes mellitus, hypertension, obesity, and female become pregnancy, and there will be again intrauterine growth retardation. This is the vicious cycle. This is the vicious cycle. If you prevent there, and that you can play a major role to prevent the disease, and these tip of the iceberg, what we are treating should be controlled. So I request you to work in that with digitalization, data, and decision. In that sense, what you people are doing. And this conference will help each and everyone to reach the height, the knowledge, research, and share their knowledge amongst them. I welcome each and every one of you in the Goa. If any arrangement is done by Dr. Jagdish, his expectation gathering was huge, but due to this flight, whatever disruption is less. So he will take care of you more sincerely, and he will put attention on each and every one individually. So we are welcoming you, each and everyone, on this Goa Medical College in Goa, and thank you very much.
Thank you, sir, for your kind words of appreciation and wisdom. Every team needs someone who holds it together, weaving patience with dedication, turning challenges into triumphs, ensuring that every effort shines in harmony and shared success. And for this team is thankful to its organizing secretary, Dr. Hemangini Shah, who I now call upon to deliver the vote of thanks.
Respected Dean, Professor Dr. J.P. Tiwari, Honorable President of IAPSM, Dr. Ashok Bhardwaj, who I presume is with us online, esteemed Secretary General of IAPSM, Dr. Manish Singh, the YLNC Organizing Chairman, Dr. Jagdish Kakodkar, distinguished faculty members, young leaders, and dear colleagues. It is my profound honor to receive the relay baton of the Young Leaders National Conclave 2024 from AIIMS New Delhi as Organizing Secretary YLNC 2025. It is a proud privilege indeed to deliver the vote of thanks at this inaugural event on behalf of the organizing team. I have come with 2 pages, so please have patience because I have a lot of people to thank. First and foremost, I extend a heartfelt gratitude to our Honorable Health Minister, Shri Vishwajit Rane, in absentia today, who unfortunately couldn't make it. I must say, Sir has been a pioneer of many firsts in the health sector for the state of Goa, as the Dean Sir has already mentioned, and who not only works for the state of Goa, but also contributes to the country at large. His efforts for strengthening the public health landscape are so in sync with the Viksit Bharat dream of our Honorable Prime Minister, Shri Narendra Modi ji. We are indebted to him for his invaluable support as always. In fact, when we told him about the YLNC 2025, we received his official message, was the first one that we received, and we could incorporate it in our brochure itself. So Sir was so very, supportive of us that he took the initiative and sent it to us immediately. I express our sincere thanks to our Dean, Professor Dr. J.P. Tiwari, whose constant encouragement, academic guidance, and institutional support have been instrumental in bringing this conclave to life. Sir, your leadership and unwavering backing has been a pillar of strength to us. Thank you for the same. My profound appreciation goes to the President of the IAPSM, Dr. Ashok Bhardwaj ji. Your presence online reaffirms your commitment to nurturing young minds in public health. I warmly thank the Secretary General of IAPSM, Dr. Manish Singh ji, for his active support, meticulous coordination, and guidance in aligning this event with the broader vision of the Association of strengthening the professional community. He has shouldered the entire responsibility of representing IAPSM on behalf of Dr. Ashok Bhardwaj sir, the President IAPSM, and Dr. Atul Kotwal sir, President-elect. I also thank the IAPSM GC members, Dr. Pankaj Bhardwaj, Dr. Vikas Shirsagar, Dr. Maltesh, who are with us here today, and also those who have joined us online. We are grateful to all invited speakers, resource persons, and panelists offline as well as online, who will be leading the academic and scientific deliberations over these 2 days. They have enriched today's session, and with their expertise and wisdom, I'm sure you all have gained a lot. Your willingness to share time and knowledge will greatly enrich the learning of our young leaders. Dear resource person, thank you for the same. My heartfelt thanks to the organizing chairman, Dr. Jagdish Kakodkar, for his meticulous planning along with the constant supervision, and the entire organizing committee of faculty colleagues, residents, and student volunteers for their timeless efforts and dedication that has ensured the seamless execution of this inaugural ceremony. A special word of appreciation goes to all the young leaders from across the country, some who have been disappointed by not being able to make it to us in person today, but I'm sure they are with us online. Their enthusiasm, curiosity, and passion for public health are the true driving forces behind this event. This conclave has been designed for them, and it is their enthusiastic participation that gives it meaning. As Swami Vivekananda said, arise, awake, and stop, not until the goal is reached. You are not just participants, you are the future. With these words, we look forward to productive deliberations, meaningful interactions, and an inspiring conclave that helps us move closer to the finishing line of Viksit Bharat. Jai Hind, Jai Goa. Thank you.
Thank you, ma'am, for your wonderful words of gratitude. We end with the words of Theodore Roosevelt. Believe you can, and you're halfway there. Thank you all for an incredible first day of the conclave. Your enthusiasm has set the momentum, and we look forward to another wonderful day tomorrow. Buses for the networking dinner are stationed at the lecture hall complex and will leave at 6:45 and will come back via Panjim bus stand back to Goa Medical College. The venue for the networking dinner is International Center, Goa. Everybody is invited to have tea, coffee after taking a group photo. Thank you. Good night. Can everybody come down for a group photo, please?
Respected faculty, Pankaj sir, governing council members, eminent speakers, Kunal sir, Vikas sir, please come on stage. The rest of you, all our faculty also are requested to come on stage. Madam Meenakshi, please come. Dr. Ame, Kulkarni sir, please come. Please be here. Can we take a group photo, please, with all of you? Senior residents, quickly with the JRs, please come in the lower row. Student volunteers, come quickly. Before you proceed, don't forget to join us for a cup of tea or coffee.